All right, good morning, everybody, and welcome to the Comprehensive Spine Course 2022. We have a excited program in store for you with clear objectives for any healthcare provider who takes care of people who have spine pathology. So my name is Kola Jegede. I'm one of the orthopedic spine surgeons and the chair for this course. I'd like to introduce Dr. Jonathan Stieber, who is a co-chair, and also Dr. Peter Pashis is our other co-chair who will be here moderating in the afternoon. So we'll go over some housekeeping things and then we'll get it started with our first talk. All right. So you can download our course app for all of the important information you'll need to know, ask questions virtually, and you can download slides as well. So we are offering the following credits, which will be available when the course adjourns. Credit instructions can be found within the app, and they will be emailed to you afterward as well if you've registered. So, educational objectives of this course. After participating in this activity, clinicians should be able to develop a systematic method for physical examination of their patients with reported spinal disorders. Moving fast here. So, also identifying specific mediators of back and neck pain and comparing non-operative methods, knowing when to send a patient to therapy versus to a specialist, and establish screening strategies. This thing's moving quickly. For combined screening strategies to use for single combined objective electrophysiologic and imaging tools to correctly identify spine degenerative diseases. Okay, so after participating in the event, this course, you should also be able to recognize when it's best to treat patients non-operatively versus operatively, when it's a spine pathology involved, develop post-operative management plans, and also analyze evidence on the management approaches based on modern pain theory. All right, I'm gonna get started by introducing our first moderator, Dr. Jonathan Stieber. Yeah, that's okay. All right, guys, so I'm gonna kick us off. The title of my talk is Buttock Pain. Is it the lumbar spine or the hip? I've introduced myself, so we'll get started here. So today I'll be discussing differentiating hip and spine pathology through clinical exam imaging and interpretation of diagnostic and therapeutic intervention. So hip and spine pathologies commonly occur at the same time. Common complaints of low back pain, buttock, groin, thigh, and knee pain are seen with patients presenting with both hip pain and lower back pain. And treatment of these hip and spine pathologies have unintended consequences on each other. So this was first described by Orefsky and McNabb in 1983. And so they classified this having pathologies of the hip and the lumbar spine at the same time as so-called hip spine syndrome. And they broke it up into these categories, which include simple, complex, secondary, and misdiagnoses. So pathology involving either the hip or the spine often localizes to the buttock, thigh, or lower extremity, which makes it difficult from a diagnostic purpose. This can create notable challenges for the diagnostician when attempting to distinguish between the two. Clinical interpretation can become further muddled in individuals presenting with pathological changes, both involving the hip and the spine, as we discussed. So when we talk about simple, this essentially means having coexisting pathologies, both in the hip and the lumbar spine, but the primary source of the patient's symptoms is clear. So a patient comes in with horrible lower back degenerative disc disease and end-stage hip arthritis, but we know that it's the hip arthritis that's causing the issues. Then there is complex. So there's pathology seen both in the hip and the lumbar spine, but there's no clear source despite detailed physical examination and a thorough history. And it requires further diagnostic testing. And then there's secondary conditions. So both conditions are independent of each other, interdependent of each other. So symptoms of one region are secondary to the pathology of another. So we can see that in situations when patients have hip flexion contractures, which causes them to have hyperlordosis of their lumbar spine, overloading the facet joints, which can lead to advanced or early facet arthropathy. We also see in scoliosis when there's pelvic tilt. That can cause issues with the one of the hips as well. The last category we discussed is misdiagnosed, right? So the primary source of the pain is incorrectly diagnosed, leading to inappropriate treatment. So there's been growing interest in hip spine syndrome since its initial description. And so the close anatomic description or proximity of the hip and the spine and the overlapping soft tissues influences have been proposed as a factor in developing concurrent hip and spine pathology. So logically, if you have issues in one area, that can be extended to the other. For example, as we discussed, a hip flexion contraction in the patient can cause hyperlordosis and then scoliosis as well. So a thorough physical examination of the hip and the spine should be undertaken in an effort to elucidate further where the pain generator is. In the context of hip spine syndrome, wherein patients are likely to demonstrate pain across multiple anatomic locations, the significance or the concordant, go forward here. All right, there we go. Sorry. So there's going to be pain across multiple sites. So concordant symptom reproduction refers to the recreation of the exact symptoms that the patient has, okay? And so this is of extreme paramount importance when patients are coming in with hip spine syndrome. So I think it's the easiest way to explain this is when patient presenting with joint pathology. These patients are going to have issues with internal and external rotation of their leg or pain with log rolls. And so even if they have unusual pain, meaning pain that radiates to the thigh for their hip OA, you'll be able to reproduce that in the office on physical exam. Other things that we can see are people who have issues with their SI joints doing the Faber test or the Fader test, so flexion, adduction, internal rotation, or flexion, abduction, and external rotation can reproduce their symptoms, helping us to get closer to a diagnosis. There are other provocative exam maneuvers, as we see here, is straight leg raise, and these things will be discussed later on as well. Contralateral straight leg raise, which is more sensitive than a straight leg raise, and then the femoral nerve stretch test, which is giving us more upper lumbar radiculopathy. Okay, so other things that we can look at are on physical exam include spinal malalignment, pelvic obliquity. Are there any leg length discrepancies? How the patient walks, right? Do they have an intelligent gait, which is going to push us more to think that this is the joint pathology that's giving them the issue? Do they have a Trendelenburg gait, which we can commonly see in patients who have L5 radiculopathy and have weakness of their abductors? Do they have a high steppage gait when we see with patients with foot drops? And we can see that with L4 and L5 radiculopathy, patients getting foot drops. And then spastic gait can give us clues that there may be something else going on outside of hip and lumbar spine pathology. Palpation is important, so you can look for step-off in the settings of patients who have spondylolisthesis. Radiotrochanteric bursitis is a very common reason people come into the office and they have pain that can be in the back, the hip, or even down the side of the leg. So palpating them on the side, right over their greater troch, and having reproduction of that pain is important. In practice, I see a lot of patients who are side sleepers or women who have wide hips will have this problem as well. So it's, just touching them on the side of the leg can get you a diagnosis. They'll come in with normal MRIs, but have pain down the side of the leg that doesn't cross the knee, and that can be trochanteric bursitis. We talked about SI joint pains, doing the provocative maneuvers that can get us a diagnosis. And the SI joint, there are 9 tests, and you'll hear a little bit more about those later, but having at least 3 of those to be positive, and then having a injection that gives 80% relief can be a sign that the SI joint is a generator. And then you want to look at the joint range of motion on physical exam as well. So we talked a lot about we talked about a lot of these things as the straight leg raise, the contralateral straight leg raise, the femoral nerve stretch test, which is most useful for upper lumbar radiculopathy, but also can exacerbate psoas pain. When you're looking for hip impingement, particularly in patients who may have pathology that is not end-stage osteoarthritis, you can do tests such as the FABR, as we discussed, flexion, abduction, external rotation, or flexion, or the FADER, flexion, adduction, and internal rotation. Snapping iliopsoas test. And we talked about hip instability and SI joint issues. So the history is extremely important, right? These patients, by definition, are coming in with pathology that is involving both the hip and the lumbar spine. As our population grows, as our population ages, we see that we find advanced imaging findings in asymptomatic patients all the time. And so talking to the patients is what's going to get you the answers that you need. So distribution of the pain can give us clues. Is it groin pain? That's more likely hip pathology, and we'll talk a little bit about that in a few. Is it buttock and posterior thigh pain? So that can be related to lumbar radiculopathy, but it also can be a sign of hip OA. Patients can have radiating pain with hip OA as well. Lateral leg pain can be L5 radiculopathy. The C sign is a sign when patients present with that. That can be labral pathology. And then if the pain is extending below the knee, as we discussed, when we see, we can see the pain stopping above the knee, and trochanteric bursitis below the knee, we think more likely radiculopathy. And so a lot of studies looking at this, the distribution of hip OA pain. 84% of patients are presenting with groin pain. And we talked about the reproduction of these concordant symptoms. You can wiggle their leg in the room. I usually ask the patients how they put their shoes on. So there's usually a very distinct difference from side to side on how they put their shoe on that arthritic hip. And if you ask them, they'll give it to you right away. Buttock pain, 76% of them, you can see that in hip OA, and obviously SI joint pain is going to overlap there. Anterior thigh pain, we can see in radiculopathy, we can see in end-stage hip arthritis as well. So you see posterior thigh pain can be seen in 43% of patients who have hip OA. 69 anterior knee pain, shin and calf, as seen on the slide. So it's important to examine the patient and get pictures of the hip, even though they may have pain in the thighs, if that makes sense. So the history, we continue the ambulatory status of the patient. Are they walking, bending, stooped forward, which can be a sign of neurogenic claudication, can be a sign of lumbar radiculopathy as well. Shopping cart sign, as we discussed, so patients walking around with shopping carts when they're not going shopping, just because it helps them by flexing forward to relieve their symptoms. Talking to them about why they're stopping when they walk on the street, I think is important, and what they do to relieve themselves. So people, you'll ask them, hey, do you sit down? They say no, but they lean up against the wall and bend over on the gate. And so similar to leaning on a shopping cart. Startup pain, where and when do they have the pain? SI joint pain is usually pain that's initiated with transitions and movements. So when you're coming from a seated to standing position, they get moving, they usually feel okay. Transitioning from sitting to standing or standing to laying. So again, the history is very important. And so we'll go into diagnostic testing. So the first step is to get plain radiographs, right? So patient comes in, they have horrible hip OA, loss of range of motion in the hip. It helps you along, but it's not the end all and be all in terms of imaging, because we know that by definition, hip and spine syndrome, these patients are presenting with pathology in both places. Next step after the plain x-rays include MRI and CT scan. And then of note, I do get flexion extension x-rays of patients in the lumbar spine, and I make sure that the x-rays are standing. So the patients will have unstable spondylolisthesis. So they'll be reduced on MRI. There's no significant pathology, but they'll get a standing lumbar X-ray, and they'll have anterior listhesis or aspondylolisthesis that we see, and so that's unstable by nature. If you fuse them in their reduced position, they do great. So those are nuances in terms of plain radiographs. Electrodiagnostic studies, including EMG, and we'll talk about this more later, so I'm going to move quickly. can help you out, high false positive rate, and negative result doesn't mean that the patient doesn't have a radiculopathy. Ultrasound and a vascular referral, if you're worried about vascular collocation, they usually will describe their pain a little bit differently, starting from the bottom of the legs going up, or it may just be in the lower legs where the pain is more concentrated. So these are X-rays looking at the alpha angle and the center edge angle, which can be seen in patients who have dysplasia or other types of issues. And so they may not have horrible hip OA, but these views can help you understand why they may be having some hip pathology. So let's talk about hip injections. So we start to go into doing things that are where they can be diagnostic and therapeutic. They can help you make a diagnosis when a patient comes in with both hip and spine pathology. So hip injections, 87% sensitivity, 100% specificity. So you have a patient who has groin pain, but they also have findings on their lumbar MRI that can produce groin pain based on the dermatomal distribution of the nerves that are compressed. This can help you out. The caveat here is that we have literature, particularly that came out from two different sources in 2016, basically saying an increased risk of total hip arthroplasty deep infections if a patient presents and gets an intra-articular hip injection within 3 months. So if the patient has end-stage hip OA and it's a diagnostic challenge, that should be kept into mind, because if it is the hip, then they have to wait 3 months. And I think most of our joints guys here are waiting and not doing these arthroplasties because having an infection can be a big deal. So you want to talk to the patient about that if you're going to send them for a hip injection. A lot of these are done lidocaine only if it's for a diagnostic purpose, so that the steroids gets absorbed by the body in general. So that's why doing these transforaminal or lumbar epidural injections can be helpful, but not as clean as the lidocaine hip injection. But we got to make sure that we think about the risk of infection if a patient is going to be thinking about getting a hip replacement. So using our physical exam, our history, and our diagnostic imaging, we were able to create a differential diagnosis, right? So you have your horses and your zebras, you pick the things that you see most commonly, and then if they're negative for those things, you further work them up and start to send them out to specialists. You can see this list here. I'm gonna skip over it for the sake of time. And so this is a kind of flowchart of ways to approach patients who are presenting with radiographic or signs of osteoarthritis and joint disease and other spondylotic lumbar issues. So essentially, find out what their predominant complaint is, get a good history. If it's groin pain, they have a good chance of this being mostly hip OA. We talked about fluoroscopic hip injection. So patient has no interest in getting a total hip. They just want to know what's going on. That may be a good starting point. Otherwise, I would work up the back. We haven't found the same thing as our joints colleagues in terms of doing lumbar epidural injections and infections, although there's some literature out there suggesting that. So I'm going to quickly finish up. So we know that there's some interconnection. These things are the anatomic locations of the hip and the lumbar spine are very close in there. We see postural changes in lumbar alignment due to hip pathology, as we can see here. This is actually a patient that presented to me. He's a 25-year-old gentleman presenting with ankylosing spondylitis, rapid kind of loss of his function, and this is his standing x-rays. And so we measure things out to look at spinal deformity, which include SVA, and so a sagittal vertical axis. So having one greater than 4 centimeters is considered malaligned, and his is 150. So we can consider this being a spine pathology. However, we have to look at other things. So our division chief here in Thermoprotosaltis described something called TPA, an angle that's used, an angular measurement to look at their actual deformity. And so when we look at his TPA, it's actually normal. And so we know that it's not generating. His stooping forward is not being generated from his his lumbar or his overall standing alignment. Also pelvic tilt. So when a patient is unable to stand because of a spinal deformity, they're going to compensate, right? And so this guy's not compensating, so that should give us an indication to look somewhere else. And so this is where we looked, right? He had hip flexion contractures. This is him in the office, inability to stand up straight. We can see that in a patient who has spinal deformity, lumbar stenosis, or hip flexion contractures, right? He underwent bilateral total hip arthroplasties and saw him in the hallway in passing, and when he was standing as tall as I was. So to conclude, should you do the hip or spine first? First find out what's most symptomatic, okay? So do the things that we talked about, history, physical exam, injections. Is there, look if there's pre-existing sagittal spinal malalignment, and then do you anticipate a change in pelvic tilt as a result? So there's patients who have both. You have to figure out what to do first. We've seen series where patients who have had total hip arthroplasties and then have spinal deformities corrected, start to dislocate their hips because we changed the position of their pelvis. And so working together, if we can diagnose that the patient has both, we say, hey, look, this patient has spinal deformity, likely going to have a spinal deformity surgery. Let's do the spine first, and then you put the hips in the place that they should be in, if that makes sense. And sometimes not an issue. If the hips are more symptomatic, we lead with that. So a little flow sheet, again, which is more symptomatic, go to the hip first. If it's equal and there's an issue with spinal alignment, the spine goes first so they're not having hip dislocations. Thank you. Appreciate your attention.
I want to thank Kola for that excellent talk, and we're going to move a little bit farther north up to the neck. Welcome. I'm impressed that you all found this lecture hall. All right, so neck pain epidemiology. High prevalence, and it's one of the most common musculoskeletal disorders. It's a source of high healthcare spending. Neck and back pain together are some of the highest healthcare spending in the US, 134 billion or so. High cause of job absence, 11.4 days of work on average among the over 25 million Americans who miss work for this reason. More women experience high disability neck pain than men. Natural history, that having been said, it's usually self-limiting. It generally improves with little or no intervention. A number of studies have reported a general range of improvement from 36% to 95%. However, about a quarter to a third of patients go on to experience persistent pain, and those are the patients we're probably going to talk about today. Differential diagnosis. First, evaluate for urgent or emergent pathology. So things like a tumor, a soft tissue tumor, potentially spinal tumors that are intradural, infection of the disc, discitis, epidural abscess, so pus in the canal, meningitis, myelopathy, which I think Dr. Bendo is going to discuss a little bit later, central nervous system disorders, trauma, fracture, and such, and then pinched nerve or radiculopathy manifesting in a profound neurologic deficit. And once you've ruled out the bad things, you can relax. Here are some bad things. There's a C5 metastatic tumor. Here's an epidural abscess, and you can see pus in the dorsum of the canal compressing the cord. Here's a fracture dislocation, C6, 7. So non-urgent, uncommon things that we see. Things like subacute or what we call cold trauma, maybe fractures, some of the rheumatologic disorders, including ankylosing spondylitis, DISH. Dr. Rackoff is going to be here later to talk about that. Patients can have psychogenic pain, fibromyalgia, and some other less common reasons to have neck pain. Neurologic evaluation. So we break our neurologic pathology out into radiculopathy, which is a pinched nerve root problem. It's a nerve problem. not a spinal cord problem necessarily, and myelopathy, which is a spinal cord problem. And then certainly you can have both, a myeloradiculopathy. But radiculopathy is going to give you nerve root compression. It's going to be a lower motor neuron lesion. Symptoms of nerve root are usually in a single nerve root distribution or maybe multiple, but are usually going to have a certain signature with pain, numbness, tingling, paresthesias, weakness, usually isolated to a certain neurologic distribution. Myelopathy is not nerve root compression, it's spinal cord compression. It's an upper motor neuron lesion, and symptoms can include loss of manual dexterity, difficulty with fine motor tasks, gait dysfunction. We can see referred pain, especially to the sort of neck and cervicothoracic region, from a variety of visceral disorders, and it's important to keep those in mind and not get too anchored on someone who comes in complaining of neck pain alone, because all these things are generally more concerning than what I see in the office on a regular basis. Non-urgent and common spinal pathology include disc herniations, spondylosis, which of course is a sort of a catch-all term for spinal degeneration, inclusive of the arthritis of the various joints and disc degeneration, including uncovertebral joint arthritis and degenerative disc disease, facet or zygapophyseal arthritis, postural disorders and deformities, and then soft tissue injuries like muscle sprain or strain. Here's a C6-7 disc herniation on the right, pinching the C7 nerve root. That's going to give triceps weakness, maybe wrist flexor in a C7 distribution. Here's a C5-6 foraminal disc herniation on the left, resulting in compression of the C6 nerve root, which is going to give you biceps, wrist extensor weakness potentially, and paresthesias, numbness, tingling along the anterolateral aspect of the arm to the radius. Here's multi-level spondylotic myelopathy with multiple levels of cord compression. Here's some acquired upon congenital stenosis with T2 signal change in the cord or myelomalacia. I would say that in both the cervical spine and the lumbar spine, a lot of our patients are set up for these things. They do have some element of congenital stenosis, and so they're predisposed to compression when they have more mild pathology. We seldom get patients with big capacious spinal canals that require decompressive surgery because their bodies can accommodate the pathology and changes. And this is just garden variety cervical spondylosis. Cervical kyphosis, of course, is normal loss of cervical lordosis, resulting in a forward flexion of the neck and inability to balance the head over the thoracic and lumbar spine and pelvis can be a source of pain and require a deformity, a correction in order to correct pain. Basic elements of the physical exam, of course, inspection, palpation, range of motion, neurologic exam, provocative testing. Here are basic benchmarks for cervical range of motion. We talk about, chin to chest, sometimes in finger breaths, occiput to spine in order to document things and be able to compare from one exam to another. Sensation, here's your classic Netter dermatomal diagram. Keep in mind that patients may present with axillary or lateral anterior chest pain, and that can come from a C6-7 disc herniation, a C7 radiculopathy sometimes. So sort of a source of non-cardiogenic pain, especially when it started going in the arm, can sometimes come from the neck. Here's a diagram of posterior referred pain. We commonly see this posterior ramus pain, especially from C5-6, C6-7 disc herniations going to the medial periscapular region. And this can be a big bother for patients and also help confirm our diagnosis. Strength grading, again, from 0 to 5. Upper extremity motor exam. Here are our so-called pointer muscles, or our quick and dirty exam, but deltoid, bi, tri, grip, interossei. Reflexes, again, graded 0 to 4+, or hyperactive with clonus. And here are our sort of basic reflexes. C4 involvement. can result in medial scapular winging. No lecture's really complete without a little brachial plexus. I got some Krebs cycle later for you if you're interested. Tough crap. All right, but C4 does contribute to the long thoracic nerve, which can result in medial scapular winging. Provocative maneuvers for radiculopathy. All these maneuvers are closing down the neural foramen and exacerbating the pinching of the nerve roots as they exit the cervical spine. So Sperling's testing, be lateral rotation and extension, axial compression, straight compression. Shoulder abduction test, a really shoulder abduction sign. Patients will come and they'll be sitting in your waiting room or in your exam room, their hand on their shoulder or their hand on their head. Why are they doing that? They're doing that to put some slack into the nerve root, to take tension off the nerve root that's being pinched. I know Dr. Bendo has a lecture later on this morning, and he goes into this in good detail, but the basic myelopathy tests and signs, Babinski test or plantar responses, Hoffman sign, which is essentially the upper extremity analog of flicking the middle digit with a relaxed hand and looking for clasping of the fingers, finger escape sign, keeping the hand with the fingers abducted and watching the ulnar digits drift away, inverted radial reflex with clasping rather than extension, hyperactive scapulohumeral reflex, Lermite sign, which is, again, lightening down the spine with flexion of the neck. I had a patient who was a Alvin Ailey dancer and came into me, and he described to Dr. Stieber, every time that I dance and I put my head down, I feel lightning go down my spine and out my arms and out my legs. And he ended up with a expansive laminoplasty for treatment of acquired noncongenital stenosis. And then ankle clonus. Rapidly dorsiflexing the ankle and looking for beats of clonus. History red flags, persistent pain in a patient greater than age 55, high energy trauma, low energy trauma in the context of underlying pathology, so someone who has DISH or AS or some other disorder that may predispose problems and put them at increased risk. A patient who has a history of prolonged steroid usage and may be osteoporotic. Patients who present with bowel bladder symptoms, obviously concerning. Patients with unexplained weight loss or night pain, concerning for neoplasm. Same thing with non-mechanical pain, pain that does not seem to be conditional on movement or position. History of drug use for infection, same thing with HIV, hepatitis, other things that might result in immunocompromise and inflammatory disease. But especially as a subspecialist or as different specialists, when patients are coming to you, often referred by other doctors with presumptive diagnosis of spinal problems, it's important to obviously not miss metastatic tumor, other primary tumors, things that could be resulting in back pain or neck pain, for that matter. Other exam red flags, neuro findings, obvious deformities, radicular symptoms, gait disturbance. Most of my patients, I have them walk. I watch them walk either in the exam room or in the hallway. Documentation of unintended weight loss, serious illness, severe persistent restricted range of motion. And you can break these down into patients that require rapid and thorough investigation, maybe even hospital admission in order to get their tests in a expedited manner, versus patients who need more reassurance and potential observation. Indications for imaging, so red flags, trauma, malignancy, infection, deformity. Patients who've had a history of previous spinal surgery, they have a much lower threshold to image, especially if they have indwelling hardware or have had fusions. Patients where delayed imaging is probably more appropriate. Persistent pain despite treatment of 6 weeks, symptoms that are incapacitating, symptoms that are progressive and worsening. Plane radiographs, the highest yield plane radiographs are the lateral radiographs. They are poor for early pickup of infection or malignancy. By the time that there's enough bony resorption to really see these pathologies on plain radiographs is usually advanced pathology. But they are useful for looking at the sagittal alignment of the patient, vertebral or facet subluxation or dislocation, fractures, disease of the facet joints or the uncovertebral joints in the neck, disc degeneration, spondylosis, certainly the relationship of the occiput to C1 and C1 to C2 for upper cervical pathology, which we can see in trauma, we can see in rheumatologic disease, congenital deformities, and congenital spinal stenosis. We can look at some of the bony lines that strongly suggest congenital stenosis and indication for further workup with advanced imaging. Other cervical views, AP views are helpful for coronal deformity, for arthrosis or arthritis. Open mouth view for C1-2 or C2 fracture of the dens. Oblique views can help us look at the bony foramen for foraminal stenosis and facet disease. Flexion extension views reveal instability. Advanced imaging studies, MRI, obviously helpful for evaluating the discs, neurologic compression, and then other pathology. CT is better for bones, better for the bony anatomy, better for identifying calcified discs, OPLL, for confirming ankylosing spondylitis or DISH, helping to better define congenital anomalies, and also post-surgically looking for pseudoarthrosis or failure of union of the bones, as well as misplaced hardware or migrated hardware, loose hardware, things of that nature. Here's a patient who had a simple AP and lateral following a diving accident. X-rays look fine, but we don't visualize down to C7-T1. And we see that he had a burst fracture, C7, with profound canal compromise. It's important when you do get plain radiographs to make sure that you visualize the entire cervical spine. So in the event that an MRI is contraindicated, CT myelogram is often the answer. A lot of the CTs now are actually very good without myelogram and getting soft tissue definition. However, CT myelogram is still the gold standard. MRI and CT are often both necessary for surgical planning. It's important to view all this imaging in context. As we get older, the prevalence of asymptomatic pathology increases. And as I tell my older patients, we don't treat the MRI, we treat the patient. We use the MRI to help treat the patient. Other diagnostic studies, diagnostic injections and blocks of the facet joints, cervical epidural steroid injections or selective nerve root blocks to help isolate specific nerve roots that may be resulting in painful radiculopathy, electrodiagnostic studies, and I know that Dr. Lolis has an excellent talk later today. Surgical indications, myelopathy, that's clinically symptomatic, myelopathy with upper motor neuron findings, and stenosis with T2 signal change or myelomalacia. Those patients should be referred to a spine surgeon for evaluation. Cervical radiculopathy, patients who have a profound functional neurologic deficit, patients who have a progressive neurologic deficit. They're moving in the wrong direction. They're trending in a bad way. Persistent neurologic symptoms that are bothersome despite non-operative treatment of at least 6 weeks. And then pain that's recalcitrant to non-operative treatment when you've exhausted non-operative treatment and it's been 6 weeks or so. Indications for neck pain, operating on neck pain alone without neurologic symptoms. We don't do that a lot, is the truth of the matter. But sometimes patients have isolated pathology is very clear. They have a beautiful neck. They have one bad disc. It's bone on bone. They had a previous history of radiculopathy. Those patients can do very well. Obviously, to treat axial neck pain, we make sure that we've exhausted all non-operative treatment. And there has to be clear cervical pathology as the pain generator. Sometimes that's isolated or severe disc herniation or spondylosis at one level, or severe facet arthritis at one level that's responsive to a facet block or radiofrequency ablation, or instability resulting in pain. Kyphosis also, spinal deformity can result in pain in axial neck pain. Thank you, and I hope you enjoy the rest of the course.
right, good morning, guys. So my name's Chirag Shah. I have the pleasure to speak with you today about back pain and the evaluation of back and leg pain. I'm one of the interventional spine and sports medicine physicians here at NYU. I don't have any disclosures. Objectives today, we're going to be talking about common sources of low back pain, the initial eval, imaging, risk assessment, and whether age plays a role in elucidating our diagnosis as well. So structures in general that can cause low back pain. So this is very generic slide here, just anything that's innervated, that's capable of being identifiable from a clinical standpoint and susceptible to injury or disease. So that includes things like bones, joints, muscles, ligaments, nerves, all of that kind of stuff. So today I basically decided to take my presentation and make it into a case presentation, so that maybe in this format we might be representative of what we might be able to see in the clinic. So before going into any of the details of our case today, I generally like to go through these steps with the history. So bringing us back to med school, it's kind of like the OPP, QRST, and looking at red flags and neurosymptoms. So when did it start? What makes it worse and better? What does it feel like? You know, where does it radiate? How bad is it? Is it constant? Does it come and go? Those kinds of sorts of things. Is there any weakness? Is there any numbness or tingling, bowel or bladder incontinence, fevers, chills, night sweats, weight loss, a lot of the things that we've heard earlier today? Is there any past medical or surgical history? Is there any social history, family history, and purview of systems, of course? All right, so our first case today is a 42-year-old otherwise healthy male who presents with radicular low back pain that began 6 weeks ago or 8 weeks ago after he attempted to lift a heavy object. The pain is worse with sitting, in car rides, or brutal for him, and it's better when he stands or changes positions. He describes the pain as stabbing and burning in quality. It's constant in nature, and it radiates along the lateral thigh into his big toe. X-rays are unremarkable. We're going to get to an MRI in a little bit. And he's also gotten a chance to see a very good primary care doc. So he's already started with Trimedrol dose pack, Mobic. After that, gabapentin. He started physical therapy and chiropractic care. Every now and then when he's walking, he'll notice that his foot will catch. And he does notice that there's numbness and tingling in the same distribution as his pain. He denied any of the red flag symptoms. So here, other than the occasional beer that he drinks, the remainder of his social and his history in general is negative. And so here, before I kind of jump into further parts of the case, I do want to talk about medications that we can use during radiculopathy. So PO, IM, and IV steroids were all kind of evaluated during this case, and there was no real significant difference between all of them. So in terms of, the only difference here was that PO steroids seemed to show a better impact on their functional ability. It didn't show a big difference in their pain, but it did show some improvement in their functional ability. So here, despite the fact that there isn't really good data or good sources of to talk about doing PO steroids when we're treating them, we certainly do often do this, especially in the clinic. If it saves them from further interventional procedures, from surgical interventions, and honestly just gets them feeling better a little bit faster, they're able to get more functional, they're able to participate in PT and start doing the things that will get them feeling better quicker. There's a lot of different kinds of steroid tapers that I've seen over the years. Some include going from 70 milligrams down to 10 milligrams per day over the course of a week. Other times I've seen 40 milligrams for 5 days straight. And then other times we'll just use a straight Medrol dose pack, so going from 24 milligrams down by 4 milligrams per day over the course of 6 days. That's what I've seen most commonly. There doesn't seem to be a huge difference between them. It's mostly just kind of anecdotal. So in terms of other medications, we have membrane stabilizers such as gabapentin, pregabalin, topiramate, and they've all been studied here and demonstrate at least minimal to moderate benefit for the management of radicular low back pain. Unfortunately, a lot of times these get limited just because of other side effects that come into play, things like lethargy, fogginess, drowsiness, especially with our elderly patients. We want to limit the chances of them having another fall or having another complication from something like that. All right, so going back to the case here, I typically examine their gait. So similar things that we talked about before, foot drop, Trendelenburg, hip hiking, those kinds of things. We inspect their skin, their spine alignment, examine their lumbar flexion, extension, side bending, rotation, oblique extension, palpate their spinous processes. We'll look at their paraspinal musculature, their SI joints, their greater trochanteric regions, and perform a good neuro and musculoskeletal exam, including provocative movers at the end. So for this patient, we had a very slight foot drop. He preferred standing as much as possible during the patient visit. Pain was excruciating with lumbar flexion. Hip range of motion was full and pain-free. There was some tenderness over the lumbar paraspinal musculature. He did have subtle weakness with ankle dorsiflexion and great toe extension. There was some numbness over the dorsal aspect of his foot, and there was a positive slump and straight leg test. All right. So this is just a dermatomal pattern map here. So this kind of helps identify any areas that might follow a nerve root pattern, as well as just listening to them from their history. Kind of, does it go to the big toe? Does it just go to the knee? Is it posterior, et cetera? So that can help us kind of identify which nerve root might be affected if there is a specific one. So here we've got the straight leg test. So with regard to lower limb dural tension signs, the straight leg maneuver has a sensitivity of about 72 to 97%, but a specificity of 11 to 66%. Contralateral is a little bit more specific. What causes the pain is the stretching of the nerves by the disc herniation, which we can see here on the image. It increases the tension of the dural lining outside of the nerve, which, as you can imagine, causes pain to the patients. Okay, here's the slump test, or another test. However, this one doesn't have as much good data discussing sensitivity and specificity, but it can also help us kind of follow the same line as a straight leg. So here's the femoral nerve, or Eli's test. Again, as mentioned earlier today, it's positive in about 84 to 95% of patients with upper limb disc herniation, upper lumbar spine disc herniations. So these are the SI joint tests. These are 5 of them. We typically want about 3 of them to be positive to show a good indication of sacroiliac joint dysfunction. We got Kemp's test here. So this is another test to isolate facet-mediated pain by loading the facet joints. A negative test often helps us rule out facet joint pain. However, a positive test is not specific enough per se to localize it, but then doing a medial branch block for diagnostic purposes can also then help us a little bit more. So differential diagnosis, this is obviously pretty extensive, and for this talk, we'll just kind of talk about 2 of the more specific ones or more common ones, which is lumbar radiculopathy and stenosis, or disc herniations and stenosis. So that's kind of where we'll go focus a little bit more on today. In terms of prevalence, that's why the intervertebral disc disease is most common with 39 to 42%. Symptomatic facet joints is about 15 to 32, and SI joint is about 13 to 18.5. So here with the average age, this is just kind of looking at broad strokes, but generally speaking, younger patients often have a disc issue. Older patients have more of an arthritic component, so facet joint pain or SI joint pain. So not that this gives us if you're a 25-year-old, you definitely have a disc issue, but obviously you're going to be looking or leaning more towards that as a possibility. So imaging here. So this is kind of the same thing that we talked about before, limited utility for non-specific low back pain with a duration of less than 4 weeks, plain radiographs, advanced imaging. We typically use advanced imaging more for persistent pain despite conservative care, or if they have neurologic deficits, infection, malignancy, those kinds of things are more of the red flag symptoms. So a lot of times I'll get patients who come in and they're like, hey, we want an MRI. They're like, is an X-ray really going to show anything, or why do we not get any imaging? How do you know what we're actually looking at until you see it? A lot of times it's just about counseling the patient. So if we start to kind of go into X-rays, MRIs, et cetera, we're going to have to tell them and let them know that there are incidental findings that are common, and sometimes that leads to unnecessary testing and interventions. A lot of times, these images are not off the table. It's just that we may need to do them only if they're not reaching their milestones appropriately. So we kind of have to educate them on what the typical disease process looks like, the time frames, and once they know that, they often kind of take a back seat and are okay with you kind of running the show. So here, imaging, I think this is just a little bit of imaging. I think this, let's move forward here. Yeah. This kind of zooms in. So this is a zoomed in picture. I apologize, but this is basically looking at a New England Journal that talks about the MRI prevalence of disc herniations and actual findings on a disc image for asymptomatic patients. 36% of them had normal disc levels at all levels. About 52% had a bulge at least one level. 27% had protrusions. 1% had an extrusion. 38% had abnormalities at greater than one level, and 14% had annular fissures. 9% had facet arthropathy. So generally speaking, about 2/3 of patients had an abnormality on an MRI without any actual symptoms, and the average age for this study was about 42. So here we go. This is basically an MRI image of our patient. Here it shows that he's got an L4, L5 disc protrusion causing impingement of the exiting L5 nerve root. So this patient had a left radicular low back pain with subtle weakness in left ankle dorsiflexion and great toe extension. So this kind of MRI correlates with some of the symptoms that he had. So I just wanted to briefly talk about terminology real quickly here. So the difference between lumbar radicular pain and radiculopathy, essentially radicular pain is just pain that where there's an irritant to the spinal nerve or DRG. On the other hand, radiculopathy has a motor, sensory, or reflex change, but does not necessarily cause pain. So quite often, pain will be present with a lot of those associated symptoms like numbness, tingling, reflex changes, and then we'll call it radiculopathy. So before we get into some of the questions that our patient has for us, I wanted to go over some things about the lumbar MRI and the standardization of some of the terms. So here we've got on the sagittal view, we have normal, where there's no disc material that extends beyond the periphery of the disc space. A disc bulge, where it extends beyond the edges of the vertebral body and usually less than 3 millimeters. Protrusion is when there's displaced material where the base of the herniation is larger than the apex, and extrusion is where there's displaced material where the apex is larger than the base. And then sequestration, which is essentially a chunk of the disc is popped off and is wreaking havoc throughout the lumbar spine. So this is basically the same thing, but here on the axial view, so you can see how there's the diffuse disc bulge, a broad base disc protrusion, which is 25 to 50% of the circumference. The focal protrusion is where there's less than 25% of the circumference, but again, the base is larger than the apex. Then we get to the extrusion, where the apex is larger than the base, and then sequestration. So looking here, now we'll describe the location of these disc herniations. The central or paracentral location is the most common. Just lateral to that is a subarticular or lateral recess. And then finally, we've got the lateral, far lateral, or the foraminal zone. And that's all the way out to the end. All right, so here we've got a little bit more imaging. These are just to identify. Here's a left L5 S1 paracentral disc extrusion. Here we've got a left L4 L5 foraminal extrusion impinging the exiting nerve root. And then I wanted to go over some biomechanics here. So one of the questions that I get is, why does it bother me so much when I'm sitting, but when I walk and stand up, I don't really have as many issues? While we're sitting or leaning forward, the anterior aspects of the vertebral bodies come closer together and force the nucleus pulposus more posteriorly, which ends up causing more pressure on the traversing nerve root. After we stand up or start walking, the lumbar extension comes into play and then brings the posterior elements forward or brings it back together, so the nucleus pulposus anterior, which then relieves some of the pressure on the nerves. So next, often I'll get, is this going to last like this forever? Am I going to be in pain forever? Now, while I could quote the studies all up on the slide, I think it's more beneficial to just talk in broad strokes here. In the large majority of cases, even if we did nothing, patients will get better. Having said that, I also advise them that our job is to primarily allow them to get functional, decrease their pain, and allow them to get back to their old selves as quickly as possible. So another question I get is the picture going to look like this forever? Is there going to be a disc herniation that's always going to sit there and kind of wreak havoc where it's at? So a lot of times I'll quote this study and I'll show them this picture, which is from painsource.com. Demonstrates an example of an acute resorption of an L4, L5 disc extrusion over the course of 1 year. On the left, we see the sizable disc extrusion, and then on the right, 1 year later, without surgery or any interventions, it's kind of improved. There is a little bit of a T2 hyperintensity that's left over. So what this kind of demonstrated here is that overall, approximately 2/3 of disc herniations will change in size. Whether they'll fully resorb or only change in a little bit of size is debatable. But the whole point of this is just to let them know that it is possible that the disc will change. It can get smaller, but in general, even if it doesn't get smaller, it doesn't mean that they're going to be in pain forever. It can certainly become asymptomatic. Here, so as an interventionalist, I figured I'd talk a little bit about interventional procedures. We're going to be talking a lot more extensively about this later today. But this was a study that looked at the effectiveness of lumbar transforaminal epidural steroid injections. I won't go into too much detail, but basically they had a success rate of about 50 to 90%, about 2 to 3 times better than the placebo. And the number needed to treat was less than 3, up to about 70% of patients had about 50% more of improvement. And this lasted for about 12 months. So here we decided to do a transforaminal epidural injection for our patient who had the slight foot drop and the L5 nerve root impingement. And you can see the needle just here under the pedicle. And then we get the contrast that flows over that L5 nerve root. Okay. And then, we decide, okay, we're going to inject. The big question is, are we injecting a particulate or non-particulate steroid? So this one just compared the 2 different types of steroid use in the epidural injection, and they didn't find any substantial difference between the 2. So basically, you can use either one with good benefit. I wanted to repeat another article here which compared the 2 as well, and in this article, it showed similar benefits. There was no real difference between the 2. However, the particulate steroid group did show a lower number of injections needed to treat compared to the non-particulate, but of course, particulate carries a little bit more risk as well. So kind of weighing your risks and benefits for doing an extra procedure potentially versus the risks of inherently included in a particulate steroid. So, it's neither here nor there. In general, from some of the studies that I've looked at, they're always looking at between 1.2 to 1.7 injections anyways for most patients. So if we're going to be doing 2 injections for most patients anyways, you might as well go with the safer option. So to summarize, most patients who present with back pain will have non-specific back pain. Less than 10% have any specific etiologies, and less than 1% have serious systemic etiologies. Focus history and exam are sufficient for most patients to have pain for less than 4 to 6 weeks. Any patient with severe progressive neurologic symptoms should have immediate advanced imaging or urgent specialist referral. And then finally, patients with persistent symptoms for specific etiologies greater than 6 weeks don't have a benefit with conservative care, can also undergo interventional procedures or advanced imaging. Thanks.
So I don't think we have any questions from the audience, but you do have that capacity to ask us questions. So I would encourage you as the day goes on to ask your questions through the Slido system. But let me ask you, Dr. Shah. So do you use oral steroids in your practice? And is your experience in line with what the literature suggests?
It's a great question. So I do use oral steroids, and typically I use them for patients who have very severe pain or intractable pain. The benefit here of using the steroid is that I found that patients do have some sort of benefit, whether that's functional, whether it's placebo, whether it's time, who knows exactly what it's going on. But after 6 days or 7 days of those steroids, they do have benefit. And when they do have benefit, at least they're able to start participating in physical therapy. They're able to start walking around and moving around more so. So that's in line with the studies, but I do actually find that there is more benefit with it than I think the studies portrayed. So I think I mentioned this earlier as well. There's a lot of speculation on which one is the best option. I've seen patients who different doctors will go from 60 milligrams to 40 milligrams to 20 milligrams over the course of a week. I'll see patients who will get 70 milligrams going down by 10 milligrams per day over the course of a week. And then finally, the Medrol dose pack where it's 24 milligrams to 20 to 16 by 4 milligrams. Generally speaking, it seems like everyone kind of does about a week of steroids. But the dosing, depending on if they have other comorbidities, also plays a factor. So if there's concern for osteoporosis or those kinds of things, then you'll do a lower dose. However, there hasn't been good data on which one's the best one. But I often just use a regular Medrol dose pack, which is the 24 down by 4 milligrams a day.
Kola, I'm not sure if you addressed the very dangerous piriformis syndrome in your talk that I have a lot of patients present with who are sure that they have piriformis syndrome. But can you talk about your approach to that patient that comes in?
Yeah, so you know, I see a fair amount of that as well. I think it's the
May I have your attention, please? May I have your attention, please? We're testing the fire alarm system. Please disregard any audible or visual signals you may see. May I have your attention, please? May I have your attention, please? We're testing the fire alarm system. Please disregard any audible or visual signals you may see. Thank you.
even the building doesn't like piriformis syndrome. But so I think in the office, it's easy to get a patient to be able to stretch their piriformis by putting them in a figure of 4. You can ask them when they get home to actually palpate deep into the groin, and they should be able to feel the tight muscle if it's actually true. And then, you know, after conservative treatment, they can work with pain management doctors to with injections if everything else has been ruled out. So that's usually my approach to it.
Mm-hmm. Yes.
Yeah, so you do a good job separating like when you should time hip versus spine surgery. I have a protocol for that. One thing I've noticed over time is if you have a C4-5 or C5-6 disc herniation, and then you're like looking at also rotator cuff pathology, how do you time that surgery? Because we know from like our sports colleagues that rotator cuffs should be done sooner than later nowadays. Mm-hmm. So how do you time that if you're worried about innervation causing weakness to the cuff?
So you can usually pick up rotator cuff pathology on physical examination, tenderness over the greater tuberosity, near Hawkins testing isolated external rotation. I think that the physical exam findings will be a little bit different. Usually the neck's not going to be involved, but if there is suspicion for rotator cuff injury or pathology, then imaging, plain radiographs and MRI of the shoulder. You know, I think one of the worst things you can do as a spine surgeon is to get burned on operating on the neck when the shoulder's a problem, operating on the neck when it's a peripheral nerve compression, or operating on the lumbar spine when it's the hip. So it's always worth imaging.
Yeah, I guess my question was more about timing. If you think there's both going on, you do the cuff first or the neck first.
Do you operate on one versus the other?
Yeah.
So which one first?
You go in. If you know there's a cuff here and you know there's the neck pathology, you can go there's sympathetic.
If you have neurologic weakness coming from the neck, that takes precedence over the cuff. Is what I'll say. Also, if there is any spinal cord compression or concern for spinal cord compression, then the positioning during surgery for the rotator cuff surgery could put the patient at risk for exacerbation and further neurologic injury.
I think to add to that, whatever their main pain generator is, you know, we work with our sports colleagues. So if they're having radiculopathy and that seems to be their driving pain generator, then it makes sense to take care of that first versus if it's the rotator cuff, using things like the shoulder abduction test. If a patient has true intra-articular shoulder pathology, they usually do not get relief with picking up their shoulder at all, versus a patient with cervical radiculopathy would and does. So I lean on that a lot as a way to kind of tease out what is the main driving force of the patient. And I think it's important for both of us, or meaning the spine surgeon and the sports surgeon, to get involved so that the patient has realistic expectations that they're going to have some continued pain afterwards, but we'll take care of whatever bothers them first. So I don't think it's a black and white thing, depending on what's bothering them the most.
Any other questions? So we're a little bit behind schedule, so I think we should go ahead and move on to the next session. Thank you. Dr. Rackoff now, speaking on the natural history, signs and symptoms of rheumatic diseases. We're very happy to have her here.
Hi, I always enjoy giving this talk, partly because I love being a rheumatologist and also because no one would ever want me to operate on anyone. So the natural history of signs and symptoms of rheumatic disease comes up a lot among orthopedists. So you all, and of course rheumatologists, take an extensive arthritis history, and we always try and figure out when someone comes in with joint pains, whether this is inflammatory or non-inflammatory arthritis. And what we generally do is ask patients, how they feel when they wake up in the morning, which joints are involved, whether they have swollen joints or just joint pain, and from the top to bottom, neck, shoulders, elbows, wrists, hips, knees, ankles, feet, and toes, and the timing of the joint pain stiffness itself. The screening tests in terms of laboratories that we start with, often but not always, is an ANA. People, non-rheumatologists seem to order this even more than rheumatologists do. So an ANA, as I explained to patients, is an antibody against your own nuclei. We're not supposed to make antibodies against our own cells. It can be confusing because up to 20% of the normal healthy population can have a low positive ANA. So we always have to put it in the context of how someone's feeling and if they make other antibodies. And even in high titers, 5% of people, especially as people age, can have a positive ANA not associated with an autoimmune disorder. We don't put too much weight into the pattern of the ANA, except when it's something called nucleolar, which we tend to see more with scleroderma. Some causes of a positive ANA, the autoimmune diseases that you've all heard about. Even in rheumatoid arthritis, about almost 50% of people can have a low positive ANA. It's very common in autoimmune thyroid disease, and patients get very anxious about having a positive ANA. But if that's the only ANA they have and they have autoimmune thyroid disease, you don't necessarily have to go looking for something else. Viruses, we've seen this a lot with COVID, can cause positive ANA, and again, not necessarily associated with a defined autoimmune disease, and malignancy, inflammatory bowel disease, pulmonary fibrosis. So when do we order an ANA? It's definitely not, it should not be a general test for a general medical evaluation. But certainly if someone comes in with the following: joint pains, joint swelling, Raynaud's, atypical rashes, oral and genital sores, eye inflammation. We see a lot of inflammatory eye disease at NYU, sicca symptoms, muscle weakness, leukopenia, and certainly kidney disease. The rheumatoid factor, also very, very common to have a low-level rheumatoid factor as we age. It's actually an antibody also. It's an antibody to the FC portion of IgG. It's mostly used for the diagnosis of rheumatoid arthritis, but it can be seen in other rheumatic diseases. The more common one is actually Sjogren's syndrome. So we have Sjogren's patients actually very commonly have a low positive rheumatoid factor. That was a long one. The non-rheumatic diseases that often cause a low positive rheumatoid factor, the more common one is hepatitis B and C, tuberculosis, endocarditis, any chronic underlying infection. I'll skip that. The other test that we use for rheumatoid arthritis is the cyclic citrullonated peptide. It's another antibody. This one is actually strongly associated with rheumatoid arthritis. And we check it in combination with the rheumatoid factor itself, and it can be helpful in differentiating rheumatoid arthritis from other diseases that can cause a rheumatoid factor, like hepatitis C. And it can, both the rheumatoid factor and the CCP antibody can be present many, many years before any inflammatory arthritis, and this comes up a lot in our discussions. If someone has an exam that's really consistent with osteoarthritis, but they have a positive rheumatoid factor and CCP antibody, do we treat them with the RA drugs? And generally we don't. We just monitor them a little more closely. This is a really important factor to emphasize. We don't keep repeating the ANA. Once an ANA is positive, unless it's like in a post-viral syndrome, we don't keep rechecking it. We see this all the time in general practitioners. Once an ANA is positive, again, unless it's post-viral, it stays positive. In lupus patients, what we keep rechecking are complement levels, double-stranded DNA, other autoantibodies. But once a lupus patient is a lupus patient, they're always going to have a positive ANA. How do we differentiate inflammatory pain versus non-inflammatory pain? The inflammatory pain, you wake up with it. That's the ankylosing spondylitis patient, wakes up with morning stiffness, and it gets better as the day goes on, worsens with rest, and often has peripheral joint involvement with inflammatory infusions. The non-inflammatory, the bad knee, you play tennis, it gets worse, improves with rest, and not more than 15 to 20 minutes of morning stiffness, and generally no effusions unless there's mechanical derangement. So recognizing joint inflammation, you guys all know that. The swollen knee is pretty obvious. You lose the defining dimples around the joint. The hands, pretty straightforward also. This is a typical patient with rheumatoid arthritis. Again, the MCP and PIPs is what you look for in rheumatoid arthritis. Although rheumatoid arthritis really, we were all taught a long time ago that it's a symmetric disease, it doesn't always have to present that way, especially in the beginning. The neck, you guys really focus on, obviously. A big deal in rheumatoid arthritis. It's often involved with severe rheumatoid arthritis, especially at C1, C2. And what you want is to get flexion extension films, certainly before you're operating on any RA patient. And a separation and flexion of more than 2.5 millimeters in adults means that the neck is actually unstable. We generally don't see this severity of rheumatoid arthritis anymore, really because of biologics. The only time we see this in people who've declined treatment, people who don't have access to medical care, but we generally don't see this anymore. This is not rheumatoid arthritis. This is inflammatory osteoarthritis. And I tell people often that the good news is that you don't have rheumatoid arthritis. The bad news is that we actually have many drugs to treat rheumatoid arthritis. It's totally manageable. We really don't for inflammatory osteoarthritis. This is often hereditary. Sometimes it'll skip a generation, but it's really very, very painful. If someone really relies on their hands, like they're a pianist or a tailor, we sometimes use low doses of the rheumatoid arthritis drugs with some efficacy. But really only some efficacy. Local joint injections help. Sometimes people opt to get their DIPs fused, but then you really lose flexion of the DIPs. Risk factors for osteoarthritis, obviously age. There are some things we only get as we get older. I mean, I tell people all the time, if you live long enough, you get osteoarthritis and you get skin cancer. Otherwise, you haven't lived long enough. Women are affected more than men. Obviously, there's a hereditary component. Mechanical stress, probably the patient I have who's the most crippled with osteoarthritis was a former football player. Basically, the only joint of his that hasn't been replaced is his neck. There are some diseases that increase your risk of osteoarthritis, crystalline arthropathies, hemochromatosis, and any post-inflammatory or post-mechanical injury. I had my ACL done in my early 30s. My orthopedic surgeon told me I'd have osteoarthritis 15 years later, and he was pretty much on the mark. Osteoarthritis, the typical distribution: neck, spine, hips, knees, the first MTPs, all the fingers. For inflammatory arthritis, it can really present anywhere. As I said, often symmetric, but really doesn't have to be. And I already mentioned that. Now, if someone comes in with one swollen joint, the most important thing is that it's aspirated and infection is ruled out. People get frustrated that we aspirate their knee and then they have to come back a few days later once the cultures are negative, but you really cannot aspirate and give a steroid injection unless you know there's no infection. Obviously, the other diseases that can cause a monoarthritis is gout, pseudogout, hemarthrosis, Lyme disease. You have to send the synovial fluid for Lyme PCR. And rarely, rheumatoid arthritis causes one swollen joint, but psoriatic arthritis really can. We send the fluid for cell count, crystals, and culture, and then do the usual blood tests for uric acid, lime, and if it's one joint, it's usually not. We are usually not going to see a rheumatoid factor or an ANA, but we generally do it anyway. For non-inflammatory synovial fluid, the cell count's generally less than 2,000. For inflammatory, anywhere between 2,000 and 50,000. The reactive arthritides can actually look like a septic joint, so you really have to wait for that culture. But the septic joint is really usually very high white count. Okay, I already mentioned that, and I mentioned that. So for rheumatoid arthritis, it actually affects 1% of the population, more women than men. Smoking is the most important risk factor. And it's often symmetric, but doesn't have to be. Always look at the cervical spine. And we generally monitor patients' progress with periodic x-rays. And I use a lot of ultrasound of the MCPs and PIPs. Heart disease is actually what shortens people's lifespans with rheumatoid arthritis and psoriatic arthritis. We have a very low threshold for evaluating patients for cardiac disease and low threshold for starting statins in people with inflammatory arthritis. Psoriatic arthritis, NYU is a really big center for psoriatic arthritis. It's actually quite different from rheumatoid arthritis, although there is overlap. There's nothing else that gives a sausage finger other than local infection. And if there's a sausage finger, it's psoriatic arthritis. And psoriatic arthritis can present in many different ways. You can just have DIP involvement. You can have one joint involved. It can look just like rheumatoid arthritis. Arthritis mutilans, I think I'll show you a photo of that. We generally don't see any more in this country if people have access to care. Dactylitis, which is this one swollen finger. Enthesitis, I'll show you some examples, and axial disease, obviously sacroiliac involvement. Here's just the other example of, you can see the nail changes and dactylitis and psoriasis at the base of this person's thumb. The nail changes, we look for nail pitting. A few nail pits is not, doesn't make the diagnosis of psoriasis, but we say anything more than 20 nail pits, you really need to look for psoriasis and psoriatic arthritis. The DIPs are spared in rheumatoid arthritis. Nail changes take a really long time to get better, even with aggressive treatment. Enthesitis, really common. Achilles tendonitis. Here's the patient with severe Achilles tendonitis. And the axial involvement, I generally get sacroiliac films on really every one of my low back patients. You know, if you only get spine imaging, you really miss a lot of sacroiliitis. I've seen patients here go through spine surgery only to find that they really actually had sacroiliitis. It's often associated with B27, but B27 can be confusing because 8% of Caucasians and 3 to 4% of African Americans are B27 positive, and only about 5% of B27 positive patients get an inflammatory disease. The Schober's test, you want to keep the level at L5 and have the tape measure 5 centimeters below L5 and 10 centimeters above. And as the patient flexes, you want them to be able to move that tape measure at least 10 centimeters. If they don't, then you really have to think about whether they have axial and sacroiliac involvement. Here's just an example. The normal sacroiliac film is at the base and actually on top. The sacroiliac joints here are totally fused. You also see squaring of the vertebral bodies because of syndesmocyte formation in ankylosing spondylitis. That moving on from the inflammatory arthropathies is gout. This is also a big center for gout. I probably see someone like this about once every other year. I don't know where they come from, but people tend to ignore swollen joints if they don't have access to care. This is tophaceous gout with the classic monosodium urate crystals. When someone has a gout attack, you have to define how often they have gout attacks. We generally don't keep people on medications such as allopurinol unless they have more than 1 or 2 attacks a year, or unless someone's uric acid is very, very high. We now know that uric acid itself is quite irritating to the vasculature. And now we put people on low-dose allopurinol, even if they've never had a gout attack, if their uric acid is above 10, and also colchicine. And the cardiologists are generally on board with that. Although most cases of gout present at some time with podagra, which involves the first MTP, you don't actually only have to have MTP involvement. Gout is strongly associated with heart disease and metabolic syndrome. This is typical gouty fluid, very, very thick. And it's more common in men. Premenopausal women don't get gout. If a premenopausal woman complains of big toe pain, it's really osteoarthritis because estrogen is a uricosuric agent. Gout attacks actually are very, very painful, but even if people didn't have access to care, they usually resolve with rest and ice over a week or so if you can handle the pain. But if they get recurrent attacks, like I said, then they do need to be treated. What do you treat them with? We still use colchicine. We generally don't use colchicine to the point where someone gets diarrhea. If they don't have hypertension or renal insufficiency, we use nonsteroidals, local injections. A Medrol dose pack often works. If people have recurrent attacks and they haven't responded to uricosuric agents, then there are biologics like anakinra, which is an IL-1 receptor blocker, which is very effective, hard to get approved. The most important part of chronic gout therapy is to keep the uric acid below 6. Here's just other examples of the gout. I mean, the photo at the bottom looks just really like rheumatoid arthritis. With allopurinol, we usually start with 100 milligrams. Once you start allopurinol, you have to, at the same time, for the first 2 or 3 weeks, either use the nonsteroidal or colchicine, because any fluctuation of uric acid up or down can precipitate a gout attack. We can even use allopurinol with mild renal insufficiency. Once a creatinine level goes above 2, we try not to, and then we use the febusostat, which is also called Uloric, which is generally safe with GFRs even less than 30. So just to sum up, the ANA, I can't hammer this home enough, it's positive in 5 to 10% of healthy people. It really depends, the significance depends on if you have other rheumatologic autoantibodies and how the patient feels. Rheumatoid factor positivity doesn't mean you have rheumatoid arthritis. It has to be further evaluated. Chronic gout, very easy to treat if people have access to care, and it's associated with other metabolic syndromes. So I'll end there and take any questions. No problem.
Good morning. I'm going to talk about osteoporosis, and it's a little daunting to try to do this in 15 minutes, but we'll try to get through it. So this is the classic representation of the transition with time. On the left-hand side is a woman, premenopausal woman. This is what she looks like 30 years later. You can see the dorsal kyphosis. You can imagine that her height has decreased and her ribs are abutting her iliac crest. So this is what we're trying to prevent with our treatments. We define osteoporosis in a variety of ways. We use, of course, the bone density findings of T-scores of minus 2.5 or lower. But really what we're talking about is trying to estimate a patient's risk of fracture because osteoporosis, after all, is a condition with compromised bone strength, which predisposes a patient to an increased risk of fracture. And we're going to go into how we estimate fracture risk over time, and that influences who we decide to treat at any point in time. This, of course, is the WHO classification. You can see here that anything to the right of anything to the right of -1 or into positive territory is normal. The term osteopenia is really fallen into disfavor. We really use the term low bone mass for that, because osteopenia, as you can see, could be almost normal or could be almost osteoporosis. So it really doesn't have any diagnostic meaning. And then you can see the diagnosis of osteoporosis is with a T-score of minus 2.5 or lower. How do we get to that? Well, we take the patient's BMD, we subtract what would normally be a young adult mean BMD, we put that over one standard deviation of the young adult mean BMD, and you can see representative values at the bottom. If a patient has a BMD of 700 milligrams per square centimeter, and you take 1/10 of that as the standard deviation, and this is how you get your T-score. What does it mean? Well, generally it means that for every T-score number, -1, -2, etc., you're losing about 10% of the normal bone mass. So someone with a -3 has 30 to 35% lower bone density than a normal bone density would be. Now, in the past few years, there's been a change in the treatment paradigm. This is still somewhat controversial, but I think the controversy has largely been settled. And that is that patients who have an acute fracture should be very aggressively treated, particularly as we deal with spinal compression fractures. And the most effective form of treatment, as I will show you, is basically anabolic agents because they have a more rapid and greater fracture risk reduction compared with the standard drugs, the anti-resorptive agents. And again, this is particularly in patients who are at higher risk. The anabolic drugs tend to have some degree of improved fracture healing compared to the anti-resorptive drug. So who are these highest risk patients who may need anabolic therapy? Those are certainly patients with a recent or new radiographic vertebral fracture. Patients with a vertebral fracture have a very high increased incidence of subsequent fractures, particularly if they are not treated. This short term in the first year or two puts patients at a 10 to 20% risk of another compression fracture after their sentinel event. Patients who have very low bone density scores, again, -3, representing 30 or 35% lower bone mass than normal. And then there are a variety of clinical risk factors. You can see smoking, excessive alcohol, people who have a tendency to fall, those who are starting steroid therapy, particularly with lower bone density. Our goal is to try to get the bone density test to a level that is in the osteopenic range if possible, improvement certainly with treatment. There's good data that shows that if you reduce or if you improve the bone density findings, you lower the risk of subsequent fractures. So this is just a study, or Medicare study, that looked at the incidence of subsequent fractures 1 year after an index fracture. The index fractures are listed on the left-hand side of the slide, and particularly if you look at the spine fracture as the index fracture, you can see that over the next year, 15% or so of patients will have another fracture. And the same holds for some of the other sites of fragility fractures. A Swedish study that was larger looked at the same kind of thing and came up with the same kind of information. In the year or two following the index fracture, you can see that there was an increased risk of another fracture, almost 20% with those who had an index vertebral fracture and almost 25% of those who had a hip fracture. And the treatment rates for patients in this study, as well as studies in this country, show that patients at high risk rarely get treated appropriately. So patients in the United States who have a hip fracture, less than 20% of them are receiving bone strengthening medications, which is really a crisis in terms of ongoing care. What about the incidence of osteoporosis? Well, you know that osteoporosis is a condition that increases with age, and you can see here by the decades, we're almost at the first decade of postmenopause, from age 50 to 59. There's about 7% of the population that have osteoporosis, and 50% or so of those will have some low bone mass, the osteopenia. And of course, again, that doesn't have much meaning because it may be almost normal or it may be almost osteoporotic. But you can see with aging the increased incidence of osteoporosis. So patients that are over the age of 75 certainly have a very high incidence of osteoporosis, approaching 30 to 35% of the population. With increased aging, we look at the fractures that may be associated with both increased aging and with lower bone density. You can see that the first fracture that patients with osteoporosis often have is the distal radius and ulnar fracture up at the top, labeled A. And you can see that the other fractures that are related to osteoporosis and aging tend to occur later. So vertebral fractures occur later than the wrist fracture, pelvic fractures, etc. Hip fractures generally don't occur to patients who are over the age of 75 or 80. But you can see that in black is females, in white circles are men, but you can see the increase with aging, showing you the probable relationship between low bone density and fracture risk. This slide estimates the annual risk of fracture, which is important when we talk about fracs, which I'll go into shortly. But you can see that patients from 75 on have almost a 5% incidence of an annual rate of fractures. So that's an important observation. If you look at the fracs data, as I will show you, generally the recommended threshold would be 20% over 10 years. So you can see that in the early age, most patients don't get into the level of risk of fracture that would indicate need for treatment according to fracs at least. Of course, what happens when we get older? Our bone density decreases and the incidence of falls increases. So here you see, not surprisingly, the incidence and rate of falls increases as we reach the same age that the bone density is decreasing and the incidence of fractures is increasing. This is a spine course, so you can see here, you can imagine this is what the woman in the first slide looked like. You can see the dorsal kyphosis. You can see the ribs down near the iliac crest. Many patients will say, you know, I've developed a little belly prominence, even though I'm not gaining weight. And that's because the abdominal contents are shifting downward. And you can see on the bottom slide there a vertebral compression fracture. Now, vertebral compression fractures are the truest osteoporotic fracture because most of them, particularly in women, are not associated with falls. So they are spontaneous fractures. And there are two types of vertebral fractures. Morphometric, those are found on imaging without a clinical correlate of an increase in back pain. And you can see that we query patients about how tall they are. If they have lost 1.5 inches or 2 inches, we generally image the patient to see if there's evidence of vertebral fracture on imaging, either X-ray or vertebral fracture assessment as part of the bone density test. About 20 to 25% of postmenopausal women are estimated to have at least one fracture. Obviously, that rate increases with aging. The lifetime risk of a vertebral fracture in a woman age 50 is about 20%. Vertebral fractures increase morbidity and mortality, particularly those who present with a significant pain and need to be hospitalized. And as I said earlier, patients with a vertebral fracture are at increased risk for sustaining subsequent fractures. So we know that there are about 700,000 vertebral compression fractures annually in the U.S., and that's equal to the number. And
what happened here?
You huh? Just all of a sudden didn't.
Yeah.
Japan. I'm sorry about this. Give me 1 second. Getting weird input into this screen.
Okay. Can you? How do I get back to them?
Sorry about that.
Okay, that's it. Yeah. Thank you.
So what we were saying is about 35% of patients with a vertebral fracture will require hospitalization. Mortality rate is increased. Fewer than half the patients know why they had a fracture. Again, these are spontaneous and, of course, painful. Patients who present with a vertebral fracture above T6, and it's a solitary fracture, you want to make sure you rule out tumors rather than osteoporosis. Usually patients with osteoporosis with a compression fracture have fractures from T6 down. Diagnostic imaging, we obviously start with an X-ray. We can see vertebral height loss, and we describe vertebral compression fractures as either biconcave, wedged, and we grade their severity by the loss of height. So you can see here what a wedge fracture is. You can see from posterior to anterior, there's compression, a biconcave fracture, and of course a crush fracture is a complete lowering from superior to inferior. MRIs are useful, particularly when the radiographs are not diagnostic. We can get an idea of whether the fracture is acute or not acute by the presence of edema, and I can show you that here. You can see that on the T1 image on the left, the edema is dark. On the right, it's light. So this indicates an acute compression fracture. CAT scans are helpful, not in terms of defining acuteness or chronicity, but in terms of whether there was a fracture, because you may see a fracture line. CAT scans are often used if a patient's being considered for kyphoplasty. Here you see a CAT scan on the left with a fracture line, and of course on the right, that's a biconcave fracture, obvious compression fracture. I indicated that our concern is estimating fracture risk, and we use a tool called FRAX, which is a web-based tool that gives us a 10-year risk of a patient's fractures. Here are the inputs, which include age, sex, weight, height, whether a patient's had a previous fracture, whether there is a parental hip fracture, and then you have some other factors, and then you put in their femoral neck bone density, and you can get a risk of fracture defined over 10 years. The recommended treatment thresholds in this country are 20% for a major fracture and 3% for a hip fracture. This tool is available. You just go online and tap in FRAX, and you can access the FRAX algorithm and put in your data for your patients and get a fracture risk. Recently, we've been coming to use a component called a trabecular bone score, which measures the lumbar spine bone quality in the lumbar spine. And this gives us a better indication of a patient's risk of a compression fracture. And you can see here that patients may have similar bone densities, the two scores on the left, but you can see that their microarchitecture is quite different. The one on top is normal. The one on the bottom has what we call poor or degraded microarchitecture. And then you can see on the right the readings. So anything above 1.350 is considered normal. Anything below 1.200 is considered degraded microarchitecture. Anything in between would be partially degraded. So this is a little helpful tool, and you can, if you have that data, which is available in many bone density machines, you can input that in terms of your FRAX. This gives us more data because the FRAX depends on the femoral neck bone density. So this gives us some additional information putting in the lumbar spine bone quality measure. The initial evaluation for osteoporosis includes certain laboratory tests. The N-telopeptide or C-telopeptide is a measure of bone collagen breakdown. So if these numbers are high, it tends to indicate ongoing bone loss. There are certain, obviously, other tests that we do to rule out things like Cushing's disease or multiple myeloma, hypercalciuria. All of those things are listed here. Obviously, a bone density test and a vertebral fracture assessment or an X-ray of the spine, particularly if there's been height loss. Treatment goals are really to prevent fractures, to maintain bone strength, calcium and vitamin D in adequate amounts, a number of drugs that we use. We have anti-resorptives, including the bisphosphonates and denosumab. We have 3 anabolic agents, and we have hormone replacement therapy and SERM therapy. These are generally used for younger postmenopausal women before committing the patients to a more potent bone strengthening medication. In terms of the effectiveness of the drugs, I told you initially that the anabolic drugs are the most effective. They are what we use as an initial treatment for patients at highest risk. You can see here the effectiveness in terms of vertebral fracture prevention with the anabolic drugs and denosumab, as well as zoledronic acid, exceeds 70% in terms of relative risk reduction. So these are very effective drugs. They also have to be followed by an anti-resorptive drug after the course of an anabolic drug, which may be either 1 or 2 years in treatment. Thank you.
Good morning, everyone. My name is Athena Lolis, and I'm going to, as brief as possible, give you a general review of how I approach neurophysiology studies in a spine patient. I have no disclosures. I do have a significant other with the following disclosures. So electrodiagnostics are really first of all, they're a broad term, and they encompass nerve conduction studies and electromyography. And the nerve conduction studies will tell you about the nerve unit, and the electromyography will tell you about the muscle unit. But we implement them into our practice in evaluating a spine patient because they help further characterize, what type of disease or pathology your patient has. And they can tell you even more. They can localize where the issue is. They can tell you about the chronicity, about the severity, and maybe even about the pathophysiology behind the presenting complaint. I always say that when you have a patient come into your office for a referral for electrodiagnostic testing, it's not just written down on the paper. So what's written on the prescription is obviously what the referring provider is concerned about. But I always take the time to talk to the patient. I always get my own history and do my own physical, because I always look at it as there's the concerns that have brought the patient into the office, and then there is the concerns that you have in talking to the patient and what you see on your physical exam. So you're really answering three different questions: your question, the referring physician's question, and the patient's question. So the first part of this is of the nerve conduction studies is a sensory nerve conduction study. It's the most routinely performed part of the electrodiagnostic testing. It's the most susceptible to technical factors. So your SNAPs, as I like to call them, are essentially the quantitative measure of all the sensory fibers in your action potential. You can stimulate them antidromically or orthodromically, and that just depends on where you're putting your recording electrodes relative to where you're stimulating from. And I always say that you should have a bilateral study. So even if a patient says I'm coming in because I have numbness and tingling in my right first three fingers, that doesn't make an excuse for not doing the left-hand side, because the patient is there to some degree also their own baseline, so to speak. So when you're looking at your SNAPs, essentially these are the different calculations that you can make based on the action potential that you see on the screen. What I look at is the latency, and so that's the distance of the simulation to the first negative deflection. I look at the amplitude, which is the distance from the baseline to the negative peak, and then I look at the conduction velocity, which is the distance of what you're stimulating physically on the person over what their onset latency is. And that will give you a number, and every lab will have different normative values. I make a note to mention that when you have someone complaining of, for example, like pain from a herniated disc, you anticipate that your SNAPs part of the test will be normal, because the lesion is distal, lesion is proximal to the dorsal root ganglion because of how it lies within the spinal cord. And as a result of that, you're going to have a preserved connection, and you're going to be able to propagate the signal and have a normal conduction velocity and normal amplitude. And again, that's why you can create the sensory symptoms without having any effect on your sensory nerve conduction study. Below is what a postganglionic lesion would look like. And again, you're going to see changes in your testing, in the motor part of your testing because of that, because the signal is not going through. Technical considerations are very important when you're doing your sensory nerve conduction studies. I found that a lot of people performing this test don't take maintaining a person's temperature very seriously. For every degree drop in Celsius of a patient's body temperature, you can also have a false decrease in the conduction velocity, and you can also have, as a result, a false increase in the amplitude. Another thing and again, the thought behind that is because they're farther from the heart. Another thing to take into consideration is age, and those numbers can sometimes also vary in the very old and the very young. So how do I formulate my sensory studies? I will essentially, in the lower extremity, will do a sural nerve, a superficial perineal nerve, and after talking to the patient, if I suspect the patient might have a plexopathy, I will add this saphenous. Routine sensory nerve studies, SNAPs that I do in the upper extremity are the median ulnar and the radial nerve, and then I tailor it further based on what I think the patient has. So if I think that they have a lesion of the ulnar nerve, I'll add on the dorsal ulnar nerve, because that will help me tell me if the lesion is at the elbow or if it's at the wrist. And again, if I'm worried about a plexopathy, a lower trunk, I'll add on the medial antebrachial cutaneous nerve, and for an upper trunk, I will add on the lateral. So you add these to your testing to further kind of tailor down what the patient has. I'm moving on to what the CMAPs, or your compound muscle action potentials, look like, and that's the motor part of the motor nerve conduction studies. This is stimulating in a distal site versus, and then a proximal site, because you need the two stimulation sites in order to calculate a conduction velocity. And again, you're looking at the latency, which, remember, the latency is the time it takes from stimulus until you go through the neuromuscular junction and you depolarize the muscle. And we're looking at the amplitude, which I'm going to mention as well, which is very important. And that's your distance from your baseline to your negative peak. The duration, which is this area under here, is essentially a measure of the synchronicity of the fibers. And that's important when you're looking at a patient that you might suspect has a conduction block for whatever pathology behind that. And then you're going to make your calculation in order to obtain the conduction velocity. And again, they show the speed of the fastest fibers only. These are the routine motor studies that I'll do in the upper extremity. I record from the abductor pollicis brevis, and I typically stimulate in the wrist and in the antecubital fossa. And then for the ulnar nerve, I will record from the abductor digiti minimi muscle, and I will stimulate at the wrist above and below the. If I think a patient has an ulnar neuropathy, I'll take it one step further and I'll do an inching study across the elbow, where I will have usually predetermined distances and stimulate each section across that and look at the changes in the velocity between those segments. And again, in the lower extremity, I'm looking at the perineal nerve, and I am recording usually from the extensor digitorum brevis muscle, and I'll stim at the head and then again at the popliteal fossa, which is painful. And the same thing with the tibial nerve. I'll record from the abductor hallucis, and I will record at the medial malleolus and at the popliteal fossa. If for whatever reason I have a low amplitude according to the normative studies, when I record from the extensor digitorum brevis, I'll also add on another more proximal site, and I will record from the tibialis anterior muscle. Sometimes in older patients, you'll see that you have decreased amplitudes, and they're essentially from disuse, from, if you're, or the older, if in females, it's very common because of the type of shoes to have some decrease in that muscle as well. So how do we apply this clinically? So in an axonal neuropathy, I would anticipate to have the amplitudes of both my sensory and my motor nerve conduction studies to be smaller because of axonal loss. And I would anticipate my conduction velocities to be normal because, remember, the fastest axons are preserved. But if I'm talking to the patient and I think they have a demyelinating neuropathy, so those are your Guillain-Barrés, your CIDPs, for example, then you'll start to see different changes, and you'll see decrease in the conduction velocity because they're demyelinating lesions. And you'll sometimes see temporal dispersion, which is this picture over here, which is why I said that the duration is important, because when you have a conduction block, you have even more increased asynchrony, and then that adds to the drop in the amplitudes between the sites of stimulation. If I do think someone has a IDP or a CIDP, I will stimulate even more proximally, and I'll go up to Erb's point as well. So I'm going to move on to electromyography. It again is viewed as an extension of the neurology exam, and I always say you perform it after the nerve conduction studies, and you tailor your EMG based on what the patient's complaining of, what you saw in examination, and what you found on the nerve conduction study as well. That kind of helps you decide what you're going to add and what you're not going to add, and further kind of hones down on what you think your differential is. A note about timing: you don't necessarily have to delay it, but the general rule is you should usually do EMG about 2 to 3 weeks after the onset of symptoms. Any form of denervation is a lower motor neuron problem, and we're going to talk about that in a little bit. And again, the only time that you really want to wait is for an acute radiculopathy. You want to give that a little bit of time to develop some denervation. So again, in the nerve conduction studies, acutely, you'll see the normal conduction because you haven't had this Wallerian degeneration occur. And as time goes on, and in a complete lesion, you'll typically get no response. And in partial lesions, you'll see those amplitude changes, which I mentioned earlier. And with an EMG acutely, you'll have a normal EMG. Subacutely, you'll have increased insertional activity, and subacute, you'll have spontaneous activity, which I'll show you. The elements of a successful exam are to get a patient's attention and trust. I spend the majority of the time before I do my test explaining what I'm doing, why I'm doing, how it's going to help us, explain that it's going to be painful, let them know that they're in control and they can tell me to stop, and I'll reposition the needle. And what I do is I do a dry run of the targeted muscle activation before I put the needle in, because I find that it really helps your exam go even faster. Because once patients have a needle in their muscle and you tell them to, bend at the elbow, it's very confusing when the needle's in there. So it's better to have them practice the movement before you actually go ahead and do the test. So I usually have my display. I'll look at the EMG in 3 different displays, and I'll usually put it on 50 microvolts per division to look at the resting activity, which I'll show you. I then change it to 200 to look at the actual motor unit, and I'll have them give me not at full strength, but gently activate so I can look at those motor units, and then I will look at the interference and recruitment pattern when they have maximal contraction, and I put that usually on 1 millivolt. Needle types, I guess, depending on your background and your training and where you trained, you're usually swayed as to which needle to use, but there are 2 types, the concentric and the monopolar needle. Your concentric needle, these are the gauges, they're hollow needles, they have a bevel tip, there's a wire going down. They produce this oval recording surface, and you're going to reference the needle to you'll put a ground distal to where you're placing where you're inserting the needle to kind of cancel the noise. They have a smaller recording area as a result of the oval recording surface. I personally think they're better at quantifying your quantitative values of your EMG, but it can sometimes, when compared to the recordings from a monopolar needle, might show you smaller amplitude and duration of the motor units. Monopolar needle, they're Teflon coated. These are the different gauges that you can have, and the active recording tip is referenced to a separate surface electrode. They can, as a result, you have, because of the tip, you have a larger recording area, but you have more noise. And as a result of that, you might not be able to do your quantitative calculations as well, and you have changes to the duration and amplitude of your motor units. There are arguments about monopolar versus concentric. Some might say the monopolars are smaller diameters and they're thought to make smaller skin punctures and there's less pain, but you need this reference surface electrode, and then where you put it is important. It helps, the distance between the active is important, and it can have a complicated wire complexity movement, and it can be difficult for the patient. So I use concentric needles in my practice. So the goal of needle insertion is to put it where it's the least amount of discomfort. So with your large muscles, you really want to pierce the skin perpendicular. With smaller ones, you want to penetrate them at a 30 to 45 degree angle. And you should always check how you're orienting your needle. So again, the goal of assessment is to look for insertional activity. You want to look at spontaneous firing at rest, and then you want to look at the voluntary muscle contraction. And you're looking at the units and the patterns. So when you first put the needle in, this is what subcutaneous penetration sounds like. It sounds like a hissing noise. That's all that you should hear. That's how you know that you're in the subcutaneous area. And then as you move the needle more through the skin, you'll hear something more crisper, high-pitched, and you use that noise to help tell you if you're close or far away from the muscle that you're trying to get. So this is what an initial needle insertion would sound like. So you hear that crisp piercing of the membrane. The noise in the background tells you that the needle has moved towards. We're going to briefly talk about insertional activity. this is what normal insertional activity looks like in a healthy muscle. You're piercing the muscle membrane, it's high pitch and crisp, and then you hear essentially nothing. So the most common things that we see in my practice are CRDs, complex repetitive discharges, which are spontaneous depolarization of muscle fibers, and then they spread to the nearby muscle fibers. They are regular. They sound like it sounds like a jackhammer, and it's very characteristic to have an acute onset and offset. So this is what a CRD sounds like. And again, you can see CRDs in neurogenic etiology of issues as well as in myopathic processes. Fibrillation and positive sharp waves are the most, I guess, commonly seen type of abnormal activity. They are action potentials of the single motor fibers that are firing spontaneously. The fibs and positive sharp waves have the different morphology that they have because of where you are eliciting them in relation to where the needle is, but they're essentially the same thing. Sounds like crackling. And so the patient's not moving when this is happening. This happens when you first insert it, so it's just firing on itself. It's not supposed to be firing. Here's another abnormal insertional activity. And that thing that just popped out was that's a stick. And the fasciculation is a randomly discharging motor unit, and it can be generated anywhere from the anterior horn cells all the way down to the nerve. And again, you can see CRDs in both myopathic and neurogenic processes, and you can see them normal. A patient might come to you because they're twitching, and they might think that they have ALS, and you elicit your history, and they're full strength. They don't have any dysphagia dysarthria. There's no red flags in the history. Their exam is normal. There's no weakness. And then, ultimately you might diagnose them with something simple like cramp fasciculation syndrome, for example. So that's why the history, talking to the patient, examining the patient is so important when you're doing these studies and interpreting these studies. So what are your motor units? This is what a voluntary motor unit potential looks like, and I'll show you that briefly. But it's essentially the electrical response that you're recording when you put the needle in from the group of muscle fibers that you're sampling that are innervated by a single anterior horn cell. They come in, and again, when you're trying to analyze this on the screen, you're going to take notice of the duration, which is it's the area of the muscle fibers in the unit. You're going to look at the amplitude, which is how large the response is, and then you're going to look at the phases, and that's the number of times that it crosses baseline. This is just a little schematic showing you this is what a voluntary motor unit potential should look like. So this is what it looks like in a patient who has no complaints and nothing wrong with them. Figure B, this is polyphasic, so you see how many times it crosses the baseline. You would typically see polyphasia in something that's reinnervating. Figure C shows you a motor unit that has a large amplitude and a long duration. You will see that in someone that has a chronic, long-standing neurogenic lesion. So like you can see that in a chronic radiculopathy, for example. And figure D, you see a response that's very small amplitude and many extremely polyphasic. You'll typically see that in myopathy. So this is what a myopathic motor unit looks like. So it's early recruitment. It's a lot of firing. The amplitude is very small. And when you put the needle in, you'll sometimes have this, the patient will barely, move the muscle itself. And the reason that you see this in myopathy is a loss of the muscle fibers from whatever is causing the myopathy. So you lose these muscle fibers, and as a result, you need a lower force to generate this contraction. This is what a neurogenic motor, and like interpreting EMG is pattern. So the more you do, the more comfortable you are at hearing. So obviously the amplitude is large, and you hear the distance. There's a loss between the next recruitment pattern. So again, I mentioned recruitment pattern. It's the relationship between the number of motor units you've activated and the firing rate to the relative force of muscle contraction. So that's why with myopathy, you'll have early recruitment because you have this loss of the muscle fibers. So you have more activated for a relatively low force of contraction, and the opposite goes for neurogenic motor units. This is just a note quickly about recruitment patterns. What the typical number is, you put them on the screen, you can count them out. Reduced recruitment you will see in neuropathic processes. And again, you're generating fewer motor units with increasing force of contraction. Early recruitment you'll see in myopathies, and you'll get a large number of motor units with minimal patient effort. So here is just normal recruitment pattern. This is early recruitment pattern again, which you'll see in myopathy. Fast firing. And again, I just make a point to note radiculopathy, the most common reason for referral to an EMG lab, you're looking for myotomal patterns of abnormalities. So if you're being referred to a patient for radiculopathy, you're going to anticipate that your sensory nerves, your nerve conduction studies will be normal. And then you're really going to have to tailor your electromyography, and you look for myotomal pattern of abnormalities. I look for denervation, renervation, and at least two muscles innervated by the same nerve root. And again, if they have mild radiculopathy, sometimes you'll have a totally normal EMG. And this is just an example of kind of my routine screen. The way I do my EMGs, I will, no matter what the presenting complaint is, I will cover essentially C5 to T1, and then I will add or subtract a muscle based on what my differential was. For the legs, I will record these muscles over here, which gives me an idea of L2 to S1, and then if I think the patient has a radiculopathy, I'll sample a paraspinal. If I think the patient, and again, this is what my add-on muscles, I sort of call them. So when I think that they have a C5, in addition to my routine screen, I'll add these. And this is just by myotomal, what I typically will add to help me rule something in or rule something out. That's it.
Thank you. Good morning, everyone. My name is Hiroshi. I'm a physical therapist at the NYU Langone Orthopedics Center, and I'm presenting today as use of modern pain theory in the management of patients with low back pain. And I have no disclosure, and this is the learning objective for today's presentation. Now, since I'm talking about pain today, I'd like to share the pain definition first so we can all be on the same page. So the International Association for the Study of Pain published the new pain definitions in 2020, and this is a definition. And the pain is defined as unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, this definition has many nuances, doesn't it? But the part that I like to emphasize is that pain is a sensory and emotional experience, and it may be associated with actual or potential tissue damage. So this definition makes it clear that pain is no longer just a sense, and also maybe associated with potential tissue damage. Now, this definition also came as additional notes to supplement the definition, and the first four notes are particularly important for my presentation, so I'm going to go over. One, the pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in the sensory neurons, and through their life experiences, individuals learn the concept of pain. So now, when I'm talking about pain in this lecture, I'm talking about multidimensional human experience rather than just a sensory perceptual experience. So now let's look at some pain theories that inform the new pain definitions. Now, this slide describes the general development of pain theories from Descartes' philosophy to the neuromatrix pain theory. Now, probably most of you are familiar with the gate control theory, which was proposed by Dr. Ronald Melzer and Dr. Patrick Wall in 1965. Up until this point, all the existing pain theory was a peripheral tissue-based theory, meaning that the nociception was presumed to be a precursor to the pain perception. Gate control theory offered the mechanism by which pain can be modulated. Still, but this theory needed a nociception before pain can be perceived. And for centuries, the nociception was believed to be equal to the pain. Now, this belief was problematic and obviously failed to explain the condition such as phantom limb pain syndrome and also the severe pain often reported by the patient with spinal cord injury patient for the quite obvious reason. So after having done a detailed analysis of a phantom limb pain syndrome, Dr. Ronald Melzer proposed the pain neuromatrix theory, and he put the brain in the forefront of pain research. And he also gave a new meaning to the pain. And this is his quote. And he says, when we respond to pain, we respond to an experience that has a sensory qualities, effect, and a meaning as a dangerous or potentially dangerous event to the body. So he viewed the pain as a dangerous signal to which a wide range of psychological and physiological responses will be initiated to protect the body from actual harm or the potential harm. So now I don't have enough time to go over the neuromatrix theory in details, but I try my best to sort of discuss the key elements in this history. So now we're going to start from the body self-matrix. Now, since the patient with phantom limb pain syndrome felt their amputated limb so real, the Dr. Melzer postulated that there must be a perceptual representation of the body in the brain, and he called it body self-neuromatrix. So the body self-neuromatrix is a wide network of neurons and it comprises mainly of three networks: cognitive, sensory, and affective networks. And in response to an injury or an event that threatens the body, the neuromatrix received all the inputs from all the networks, and I praise them to ask this simple question: how dangerous is it? And depending on assessment of the danger, a number of responses or outputs that he called may be produced. And the pain perception is one of the outputs from the neuromatrix, and other outputs include action program, and that represents the behavioral response to the threatening event, as well as the stress regulation system. This represents more of a physiological response to such an event. Okay, and the outputs in turn affect the inputs. And if this cyclical process eventually reaches the formation of what Dr. Melzer called neurosignature. Now, once neurosignature is formed within the neuromatrix, now all the input signals are processed through the neurosignatures, producing a predictable pattern of responses. Which really means the pattern of response to the event can become more chronic, if you will. Now, this neurosignature is actually an important concept for the pain management I'll discuss later on, so I'll come back to it later. So the question is that which brain regions form the neuromatrix? And this systematic review by Abkarian et al. Found that the 6 brain regions, as shown in this slide, were consistently identified across the pain studies using advanced neuroimaging. Many other brain regions are also observed during pain experiments, but their importance seems to depend on the study setting, subject, and types of pain studied. And this review also identified the connectivity or the network of brain regions activated for distinctive inputs. The anterior cingulate cortex and the prefrontal cortex were highly involved in cognitive inputs such as memories and past experiences and attention, so they were called cognitive network. Similarly, the sensory network is comprised of thalamus, primary and secondary somatosensory cortex, and the affective network include the thalamus, insular cortex, and anterior cingulate cortex. So these brain regions are considered to form the neuromatrix for pain experience. So now when we talk about pain management, we really should be talking about all the outputs, not just the pain perception. But today I'll focus on the pain perception, and we'll discuss how the new scientific discoveries led to the new pain management approach for patients with lower back pain. And this is a comprehensive review by Ziegel et al. And they systematically reviewed all the available literature investigating the brain activation patterns during the pain experiments. And they concluded that the most notable cortical changes in activities occurred in the gray matter of the neurons in the cognitive and affective networks, as shown in this slide. Now, while sensory network remained relatively stable over time, and this is regardless of the chronicity of pain. So that these two networks are considered an important brain regions for the pain perception. This review findings also support the notion that the pain is an emotional and a cognitive experience rather than a simple sensory experience. And interesting to note is that the many brain regions in these networks also involve the general learning process. Now, if you recall from the previous slides, one of the additional notes says that through their life experience, individuals learn the concept of pain. So the key message here is that the learning is a powerful process for the pain experience, and a maladaptive learning is likely involved in persistent pain and pain-related disabilities. So the neuroplastic changes that occurs in cognitive and affective network and also may be a driver to persistent pain and disability. So now all this kind of sets a nice stage to introduce the pain education. Now this pain education is a new educational intervention technique based on the modern pain theory. And this pain education is known in several different names, or the brands, if you will. But regardless of which system you use, the core objective of the pain education is to shift one's conceptualization of pain from that of a marker of a tissue damage to that of a marker of perceived need to protect the body tissue. So the primary goal of the pain education is to address pain-related psychological distress and a maladaptive belief by providing more evidence-informed neurobiology of pain. Now, regardless of a teaching system that you subscribe to, most of the key concepts are the same. They are pretty consistent with the pain definition and accompanying notes that I reviewed already, so I'm not going through all of them. You might also see that the neurometrics theory gave the theoretical foundation for the pain education. Now, let's look at the evidence on the pain education. Now, this system review included the 12 RCTs, and the result demonstrated that the pain education had a clinically meaningful effect in the kinesiophobia in short term, and the pain catastrophizing in midterm. But the pain education was found to have no clinically meaningful effect on the pain intensity and disability. And clinically meaningful effect in the pain and disability was reported only in studies that combine the pain education and exercise-based interventions. So the pain education alone doesn't seem to be effective in mitigating the pain and the pain-related disabilities. But in reality, the pain education should go beyond those key concepts because there are many examples in our daily practice that should be a part of pain education. And I think this is a good time to bring back the concept of neurosignatures. So I think it is more meaningful to conceptualize the pain education as an intervention aimed at minimizing the influence of danger neurosignatures and maximize the influence of safety neurosignatures, because it's that delicate balance between the two opposing neurosignatures that will determine the pain experience as well as pain-related disabilities. So then what contributes to the formation of safety and the danger neurosignatures? Now, this discussion is more based on the clinical observation and expert opinions, not exactly the evidence base, so please keep that in mind. So the new safety neurosignatures are formed by concepts or the belief that is fear and anxiety associated with pain experience, and they often lead to active coping strategy. For example, understanding pain as a biopsychosocial experience should ease fear and anxiety associated with pain experience. And not all pain is a marker of a tissue anomaly and needs to be avoided or feared for. And motion is lotion. It's a very simple analogy, but can be very powerful in removing the fear or anxiety associated with painful movements or any movements perceived to be harmful by the patient. Now, I cannot emphasize enough that the importance of the movement on the human physiology and the nervous system. And in many cases, the movement doesn't have to be specific, as we often believe it to be. Now, biopsychosocial approach to patient management encourages patients' participation in medical care and facilitates self-management, and the patients are more likely to adopt active coping strategy when they feel empowered. On the other hand, the danger neurosignatures are formed by concepts or beliefs that promotes fear, anxiety, and helplessness. For example, the belief that pain is a sign of tissue damage is not only obsolete, but also leads to fear and avoidance of activities associated with painful experience. Now, biomedical or biomechanical model often fails to give a full account of patients' experience of pain and associated behaviors, yet we still heavily rely on the concepts to guide our treatment. For example, asymmetry in our body is a rule rather than an exception. Many abnormal imaging findings are fairly common among the asymptomatic populations, yet we strive to achieve or educate a patient to correct the asymmetry or imaging abnormalities. Like concept like out of alignment, slip disc, pinched nerve, spinal instabilities are examples of biomedical or biomechanical jargons and concepts, and often used in clinical practice without clear meaning and definitions. And what we should be aware of is that these biomechanical concepts can be fear-provoking and often leave patients feeling helpless, and encourage dependence on the healthcare professional to fix my problem. And that often leads to a passive coping strategy. So I conceptualize pain education as planting as much safety seeds as possible and let them blossom while removing as much danger weeds as possible. And there's plenty of opportunity to do that in our daily practice. Again, the neuroplasticity is a powerful process and it very likely influence the outcome of physical rehabilitation. I think we just have to embrace it. Now, in summary, I'd like to present this quote from renowned pain researcher, Dr. Rheumatic Diseases. Pain is a biopsychosocial experience and it requires a biopsychosocial approach to treat the pain problem. And I think this quote sums up my presentation very well. And I think it's a time for us to rethink about pain and embrace the biopsychosocial approach to managing the patient's low back pain. Thank you.
Good morning. Thank you for having me. Today I'll be discussing the medical management of spinal disorders. I have no relevant disclosures to this talk. Prior to the pandemic, we did see, and we're concerned about the opioid epidemic. Prior to the pandemic, pardon me, just getting over a cold, there were a lot of articles that actually focused on perhaps physician missteps. And it's disconcerting, especially for us as providers who are trying to help our patients, that there are people that could take this path. And then it really, raises the concern on our end, how can we best manage patients with medical therapies? But it actually got worse, a little worse after the pandemic. There were an increase in overdose deaths. And it was actually prior to that decreasing to a degree. There was a small drop, but after the pandemic, it did rise. And there are several reasons for this, many of which I think, in terms of access to care, access to providers during the pandemic were difficult for some patients, the isolation, the mental health issues associated with that. But in addition to that, governmental agencies have also brought up the problem with illicit fentanyl use. So this is getting worse, and you have to understand that in the illicit drug trade, fentanyl is beneficial to those that are on the wrong side of things because it's dosed in micrograms. So large quantities of this medication can actually be transported in very small packages. So that's an unfortunate circumstance, but is one that we are now dealing with, unfortunately. So today we'll talk about the pharmacologic management of pain related to spinal disorders. It is quite expansive. I will focus on some of the major topics and major therapies for review, and try to focus on, if we're going to provide opioid analgesics, how can we safely do so, and how should we do so? I like this quote because, as you've probably heard already, a lot of us are going to experience pain, especially back or neck pain at some point in our lives. But what this does infer is that there is an individual component, suffering, and even in the definition of pain, as we saw just in the previous presentation, that there is a sensory and emotional experience associated with the presentation of pain. As practitioners, it is up to us to really identify if there's a strong emotional component to a patient's presentation, because that's really going to dictate how you're going to provide medical therapies. There are certain medical therapies that you may avoid, such as opioids, as they can have, an anxiolytic effect, and it may result in more of a misuse than an actual use or appropriate use for that medication. The concept of multimodal analgesia is supported by many national and international pain societies, and really it's a combination of everything that we have at our disposal, the physical, cognitive therapies, pharmacotherapy, as well as interventions, to try to target different mechanisms of pain to have a better overall outcome. So when it comes to medications, that's what multimodal analgesia allows us. Hopefully, an improvement mostly in looking at function, analgesia, safety, hopefully using smaller doses of different medications reduces the adverse effect burden because you're not reaching ceiling doses or maximal doses. And of course, we always are balancing issues of abuse and diversion and misuse. Tylenol, or I should say acetaminophen, and anti-inflammatories, they are recommended in the treatment of acute and subacute, as even chronic back pain protocols. NSAIDs can certainly help reduce both pain and stability for patients of spinal origin. Unfortunately, individually, the effect may be small. I think the important thing to understand is there is inter-individual variability when it comes to analgesics, especially anti-inflammatories, even when it comes to opioid analgesics. So it may not be a failure of one therapy. You may need to try an alternative anti-inflammatory medication to find the one that works best for that patient. The diagram to the right here is important because while certain medications have been removed from the market, those that have significant effects at limiting gastric distress, there are some that are still available that were not necessarily designed or classified in that COX-2 category, but do have more COX-2 activity, so may provide some gastric benefits for your patients. NSAIDs are not without adverse effect, of course, and we are all aware of this. I think we're all aware of the major complications that can be associated with these medications. The biggest thing to understand is that a patient with multiple comorbidities is at a greater risk of these significant adverse effects than perhaps a young, healthy person with limited comorbidities. I think the biggest one that we should all be concerned about and really watch and monitor are the cardiac effects or cardiovascular effects. And the most recent FDA warning really summarizes it for us that NSAIDs can increase the risk of heart attack or stroke in patients with or without heart disease, or even risk factors for heart disease. And it can actually happen within the initial treatment plan, within the initial treatment or initiation of the medication, within the first week or two. It doesn't have to be months down the road, so you really do have to monitor your patients and follow up frequently. And it's not just, it was brought to our attention mainly through to the studies on the COX-2 medications, but it happens with other medications that are not specifically classified as COX-2, but have more COX-2 activity. So we do have to be aware of these effects. Skeletal muscle relaxants, there's evidence for both short-term and long-term use. I always recommend considering the individual mechanism of the medications. For the vast majority, they're considered CNS depressants overall, but certain medications such as tizanidine have central alpha-2 agonist effects, which can also affect some neuropathic pain control as well. The issues you also have to be aware of are the potential adverse effects. So medications like tizanidine can cause some relative hypotension based on its mechanism of action. And overall, they are just sedating as well. So when you're combining them with other medications, you do have to be careful. We often don't recommend the concomitant prescriptions of benzodiazepines with opioids, and the reason being that the risk of overdose significantly increases when you're combining those two medications together. So the purple line shows you that just benzodiazepines alone doesn't result in significant overdose, but when you combine those with opioids over time, certainly increases the risk. These are just good summary slides. You have access to these. I'll just have you refer to these just for overall recommendations for the different classes of medications in terms of the recommendations currently in both non-specific neck and back pain as well as chronic neck and back pain. I don't know if anybody saw a recent Hulu mini-series, docu-series called, remind me of the name, but Dope Sick. So this actually article was really brought to light. It's really not an article. It's just a small letter to the editor where they said they looked at many over 11,000 hospital charts, and they felt that addiction was pretty much rare in patients that they reviewed, in the charts that they reviewed. It was not a randomized, controlled trial over a period of time. It was really just a retrospective review. And that's really what brought pain, or started bringing pain back into the forefront and management of pain into the forefront. And then you have in the early 1990s or 1992, JCO reported pain as a fifth vital sign, bringing more attention. And then, of course, as we all know, OxyContin was marketed in the mid-90s, and you see that vast increase in use of these medications. And now we're starting to come down as we are aware of this opioid epidemic. Because of that, because we are cutting back and being more conscientious about our prescribing habits, we are seeing an increased issue with opioid-related deaths due to illicit medications, specifically heroin and the synthetic opioids, as we discussed, like this illicit fentanyl trade. As it stands now, evidence is scant and inconclusive for the use of opioids for neck and back pain. Most of the studies that have been done in the past are short, weeks to just a few months. And they really haven't followed them out. A lot of people have dropped out due to adverse effects, which we are all aware of with these medications. So it begs the question, is there any more long-term data for the use of opioids? So this study came out in 2018 through JAMA, and they did look at the effect of opioids versus non-opioid medications as it related to pain-related function. So they really looked at function in patients with chronic back or hip or knee osteoarthritis pain. And basically the conclusion was that treatments with opioids was not superior with non-opioid medications for improving pain-related function over 12 months. As we know, function is becoming more of the buzzword rather than relying on verbal report, which is very subjective. So to their conclusion, results did not support the initiation of opioid therapy for moderate to severe chronic back or hip or knee osteoarthritis pain. So this is we consider this long-term data. This is 1 year. As we all know, we see patients that are on opioids and pain medications 3, 5, 10 plus years. So unfortunately, we just don't have that data. If you're going to consider using medications, we do want to help our patients. We do want to make them feel better. Always important to familiarize yourself with the CDC guidelines. I do have a great summary slide of the major take-home points related to the CDC guidelines. Most importantly, I think noting the relative morphine milligram equivalents that you should be aware of when you're prescribing your medications that you should avoid or justify the use of when you're getting to certain levels. I think the CDC may at some point change those guidelines. and eliminate those specific dosages, but it's still important to keep in mind. Obviously, it can result in some unnecessary scrutiny when they do start putting forth these sort of morphine milligram equivalent guidelines. Not every opioid is the same in that there are some that are more potent than others. And this is a great reference just to understand that 10 milligrams of morphine is not 10 milligrams of oxycodone. And we should familiarize ourselves with this so that we understand in terms of the morphine milligram equivalents that we are prescribing our patients, because it may be easier to hit those levels, especially when you're prescribing medications like oxycodone or hydromorphone. If we're going to prescribe, we certainly need to be aware of the potential adverse effects. I think when it comes to the long-term prescription of these medications, if some of you do that, that it is important to understand these, because the risks may potentially outweigh the benefits for continuing the prescription of these medications, especially when you look at the long-term effects when it relates to the endocrine function of individual patients, both male and female, as well as the potential for hyperalgesia, just sensitizing patients to more pain by the continued prescription of these medications. Additional consideration should be given to the potential complications, but based on medical comorbidity. And so this has been put forth by the Joint Commission, and it's good to familiarize yourself with this. Actually, in the institution, when prescribers are considering using these medications, we do make these available so that they can review and be familiar with that, because multiple comorbidities can certainly predispose someone to significant adverse effects when prescribing opioids. How can you best protect yourself and the patient when it comes to prescribing these medications? Well, using risk assessment tools. One simple tool is the opioid risk tool, easy to administer, and can be helpful in terms of your medical decision making, whether you're going to utilize opioid analgesics. Treatment agreements, they're often referred to as contracts. They're not contracts, but it does allow for documentation of what you can expect from the patient if you're going to prescribe and what they can certainly expect from you as the prescriber. Urine drug screening is important to incorporate into your practice. I certainly will advise monitoring of the state prescription drug monitoring programs, incorporating that data into your documentation, and obviously doing these things, educating ourselves, and of course educating our patients about these medications. Most times I think patients are now very familiar. There's been certainly quite a lot of media attention to the opioid epidemic, and they are also very aware of these issues. And of course, we're focusing on function and not so much verbal report, and consider opioid rotation. So in summary, chronic opioid therapy is not necessarily indicated for chronic low back pain. We really want to figure out how we can help our patients take more autonomy and maybe be more an active participant in their recovery rather than just relying on medications, of course. We can manage expectations, but focusing on function, as we discussed, keep the doses, the pill counts low, and always try to use short duration, especially if you're using opioids. We will always wean and taper and not detox, because we are not detox practitioners. So keep that in mind. If you're taking someone off opioids, you can comment on the fact that you're weaning or tapering off opioids and not detoxing. Opioid agreements are important. Combination of NSAIDs and acetaminophen, they can seem to work better, and in certain post-op data, the combination seems to work better than individual medications like just acetaminophen or just an NSAID. And of course, always keeping that concept of multimodal analgesia and combining therapies with smaller doses to have a better effect and hopefully less adverse effect. Thank you very much.
So a few years ago, I had an 80-year-old female come to see me in the pain clinic, and she was suffering from neuropathic leg pain secondary to a spine issue. She was getting prescribed increasing doses of opioids, and she was starting to have side effects. She was getting a little constipated. She had pruritus at times, and she was referred to me for an epidural steroid injection. The problem was she was on anticoagulation. So she could not have any sort of injection for the next 6 months. She asked me at that time, which was a couple of years ago, what do I know about medical marijuana? So I started to think, how many lectures did I have in medical school and residency and fellowship on medical marijuana? And the answer was 0. So I unfortunately had to tell her that I didn't know, I wasn't sure. So she left the clinic that day. She came back to me 6 months later and came back for her epidural at that time. And she was now on medical marijuana and off all of her opioids. So medical marijuana not only helped her with her pain, but it also allowed her to gain control back of her life by getting her off the opioids. Medical marijuana can help restore power, autonomy, and control back for patients that are suffering from pain. So I want to thank the course directors for their invitation, the digital team and the NYU CME team, and finally you all sitting here. It's hard enough to pay attention while you're here, but I imagine there's people virtually also logged in. So thank you for paying attention. Quickly, my academic background, I did my undergrad and my master's in public health at Johns Hopkins. I went to medical school here at NYU. I did my residency in anesthesiology, fellowship in interventional pain, also at NYU, and another master's in clinical research at NYU. My non-traditional background, I have a license in medical acupuncture from Harvard. I have a 500-hour yoga teacher training certification from Kripalu, which is an ashram up in the Berkshire Mountains. I've studied sound meditation with an ethnomusicologist, and I spent a year certifying in psychedelic therapy at the California Institute of Integral Studies. Related to that, I actually want to start by making a bold prediction. I think that within the next year or two, MDMA will get FDA approval for the treatment of PTSD. And in a few years, I think that this course may actually feature a talk on the pain-relieving properties of not only medical marijuana, but also of psychedelics. There's some early research that suggests there could be an anti-inflammatory role to microdosing some of those compounds. What do? I work here at NYU at the Center for the Study and Treatment of Pain. I'm on faculty here, and I mainly perform spinal injections and some minimally invasive procedures like radiofrequency ablations and spinal cord stimulation. So, as we're climbing out of the most recent crisis, which is the pandemic, we remain in another crisis, which is the opioid crisis. Prior to the pandemic, about 115 people were dying every single day from an opioid overdose in the United States. And we've talked already this morning about how those estimates have actually gone up during the pandemic. In 2017, about 2,000 people died from an opioid overdose in the state of New York. During the pandemic, that number jumped up to over 3,000. In 2017, approximately 47,000 people died of an opioid overdose in the United States. In 2020, that number jumped to over 68,000 people. The CDC now estimates that there's over 3 million people that are diagnosed with either an opioid use disorder or are just addicted to opioids. Things have gotten so bad that it's actually dragging down the life expectancy in this country, and that hasn't happened since the 1960s. In the summer of 2018, New York State took a really drastic step to address this problem. Back then, they decided effective immediately, they were going to allow all doctors to prescribe medical marijuana as a replacement for opioids. So this move basically allowed for any patient with severe pain that did not meet the criteria or definition for chronic pain to use medical marijuana instead of an opioid. It even included post-op surgical patients in their criteria. The latest update to this is that early 2022, New York State actually expanded the medical marijuana eligibility criteria to include any diagnosis deemed appropriate by a certifying healthcare practitioner. So Pandora's box is fully wide open. And the question is, can medical marijuana cure pain? Well, we have old studies from over 10 years ago that say, yes, it can. What about the newer studies? This is a 2015 meta-analysis from a Canadian journal that also says, yes, medical marijuana can control pain. More recently, this is a 2021 meta-analysis from the British Medical Journal, also said yes. Now, despite some positive studies, and despite legalization of recreational marijuana across many states in this country, many researchers are actually saying, whoa, let's pump the brakes here for a second. I think we need a little bit more research. And they're not wrong. Shown here are two recent studies that actually question the use of medical marijuana for certain chronic pain conditions. There are even some examples of medical marijuana actually worsening pain. This was shown in a study that used an experimental model of pain, and they tested this in 23 healthy volunteers. Now, despite these questions that are being brought up, pain remains the #1 diagnosis for medical marijuana treatment. Patients are saying it helps. States across the United States are continuing to legalize it. Currently in New York State, there are over 150,000 registered patients. There are over 2,000 registered prescribers. And as medical marijuana treatment becomes more widely accepted and more widely used, I think the question becomes, what type of pain patients can actually be helped? To figure that out, there's two ways that we can study this. One is to study it in actual patients with various chronic pain conditions. The issue with that is that you have to solve for covariant confounding factors. So the other way to study it, the second way, is that you can study it in experimental models of pain using healthy adult volunteers. Essentially, you recreate pain in an experimental model, you give medical marijuana, you test the results. This was recently published in JAMA. This is a systematic review and a meta-analysis of 18 placebo-controlled studies. They studied the effects of medical marijuana on experimentally created pain in healthy volunteers. What did they find? One, medical marijuana produced a small increase in the pain threshold. Two, medical marijuana is not associated with reduced intensity of ongoing experimental pain. That suggests that once someone is in pain, medical marijuana does not reduce the pain. Three, medical marijuana is associated with decreased perceived unpleasantness of ongoing experimental pain. That suggests that it's likely working at the affective component of pain. Four, medical marijuana is not associated with a decrease in mechanical hyperalgesia. Therefore, we can state that it's not associated with the process of central sensitization. So that's what the experimental pain studies are showing us. Clinical studies with actual patients that are experiencing pain, those tell us that neuropathic pain is the primary type of pain for which moderate evidence exists supporting the use of medical marijuana. So if we combine the findings of the experimental pain studies and the clinical pain studies, what do we get? We can say that medical marijuana helps with neuropathic pain, not by treating or affecting the actual pain, but rather by decreasing the unpleasantness of the neuropathic pain experience. So if you're going to see a patient, you're going to counsel a patient about medical marijuana, what could you say to them? Specifically, you want to be talking about neuropathic pain. This can help you with your neuropathic pain. It's not going to cure your pain, but rather it might make your pain less bothersome and less disruptive to your mood. Overall, the development of medical marijuana as a treatment is pretty exciting. It's exciting to doctors and physicians and clinicians because it gives us a new tool. It's exciting to patients because it allows them to take back control over some of their health care. And to understand this concept, you need to understand how medical marijuana treatment is administered. And it's actually administered in a very different way than most treatments that spine patients are getting. If you're a spine patient, you need a surgery, who do you go see? You go see a surgeon. The surgeon decides how many levels are they going to fuse, what types of screws are they going to use, what hardware are they going to put in. If you need an injection, you go to an interventionalist, you go to a pain doctor. They decide, you're going to do you're going to get a transforaminal injection or interlaminar injection. They decide whether you're going to get a particulate steroid or some type of non-particulate steroid in your injection. Let's say you need a medication. Now you need to go to a prescribing clinician. They're going to decide that you need gabapentin at X milligrams, Y times per day, and they're going to hand you the prescription. Medical marijuana is completely different. To illustrate that, let's consider how a patient gets medical marijuana treatment. It's a fairly straightforward process in this state. First, you contact the prescriber. Second, you obtain certification. Third, you register online. And fourth, you go and purchase the product. With regards to dosing, the law here doesn't have a mandate for the prescriber to give a certain dose. You can recommend, but it's not really required to do that. The patient is the one who decides. There's two main components of medical marijuana. There's THC and CBD. It comes in various mixtures. High CBD, low THC, low THC, high CBD, and equal parts of both. In addition to selecting the dose, the patient also picks the preferred route of administration. You can pick capsule, you can pick liquid, plant, topicals. The only forms that are outlawed by New York State are smoked and edibles. Dispensaries are not allowed to dispense any of these types. So when patients are suffering from severe pain, they have both anatomical problems as well as physiological problems. On top of that, they can also suffer from the psychological problem of feeling a lack of control. Medical marijuana works not only by producing changes within the body, but also by giving power, autonomy, and control back to patients suffering from pain. Thank you.
Hello, I'm Kristoffer Padjen. Thank you I'd like to extend thanks to the course directors for inviting me to give this talk. I enjoy giving it. This is interventional options in the management of spinal pain. So really briefly, I have too many slides as it is. It's only 15 minutes, and so most of the literature-based slides are kind of hidden at the end of the talk. You should look over them. You have them in the slides, but it's hard to give this talk in the entire scope of interventional pain medicine in 15 minutes, so it'll necessarily be somewhat superficial, but I know we'll be happy to talk about it. I have no disclosures. No disclosures. I don't know how to get any of those. So the most common areas of pain. So there's lots of them, right? So, however, neck and back pain tend to be very, very common. I mean, I know working in a chronic pain clinic, and I'm sure working, PM&R, or just being in a general practitioner's office, a lot of people that come in, right, most common reason for coming to see a doctor is pain, and I got to say, at least in the chronic pain clinic, it's like at least every other patient is back pain. Back or neck pain, it's continuous, and honestly, the 80%, I saw an 80% quoted last time, 80% of adults have experienced back or neck pain. I almost feel like, if you get older, it's waiting for you. So, it's going to happen. So sources of neck and back pain, they're numerous. The focus of this talk is obviously going to be things where you've already screened against, like for red flags, right? So these are going to be people that you ask, do you have night sweats? Are you losing weight for no reason? Do you have fevers and chills? These kind of things, so you've already tried to rule out infectious etiologies, cancers, is there some sort of inflammatory process? And also you're going to carefully look at, are there signs of myelopathy or radiculopathy? But, sort of back up to sort of pain medicine, I always think of like pain management. I think when patients initially, maybe this has changed, but when they initially come to see us, they always kind of think of this like the World Health Organization, like the pain treatment ladder, right? And this is sort of very medication and really opioid centric. It originally came out of the desire to treat people with end stage pain, right? Really with opioid medications. And so, but there's more than opioids, right? There's a whole galaxy of medications for chronic pain. But really, I like to think of pain treatment sort of either as a ladder of sort of increasingly invasive treatments, or perhaps even as sort of multiple spheres. So I know when I'm talking to a patient, I'll usually just to organize my thoughts, think of, how can we treat your pain? And so you try to think of, well, there's sort of physical therapy-based or acupuncture-based, things-based therapies, things that are not shots, that are not pills, that are not surgery, right? And then you can move on, and those are often effective. And honestly, as long as there's not some sort of red flag, often the things to start with. But then there's also sort of medication-based treatments, which have their own invasiveness. There's interventions, which have their own invasiveness, and there's psychological and psychiatric-based therapies as well. And all this, again, is excluding surgery. But again, that can move to the front of the list if you're talking about people, again, who have progressive numbness or weakness or any of these sort of more acute or red flag causes of pain. But I think when you combine all these, you've got multimodal pain treatment, which I think is a buzzword, but can really add a lot to your overall success in improving people's lives, which can oftentimes be very difficult, especially if you want the gold standard of function, right? Everybody talks about function, that's the gold standard. Well, that could be very, very difficult to actually achieve in a real-world patient. So if you can combine things like intervention, medications, physical therapy, psychological treatments, I think you can actually move people forward and meaningfully improve their lives rather than just, say, get them to report a lower score on a VAS. So we're going to talk about intervention here, right? It's part of a multimodal treatment plan for cervical and lumbar pain, right? Spinal pain. So injection techniques for spinal pain. Right? There's many of them, right? There's steroid injections, there's nerve root injections, there's intra-articular facet injections, there's medial branch blocks, there's intradiscal things. That's just leaving aside things like neuromodulation, spinal cord stimulator, which obviously is a huge field. So I'm necessarily really going to focus on 2 or 3 major techniques. And those will really be steroid injections, medial branch blocks, or really, for facet pain, and if we get time, sacroiliac joint injections. So, interventional pain management, injecting the spine. Why on earth would anyone ever do this? So, indications. Well, failure of oral medications and physical therapy. So again, I'm a big believer in physical therapy. I got to say, when I get people involved in it, my interventions seem to work a lot better. And I think there's a lot of reasons for that. One, you can actually get people invested in their own getting better, which I think from a psychological perspective is key, because again, and this was brought up earlier, if a patient comes to you and their idea is you're going to fix me, like I've got these problems and they are caused by my biology and you're going to fix them, that makes your job a lot harder, right, than if you're working together as a team. I think physical therapy will do a lot for that. Plus, I think physical therapy can improve function. It really can. A lot of the point in my mind of doing interventions is to get people to be active and to actually do physical therapy, right? Because there's like a spiral, right? So I have pain, so I don't want to do X activity because I think it's going to hurt me and it's going to cause pain. And so then I get weak and I don't want to do the activity anymore and I have more pain. And eventually, that's a bad scenario. So failure of oral medications. So there's a lot of pills and there's a huge literature of what do they work for and what don't they work for. And it honestly ends up being very patient specific, I've got to say. Plus using, a lot of these patients are elderly and using these medications in older patients becomes more and more difficult. If you look at the Beers criteria, you can hardly move. And so sometimes it's useful to think of intervention first. Uncontrollable severe pain, again, if someone comes to your office and they're like, I got 10 out of 10 pain and I can't sleep, saying, go to physical therapy and try to move more might not be the most effective thing. And then there's some diagnostic utility to some of these injections. And so if you have an unclear pain generator, you can use interventions for that. So Another way to think of what are your considerations for pain intervention would be what's the differential diagnosis of cervical and lumbar pain, and what are the treatments indicated for these diagnoses. And again, it's vast, but just a grossly simplified view might be musculomyofascial pain. So you can talk about trigger points. I'm not going to in this talk, but again, there's actually a surprisingly robust literature. You can talk about lumbar radicular pain, nerve root pain, and you'd be talking about epidural steroid injections, basically. You can talk about facet pain arthropathy. You can talk about sacroiliac joint pain. So radicular pain. So, it's thought to be caused by inflammation or impingement upon a spinal nerve or by irritation of that nerve, right? And this is a hard thing to study in actual people, and there's some rat models, for example, that are interesting that show that, for example, if you have impingement that doesn't involve the dorsal root ganglia, that you need inflammation to actually cause pain. And so that's kind of a nice story to explain how steroid injections might work. But then, there's other theories as to how these work, and again, inflammation and nerve root impingement they co-occur, and they both seem to be involved in the pain response. Now, radicular pain usually begins at the back, and it usually radiates in a dermatomal pattern, depending on the dermatome, often below the knee. So here's some dermatome maps. We already saw these. Again, like really everything else in medicine, right, it's endlessly complex, so these aren't real. I mean, they are, but, if you look at other studies, these actually, vary between people. I mean, you're not an automobile, right? So there is some variation between people. They can overlap significantly, and they can actually change over time based on neurologic injury. But again, we all have sort of a dermatomal map. So with the history of lumbar radicular pain, and this was touched on a little bit earlier, but again, pain radiating from the spine to the extremities, may be burning or electric in nature, may be associated with paresthesias, and it may be associated with neurologic complaints. And for the purpose of this talk, what I mean by neurologic complaints, right, that's sort of a big term, but things like, numbness, weakness, paresthesias, right? And these are important to ask about, because obviously if someone comes to you and they say something like, I've got pain through my back, down my leg, but I'm still functional and I'm walking, but the pain's really bad. I'd love to go to physical therapy. You might be thinking, oh, great, intervention, physical therapy, I can fix your problem. On the other hand, if I come to you and I'm like, I can't walk and I've got objective weakness in the clinic, then the algorithm of how you're going to treat them might change. Exam imaging, I'm not going to belabor in this, but there's the straight leg and the contralateral straight leg raise. And imaging may show nerve impingement. And I think the reason I show nerve impingement is that there's really a pretty poor correlation between people's symptoms and their MRIs, right? So they come in, and that works both ways. So one way it works is that as you get older, right, and if you MRI people every few years, which I think in the U.S. we do basically, the older they get, the more disc disease and arthritis and, foraminal narrowing and possible central narrowing they get until eventually, if you just want to do interventions, you can justify almost anything. But that's not what you're supposed to do. You're supposed to treat the actual patient, not the imaging. So, and I think, again, this is important because sometimes patients will come in and they'll say things to me like, oh, yeah, instead of describing their symptoms, right, they'll start with, oh, I've got like L5S1 or I've got L4-5. So they'll start with the perceived, physical problem, right? But what I really want to hear is their symptoms. Because, for all I know, I'm sitting here with disc disease at L5S1 right now. Probably am, right? But my back feels fine. So you don't want to, imaging is useful. And certainly when it correlates with their history and physical, that's great. It makes you feel even better that you're going to do this injection and maybe it'll work. But you don't want to treat the MRI. So epidural steroid injections. So, there's interlaminar and there's transforaminal injections, as well as obviously caudal injections. I'll go into them a little bit more later. Theoretical basis, again, structural change in the spine can result in an inflammatory response in the epidural space, as well as damage to the disc, and basically expose usually immunologically privileged structures to reaction from the immune system, thereby possibly triggering pain in a dermatomal dermatomal pattern. So back to considerations of pain interventions. What are the indicated treatments for my diagnoses? So radicular pain. So why would you use an epidural steroid injection for radicular pain? Well, it's high in the algorithm for management of radicular pain, and there's a lot of reasons for that. A transforaminal, as opposed to an interlaminar, may potentially provide diagnostic information that can be useful to you. It could be useful to the patient for further treatment. It might even be useful to the surgeons if it ends up going that route. And pain relief may decrease the patient's need for medication use, may get them into physical therapy, may improve their mood, may improve their sleep. You can really help people. Risk contraindication. So the evidence, frankly, is mixed and it's highly variable depending on the literature source. And that is just the nature of the field. So, and so I think the longer you practice, the more selective you're able to be because, again, depending on the quality of evidence you're willing to accept, you can justify a lot of things. The evidence for transforaminals being selective to nerve root blocks, again, is equivocal at best, and there are severe complications that are rare, but are a very significant concern. And so here's some, again, the approach to epidural steroid injections. You have interlaminar. It's basically like a labor epidural, right? There's lumbar transforaminal epidural steroid injections. There's sacral transforaminal epidural steroid injections, which are somewhat different than lumbar. And then obviously there's caudal epidural steroid injections. And then there's transforaminals in the cervical spine as well, although they warrant sort of special mention. So the interlam. So, you know, it's blind versus fluoroscopic, although I've got to say I think it's moving or is standard of care to use fluoroscopy at this point, although it may be that they're still performed blind. Posterior epidural, there's posterior epidural placement, which theoretically may be problematic because some of the structures you're trying to target are anterior. It's 4 to 10 cc's of volume that's injected. It's mostly therapeutic because I don't think you're going to get not a lot of specificity here, that's sort of a double-edged sword. So, you know, if you're pretty sure the patient's pain is from one area, you want to inject in that area, but you're not really going to be able to prove it based on the position of your needle. But that can be good too, right? Because if you can do an interlaminar steroid injection, let's say people come in, and they often do, and they've got multiple overlapping dermatomes that seem to be painful, or they've got pain on both sides, you can really do one interlaminar steroid injection, and you get a lot of spread, and you can get steroid medications to a lot of areas that really would require many transforaminals, frankly, to get to, and so you really do reduce the number of injections that you have to do. And there is a proven safety record, although again, you know, interlaminar steroid injections have, you know, notable risks, you know, hematoma, abscess, you know, very, very rare, but can be catastrophic, and then post-dural puncture headache are a risk of these, among others, risk of these injections. So cervical interlaminar epidural steroid injection, much the same type of procedure, again, relying on both loss of resistance as well as your fluoroscopy. And really, you know, more risky simply because of the real estate. So let's talk about transforaminal epidural steroid injections. So these require fluoroscopy. They do. They have confirmed spinal level and laterality, and I think it's a lot more important for these. Again, my view with interlams is, I mean, you can't be nowhere near the site of where you want to treat, but it's sort of a feature, not a bug, that you can be sort of a widespread. But certainly with transforaminal, you need a lot more specificity, you know, where you want to inject. You need to confirm spinal level and laterality. There's theoretically improved steroid placement. There's better nerve root coverage, certainly, and the steroid is anterior laterally placed. And there's been quite a bit of effort to prove that these are more effective than interlaminar steroid injections. And there is some fair evidence that that may be the case. And they also can be potentially diagnostic as well as therapeutic. The downside, perhaps, of the transforaminal injections, as opposed to the interlaminar, right, everything has pluses and minuses. The downside here might really be that not all, but certainly many of, or a plurality of the catastrophic outcomes from these injections tend to be based on transforaminal injections, particularly in the cervical spine, where I think they're controversial. So cervical transforaminal epidural steroid injections, again, simply, and it's out of the scope of this talk, but simply based on the nature of the vasculature in this area, these are significantly higher risk injections than other epidural steroid injections. And at least in my practice, there would have to be a very clear reason to do something like this rather than just opting for the interlaminar route. And so just moving on from that, let's talk about facet pain. So, you know, another very, very common, besides the, you know, epidural steroid injections, probably the most common thing that's done interventionally, frankly, just in terms of volume, ends up being medial branch blocks or injections for facet pain. So just to back up to, you know, what is a facet joint, right? So these are these joints in the lumbar, thoracic, and cervical spine, and they're each innervated by 2 medial branches of the dorsal ramus, right? And let's start with lumbar facet pain. It's typically worsened by extension and twisting of the back, and typically does not radiate below the knee. Although, again, the physical exam, there's not good evidence base that you can clearly pinpoint whether someone has facet pain based on the physical exam. Cervical facet pain, again, is associated with axial neck pain and can be associated with occipital or, quote, cervicogenic headache. So let's talk about cervical facet pain. It can be a secondary to whiplash injury, can result in headaches. Cervical facets have defined but variable radiation patterns. Can be increased with extension, lateral flexion, or palpation. But again, the evidence for a lot of the physical exam to diagnose facet pain is somewhat lacking. And joint arthropathy on imaging correlates really very poorly with pain. And again, I don't know for sure why that is, but some of it certainly must be the fact that, again, as you progress with age, basically everyone gets facet arthropathy. It just occurs, you're going to have it. And so you can't necessarily say that just because you've got arthropathy or hypertrophy of these joints, they've got facet pain. So here's some cervical facet radiation maps. Here's the one you're sort of familiar with on the left. But of course, when they study it again, it's more complicated. They overlap and they vary between patients. And so you just need to take everything with a grain of salt when you're trying to examine these patients. Lumbar facet pain, theoretically, again, associated with arthritic changes in the lumbar spine. Should be worse, or at least per textbook, should be worse with extension, long periods of standing. And lumbar facets, again, have defined but variable radiation patterns. And really the same thing. The exam and the imaging can kind of point you in the direction of, yes, I think this is facet pain, like, oh, doctor, I have a lot of pain with standing, and then you examine them, they've got some positive, facet loading maneuvers, but it doesn't really prove it. Here's some facet, sort of the facet loading, some facet radiation patterns. And I got to say that there's a lot of these, and lumbar facet pain overlaps a lot with a lot of sort of non-specific causes of back pain. Muscular pain, discogenic pain can look different in the exam, but the overall pain patterns can be similar. And obviously even the hip or sacroiliac joints can overlap a lot with these types of pains. So how do you prove they have facet pain? Well, so the involved joints, you can sort of determine by history and exam, but really what you have to do is deinnervate these joints. And so you do what's called a medial branch block normally, right? So each joint is innervated by two medial branches of the dorsal ramus, and it's a fairly straightforward process to use local anesthetic to block these branches. And what you're looking for is the patient to come back and tell you that, oh, I have significant pain relief. And the arbitrary, well, in my mind, somewhat arbitrary percentage chosen is 80%. And there are reasons for why 80% is chosen, but that's inherently problematic, right? Because pain is subjective. So when the patient, when I do these, I usually tell patients that, you want to have very clearly relieved pain, right? And you want it to be the day of the injection. It should happen fairly soon because you block these joints. To expect a patient really to come back and say 80%, though, I think is a little much because I don't know what 80% pain relief is. Like, I don't know what that means because that is a subjective thing. It's not even these numbers aren't real. And so, if I say I have 75% relief, does that really mean it's better than 85% relief? You can't convince me that it does. But, what you don't want is you want to stress to the patients that these blocks need to work and they need to be profoundly effective. And they need to be profoundly effective because what you don't want, at least what I don't want, is to do two medial branch blocks and think this is great, I'm a great doctor, everything worked, I'm going to relieve this patient's pain, but only briefly, right, because the local anesthetic wears off. And then go to the RFA, which is the radiofrequency ablation, right, where you burn these nerves. And the patient come back and say, yeah, that totally didn't work, right? So that's, and I think one way to avoid that is to really stress the importance of these diagnostic procedures. So radiofrequency thermocoagulation, just, it's a continuous output of high-frequency electric current. You heat up the tip of the needle to 80 degrees for 60 to 90 seconds. And there are variations of these. There's something called cool RF, which, not to get into technicalities, but basically produce a larger lesion. And, the temperature induces, thermocoagulation of the nerve fibers. Sensory loss can be transient. Pain relief can extend for much longer periods, depending on the literature source you believe, somewhere between 3 to 9 months. And then finally, I'll just briefly touch on this. There's something called pulse radiofrequency ablation, which is basically where you expose these nerves to a modulating electromagnetic field. It never really goes above 42 degrees. So you don't do any thermocoagulation. There's no real destruction of these nerves. However, in some way that may contribute to gene expression changes and may be an effective treatment as well. Although the evidence for that is definitely not as clear. So finally, and I know in the interest of time, this is where we'll stop after this, there's sacroiliac pain, right? So sacroiliac pain can overlap a lot with hip pain. It can overlap a lot with back pain. And there are sacroiliac joint injections. And basically, the SI joint pain will often radiate from the buttocks to sort of the posterior thigh. Osteoarthritis is the most common cause, but even with SI joint pain, especially if they fit other sort of risk demographics, you might want to think, does this person have sacroiliitis? And then you want to refer them to your rheumatologic colleagues because while your block might temporarily relieve their pain, you do need to treat the underlying cause of their pain. But, left side joint pain can be associated with things like previous fusions. It can be associated by osteoarthritis, which is really the most common cause. And there's sort of two major treatments for this interventionally. There's injection, which is just placement of steroids and local anesthetic within the joint itself. And then finally, there's lateral branch blocks, followed by RFA, which you can think of as analogous to these medial branch blocks for facet pain. Basically, what you do is you, in a line, numb all the lateral branches. These are the nerve branches that basically give nociceptive information to the patient. You denervate these with local anesthetic. If the patient says they're much better, there's a procedure whereby you can actually do a radiofrequency ablation of them. It's much less well defined in the literature than medial branch RFA, but it is another potential treatment process. And so I think with that, for the nature of time, I'm going to stop. Thanks very much.
So those are excellent talks. We have a few questions here. Unfortunately, we're running just behind the work ahead. Go ahead with the next session. My colleague, Charla Fischer.
All right. Thank you, everyone, for coming in today. Thanks, everyone, for joining us virtually. I'm going to skip through a bunch of this to try and get us back closer to being on time, if that's okay, because I do know that Dr. Stever talked to you a lot about evaluation earlier. I just want to go over my disclosures. Most importantly, this is not my talk. This is Dr. Young Kim's talk. He's just away today, so I'm giving it for him. Okay, so I'm going to skip forward to the treatment section, if that's okay. If anyone has any issues, feel free to reach out to me and I can send you this talk and you can go over that. But I really want to get into sort of the treatment considerations. Okay, so axial neck pain surgical considerations. So axial neck pain is a really challenging area surgically. Number one, it's multifactorial, and the surgical solutions usually are not sufficient to address everything. Now, there are a few exceptions. If you have a C1, C2 osteoarthritis with severe occipital headaches and a lot of pain, fusing that segment can sometimes be helpful. If patients have severe progressive intolerable pain more than 6 months, if there's employed, non-smokers, off narcotics, no overt psychopathology, and surgeons are terrible at identifying that, or a really motivated patient. But in general, when we see patients with just axial neck pain, we're very, very reticent to offer a surgical option. So patients that come in with a pain diagram that's like all over, this is when we say, you know what, you may be beyond the limits of my science here. And the reason why the C1, C2 fusion causes a lot, C1, C2 osteoarthritis causes a lot of neck pain is because it's just a lot of pain at the base of the skull and referring into the paraspinal muscles. And so you can get a lot of pain exacerbated with lateral rotation, but they shouldn't have a lot of flexion extension pain. So C1, C2 is mostly rotation. So they're having a lot of flexion extension pain. You want to think subaxial spine, and maybe that's not really the best patient to offer a surgery for. Okay, so the subaxial spine, we can do surgery. We can do an ACDF or disc replacement or posterior cervical fusion. And the clinical success is just quite variable. And so when you look at patients, and we did this task force looking at neck pain and surgical options for that, and there's just really no good clinical supporting evidence that a fusion or a disc replacement is going to help patients who have neck pain without radiculopathy. If you have radiculopathy, that gets better, and we deal with the neck pain afterwards. But if they don't really have radiculopathy, then surgery is not going to be the best solution for that. So let's talk about a condition in which surgery is really helpful for, and that's cervical radiculopathy. And so that's a disc herniation or compression of the nerve in the neck causing arm pain. And some of these patients have an acute disc herniation, so it's a soft disc, and sometimes it's either a disc herniation that's been there a long time and calcified, a hard disc, or they have disc degeneration such that the foraminal height is decreased, or you get uncovertebral joint spurring, so that joint becomes calcified and it can push on the nerve root. And so it's very classic. You know, the nerves in the cervical spine exit the neck, they form the brachial plexus and then go into the arm. There is some variability in that sort of pain distribution pattern because the brachial plexus, it doesn't follow the textbook in every patient. But for the most part, if you have a pain rating down in sort of like the thumb and index finger, that's C6, and middle finger at C7. So for the most part, most patients do follow the textbook. As far as the dermatdermal pain distribution, numbness and paresthesias, weakness, and you can get reflex pain changes and provocative maneuver issues. So spurling sign is when we just extend and rotate to the painful side, and that collapses the foramen down. You have axial compression, shoulder abduction release sign. I think this is the best prognostic indicator of a patient who's going to do really well with the surgery for cervical radiculopathy when they're sitting during the examination talking to you with their arm up over their up and their hand on their head. That means that they are so uncomfortable that they can't just let their arm rest by their side. That means the patient's going to do really well with surgery as long as the imaging matches that. And so on x-rays, a lot of times these patients have very normal looking x-rays. If it's a soft disc herniation in a younger patient, if it's due to disc degeneration and foraminal stenosis, you're going to see loss of disc height and osteophytes, and these foraminal cuts are going to be very helpful. So this picture right here, is that arrow showing? Okay, great. Is going to show bone spurring in the foramen as shown here. And so that can sort of push onto the nerve root there and be very painful. MRI, of course, is our modality of choice, and it can show these large herniations pushing on the nerve root, causing a lot of pain due to pressure and inflammation. There's other tests you can do. We can do a CT myelogram if they can't get an MRI. You can start out with a plain CT if you think it's going to show up pretty well, or a CT myelogram if they can't get an MRI. These days, there's very few reasons why a patient can't get an MRI. And then you can do nerve study tests, EMG and a nerve conduction velocity to look at the track of the nerve and make sure it correlates to cervical radiculopathy. Also to rule out peripheral compression. So there may be some patients with carpal tunnel syndrome or cubital tunnel syndrome, posterior interosseous nerve issues that can kind of look C8-ish. So you want to make sure that everything matches up. And again, PIN is very rare. Cubital tunnel, they're going to complain of different symptoms. The same thing with carpal tunnel, that waking up and shaking the hand type of thing. Differential diagnosis, so you can look for a tumor in the nerve, and some of our neurosurgery colleagues are going to talk about that a little later. You can think of neurologic issues, MS, and then if they have something that seems really radicular, but there's nothing on the MRI, you might want to think about Parsonage-Turner syndrome, especially if they've recently had a virus. I did have a patient who had, I think it was a COVID vaccine, and then it seemed like a Parsonage-Turner syndrome, but it didn't really pan out. So you want to think about those types of things when the imaging just doesn't quite match up. And then nerve entrapment syndromes, thoracic outlet, and then peripheral nerve entrapments in the medial ulnar and radial nerve. And you want to think about shoulder pathology. So if a patient comes in like this with their arm up over their head, then that's clearly cervical radiculopathy. But if they are holding their arm at their side and they don't want to reach overhead, maybe you want to think shoulder issues. And then complex regional pain syndrome is always something you want to think about when they talk about temperature changes or color changes in their hand, and that will get worse after surgery. So you want to make sure that there's no CRPS involved. So we can treat it with non-surgical treatment. And like 70 to 80% of patients with a cervical radiculopathy do not need surgery. But there are some cases where we do want to do surgery. If they haven't had any improvement with conservative treatment for a minimum of 6 weeks, and some patients will notice slight improvement over that time. you might want to give them another 6 weeks of non-surgical treatment. But if it's sort of plateaued or stayed the same for that entire time frame, maybe their body just isn't healing this disc herniation like it should. If they have any weakness that's progressive or profound, or if their pain is acute and severe and unrelenting, and I've seen patients in the office, they're sweating, it's like a cold sweat, they can't sit down, they can't do anything. And those are the patients I say, you know what, if you want, just go to the hospital, we'll do it tomorrow, because they're quite miserable. So the goals of surgery to decompress the nerve root, decrease that arm pain, and then, some part of their neck pain will get better, and then we want to stabilize and either do a disc replacement or a fusion. So going into the front versus the back, there are many, many things that affect our decision-making for that. Sometimes it's surgeon preference, sometimes it's location of where the compression is, whether it's hard disc, soft disc, if you need to take a lot of bone to get all of the material out. So you could show an image to a lot of surgeons and get a lot of answers. For the most part, a lot of spine surgeons like going in through the front because it's pretty clean, pretty simple. So we're going to offer anterior approaches many, many times. So when you go in through the front, you can do your discectomy and then either do a fusion or disc replacement. And so ACDF is tried and true. It does very, very well, and it can help with the arm pain. Sometimes, depending on how much distraction of the disc space you get, you can have post-op neck pain, and most patients fuse. The issue with the fusion is, does it transfer stress to the other levels, and are we looking at higher reoperation rates? But it does very, very well in most patients. So you're able to do both direct decompression of the nerve root by taking out the herniation or taking out the bone spurs, and then indirect decompression of the nerve root by restoring the disc height. You're making more space for the nerve. And then once you stabilize that level, any extra osteophytes that you don't take out are going to be resorbed over time. I like to go for those osteophytes because I like patients to have significant improvement right away, as opposed to saying, oh, it'll get better over the next 6 months. It'll get better over the next 6 months. That's really frustrating for both me and the patient. And then sometimes they can get some axial neck pain improvement. So patients do really, really well with an ACDF. And these are, you get really good outcomes for single-level disease or two-level disease. Once you start getting above two-level disease, the outcomes aren't as reliable or predictable. And then you can get non-fusion, right? So we need the bone to grow between the disc spaces, and the pseudoarthrosis rates increase based on the number of fusion levels because you need more biology to happen, basically. And so you can see more non-fusion or lack of fusion as the number of levels increase, but there's no real clear correlation between pseudoarthrosis and poor outcome. I have a guy who had a ACDF, I want to say about 10 years ago in another country, and so there was no instrumentation placed. It was the old Cloward procedure of just taking the disc out and putting bone graft. He feels pretty good. Another level is starting to wear down, but I may have to refuse that one level because it's bothersome, and especially if I'm going to ask another level to fuse. Okay, so post-op management. Most cases at NYU are being discharged the same day or the next morning. And then return to work really depends on their job. So some patients who work remotely on the computer can start to work in a day or two. But if they are doing any sort of manual labor or a really active job, then you might want to hold them out for a little bit longer. Every surgeon's a little different on that. Driving, there's really no consensus on that. But if they're off narcotics and they have minimal pain and they can turn their head okay, they should be fine to drive. Complications, infection is exceedingly rare. You can have issues with the blood vessels in the area. You can get trachea or esophageal injuries. Everyone has some form of dysphagia after surgery, both functional and symptom-wise. They just feel like swallowing is weird. And in like 90% of patients, that resolves back to normal in a few weeks. You can also have hardware failure or injury of the neurologic structures in the area. Bottom line, it's really a good option. But does the fusion affect the other levels? So everyone has their genetically predetermined way they're going to age, right? You know, there's no science behind who gets gray hair and at what age, but we know that it's based in our genes. So our other discs could be wearing down over time. Is it the stress of the surgery, the fusion at that level that's transferring stress to the area, and we see adjacent segment disease? So we do see 25% reoperation over 10 years. And some patients say, fine, give me 10 years of significant improvement and I'll come back when there's a problem. But then, you know, we developed disc arthroplasty. And because it maintains the normal motion of the spine, we're seeing at 7 years, 14 years after these initial studies that there's lower reoperation in these patients with a disc arthroplasty compared to the fusion. So that's really what we're trying to do with a disc arthroplasty. We want to do the same thing with the fusion, take the disc out, restore some disc height a little bit, but we're just trying to avoid the reoperation over the next 10 years. The complications with a disc arthroplasty, if it loosens, if there's subsidence, or if there's arthritis at the facet joint. So the biggest issue with disc arthroplasty is it's maintaining motion at the level, right? So if you have a lot of arthritis at that facet joint at that level, you're still moving it and still causing pain. So I do have to tell patients who have a fair amount of disc height collapse and facet joint arthritis, while I would love to do a disc replacement in you, I don't think that's going to be a good idea because you're going to have worsening neck pain afterwards. And then there's also posterior foraminotomy. A very, very lateral or foraminal soft disc herniation can do really well with a posterior foraminotomy. It's an approach from the back. We can't retract the cervical spinal cord like we can retract the lumbar thecal sac because it's spinal cord. Anytime you touch it, it's not going to like it. So if it's far off to the side enough to where we're not touching the spinal cord and we're just exposing the compressed nerve and maybe taking out a soft disc herniation, it's a good surgery. It's rather rare only because a lot of people do have a fair amount of uncovertebral joint degeneration and bone spurring, and so it makes it kind of stiff and it's hard to get off. So a young patient with a very lateral or foraminal disc herniation can do well with this. And this is just the technique showing that we're able to get in and then make a hole in the back part of the spine. And here's the nerve root. So we can move a nerve root, but we're not touching the spinal cord. And then we can expose that herniation and get some of that soft disc material out. Complications with this: wrong level surgery, infection, nerve root injury from that slight retraction, inadequate decompression, or if you take too much of that facet joint off, you can cause some instability. So in conclusion, non-surgical treatment for the majority of neck pain and radiculopathy is going to be successful. Surgical management in patients with progressive neurologic deficit or failure to improve with time or in severe pain. And when properly indicated, surgical procedures for the cervical spine have excellent outcomes. Thank you.
Morning, everybody. Just going to take my jacket off. It's a little warm in here. So this next talk is evaluation and treatment of cervical myelopathy. Just changing gears. We heard about radiculopathy. I tell my radiculopathy patients that there's about an 80 or 90% chance I can get you through this without an operation. We say the exact opposite with cervical myelopathy. If it's clinically significant, then there's an 80 or 90% chance they may be looking at surgery to prevent further progression. That's my disclosure. In terms of definition, in its simplest form, cervical myelopathy is dysfunction of the spinal cord. There are many different causes we'll get into in a second. The natural history, if you leave it alone, is very poor, and that's why we end up operating on a lot of these patients. If you leave it alone, it could lead to permanent dysfunction, gait disturbance, which is one of the earliest findings, upper and lower extremity weakness, paresthesias that become chronic, and of course, bladder function if it stays long enough. The funny thing about myelopathy is patients are like, well, I don't have any pain, so I don't need an operation, right? So myelopathy is often painless, and that's important to know. And that's why it gets missed. That's why the signs and symptoms of myelopathy get missed by a lot of medical professionals all the time. So remember, these patients don't really have pain. They could have pain, but most of them do not have pain. They have neurologic dysfunction, such as paresthesias, weakness, loss of dexterity. They tell you they can't button their shirt anymore. They can't, their handwriting is becoming progressively worse. They can't use chopsticks if they eat Japanese food, that kind of stuff. They can't discern between a nickel, quarter, and a dime if you ask them to. Their loss of balance is very common. That's an early finding. When they come in, they get a very broad-based, unsteady gait, like they've had several drinks. You know, that is very typical of myelopathy. One of the earliest signs of myelopathy. They get this heaviness or leg stiffness. And people would never think that cord compression up here is going to affect their lower extremities, but it certainly does. And of course, urinary dysfunction, one of the later signs. These are the clinical signs that we elicit in the office for myelopathy. Upper and lower extremity hyperreflexia, right? Reflexes, knees, ankles, hips, and biceps and triceps, they all get hyperreflexic. A Hoffman sign, as you see from this picture there, you kind of tweak the middle dorsal phalanx of the middle finger, and you get this kind of pincer response of the index and the thumb. That's an abnormal pathologic upper motor neuron reflex. It's more significant if it's unilateral. Most pathologic reflexes are more significant if they're unilateral. Some of us develop Hoffman sign as we get older. It can happen of no clinical significance, but if you start seeing unilateral signs, it's always more concerning. Lermite sign is when you have the patient flex and extend very quickly, and that elicits kind of like this shock-like sensation through their trunk and down their legs. Basically, what you're doing is you're pushing the cord through a very tight area and exciting the cord, and the cord doesn't like that. You check for clonus, and if they have clonus, you want to document how many beats of clonus and whether it's sustained or unsustained. Babinski sign, as shown here, you always want to do that. And when you do the Babinski, if they take their leg up like this and go into a spastic response where they flex their hip, flex their knee, dorsiflex their foot, that's a triple reflex response. That's also consistent with myelopathy or cord dysfunction. So in the office, the most common things we see are extrinsic compression. What are the three main things that compress the spinal cord extrinsically? An acute herniated disc. Somebody all of a sudden was fine. They have a large herniated disc compressing the cord, and they have signs and symptoms of myelopathy. That patient should have surgery immediately. That's not a disc herniation that you want to sit on and say, come back in 3 months, right? This is not a radiculopathic disc herniation. This is a myelopathic herniation that should be addressed surgically 9.5 out of 10 times. The other thing we see commonly is cervical spondylotic myelopathy in the lower left picture, right? Slowly the cord starts getting compressed. You may start seeing myelomalacia. This is an insidious thing. It kind of happens slowly over time, but eventually patients will tell you they start losing function. And it's the first sign of significant clinical dysfunction. They should consider surgery, because we know, bottom line is to tell patients you're on a downgoing elevator. Okay, you have myelopathy. You're heading down in the elevator. You're going to end up in the basement if we don't do surgery. If we do surgery, press the button, get off at the 7th floor. You may live at the 7th floor after surgery, or you may go up, but we tell people you're going to live at the 7th floor. Maybe you'll go back up to 8 or 9. You're probably not going to be perfect, but there's a good chance you'll live on 7, which is not a bad compromise, right? Because otherwise they're going down to the basement. So we do surgery to prevent further progression. There are other uncommon things like AV malformation, epidural abscess, tumors that can cause extrinsic compression of the cord. Of course, there's intrinsic compression, a tumor within the spinal cord, a syrinx, that's a fluid, a mass expanding within the cord, giving cord compression. And of course, there's the non-compressive etiologies like viral and transverse myelitis that, it's in the back of our differential all the time. Vitamin B12 deficiency, by the way, should also be on everybody's mind because that can create myelopathic type symptoms. So surgical indications, bottom line is we said 9 out of 10 of these people need surgery. So if they have clinical signs of myelopathy and symptoms, and where they have clinical dysfunction with concomitant studies that show cord compression, you need surgery. If they have a progressive significant neurologic deficit, like weakness, that's progressing in front of you, you need to have an operation. And of course, they have to have concomitant radiographic compression that matches their complaint, and 9 out of 10, they need surgery. This is an unusual case. We see this a lot. We see people that, for whatever reason, they come in, and maybe they're coming in for their lumbar spine, you get a cervical, and you see this, and you're like, and they have no symptoms. They're asymptomatic, referable to this MRI. What do? It's a really lousy-looking MRI. Some surgeons I've heard tell patients, well, if you don't have an operation tomorrow, you're going to end up in a wheelchair. You get into a car accident, you're going to be paralyzed. We've all heard these stories. Is that true? Pretty unlikely. Bad things happen in the operating room, seldom. Bad things happen in the car, seldom. So I tell patients, they've done actuarial studies on this, and you probably have a higher chance of getting hurt in the operating room or after an operation if you're completely clinically asymptomatic versus having, just living with it. So I tell patients, look, if they're really truly clinically asymptomatic from a picture like this, or maybe not as bad as this, but you start seeing cord compression, you may see some early signal change, and signal change we all know heralds a poor prognosis. But if you see somebody with a picture like that who's completely clinically asymptomatic, I tell patients, I can't make you better. How am I going to make you better than you're functioning perfectly fine? I can only hurt you with an operation. So I tell people, I'm not going to operate on you, but you don't stick your head in the sand. You follow them very carefully. You have them see yourself or a neurologist or anybody who's deemed appropriate to follow a neurologic issue, and have them see the neurologist every 6 months for serial reevaluation. And then you tell them, be on the lookout for numbness and tingling, weakness, this, that, all the things we discussed. And if they don't develop those things, okay, then they go another 6 months and they get reevaluated another 6 months. So you can follow these people really carefully, just make sure they don't get worse. You don't have to operate on a bad picture if they're clinically stable. What are the goals? As we said, there's really no pain, so that's relieving pain, usually not an issue. But you want to stabilize neurologic deterioration, you want to maximize the recovery, and you want to minimize any late neurologic issues. So the goal of surgery, we got to decompress all the levels that are compressed, specifically the cord levels. Maybe you don't have to go over after every single nerve that's compressed peripherally in the foramen, but you do want to make sure that you get all the central cord decompressed if you're treating myelopathy. Now, if some people have radiculopathy in addition to myelopathy, okay, then you may have to focus your attention more on the nerves and in addition to the cord. But most of us go after the cord compression because that's where the issue is. And you want to maintain or achieve stability. You want to make sure that if you're going to fuse them, you fuse them in a good alignment, right? Decent lordosis, so they don't develop postural issues or adjacent level issues down the line. And the prognosis is better if the cord's not as severely compressed pre-op, right? That's kind of intuitive. It's not as bad pre-op, then you probably got a better prognosis. The less severe your clinical myelopathy is before surgery, okay, the better prognosis is after surgery. The younger you are, the better chance you have of recovering. They say, studies have shown that if you have these significant symptoms of myelopathy for greater than a year, bad sign. You may not recover as much as you'd like to. And obviously, single-level involvement is better than multi-level involvement. So when we operate, what are the options? Like most things in spine surgery, pretty simple, front, back, or front and back, right? So most of us, if it's anterior compression in a younger person, we'll try to do an ACDF or a corpectomy or maybe even a cervical arthroplasty, right? Anterior. Posterior is good for multi-level issues. And the two options for posterior surgery for myelopathy are typically laminoplasty or laminectomy and fusion with instrumentation. And of course, if you get into complex cases who are like kyphotic and you can't fix them from behind and you want to restore the alignment, then you may have to do a front and back type of procedure. Multi-level corpectomies, if they're extremely osteoporotic, we think about backing up our anterior surgery with posterior surgery to make sure the whole thing doesn't fall apart after surgery. And, if they're very deformed, particularly in the sagittal plane, we'll give more thought to front and back surgery. So anatomic considerations, just quickly, how many levels are compressed? Now, how many levels, the things we discussed with the patients in the office, well, how many levels do we have to decompress on you? Where is your compression? Is your compression behind the disc or is it behind the body? Obviously, if it's behind the body, it makes it harder to get out from an anterior because then we have to drill out the whole body and it's a little more difficult. We do that. It's called a corpectomy, but we have to consider all these things beforehand. What's the alignment of the spine before surgery? If it's kyphotic with a chin on chest, that's an issue. That may require a deformity correction. Sagittal plane flexibility. Well, okay, it looks kyphotic on the standing x-ray, but is that kyphosis fixed with severe spondylosis, or is it mobile? If I extend the patient's neck, does it come back into a neutral or lordotic position? We want to know all these things before surgery. So we get flexion extension x-rays like you see there. Is it revision surgery? Revision surgery poses a whole other host of issues that we have to be, wary of. General rules of surgical approach, very simple. Like Dr. Fischer said, if it's 1 or 2 levels, we try to go from the front if we can, preferably, because that direct decompression in the front we know is very effective. If it's 3 or more levels, particularly in older people, we'll think about back of the neck, laminoplasty or laminectomy infusion. And once again, if it's kyphotic and a really bad posture, bad deformity, we may have to do front and back. The benefits of anterior surgery, it's a direct decompression, right? Most of the stuff that's compressing is usually anterior. The discs, the bone spurs are usually anterior. So we have to drill those out in the front. They have generally less axial neck pain from the front because we're not disturbing the muscle in the back, and it's an expedited recovery. Limitations of front surgery. Oh, they get painful swallowing. They get difficulty swallowing, especially in the elderly. I just did an ACDF on a 78-year-old woman yesterday. Everything was great. Arm pain was gone today, but she's like, oh, my swallowing is a little difficult. So it's very common in the elderly to get dysphagia. So we have to warn them of that. But usually, 9 out of 10, it gets better within a few weeks. Pseudoarthrosis, obviously an issue. And of course, if you see OPLL anteriorly, that's one of our biggest fears, really, as spine surgeons. If we do OPLL anteriorly, it could be not fun, disastrous. You get dural atresia. You can end up with a large spinal fluid leak. So most of us, if we see a lot of OPLL ossification anteriorly, we'll typically shy away, except for isolated cases, and do it from the back of the neck. It's safer. Okay, benefits of posterior surgery. It's an indirect decompression. So you can do a multi-level cord decompression in an hour and a half, which is pretty hard to do if you're doing it from the front, because the front takes a little longer. And that would be through a laminoplasty, which is nice. A laminoplasty is a motion-preserving operation. It's a good way to give somebody space for the cord over multiple levels without putting any, metal in sometimes. No fusion, right? No metal, no fusion. It's a nice alternative. The limitations of a posterior surgery, well, it's an indirect decompression, but that could work actually quite well if the spine is neutral to lordotic. All right, they may have increased axial neck pain, right? Because you're cutting through the muscle a little. It is a prolonged recovery. Another problem that we see is C5 palsies. We've all heard about this. I can talk about this for hours. It's like tortured all of us in our offices. And my personal feeling is I've had more C5 palsies with laminectomy and fusion than I have with laminoplasty. There is some literature to support that, and there's theories behind why that is. But my own personal experience is I used to do a lot of laminectomy infusions, and now I'm shifting back to laminoplasty if I can, because I do feel that those patients have less of an incidence of C5 palsy. Obviously, if there's instability, there's other issues or deformity issues, you have to do fusion. But some of us, I do more laminoplasty now than I used to do in the past. We have to worry about if you do a fusion, obviously pseudoarthrosis. Of course, anytime we fuse, we worry about adjacent level breakdown. So some of us will stop at C7, and other of us, if we're concerned about junctional kyphosis at C7, T1, we'll put a couple more screws in and cross the junction to protect that postoperative junctional kyphosis that we see. Now, obviously, wound infections can happen with a posterior cervical versus an anterior. We don't see them with anteriors. We see them with posteriors. Laminoplasty, I like it. It's not for everybody, but in select patients, it works great. And it's a way of opening up, giving the cord room without fusing it. especially in a young person. It can work very nicely. Now, what are the outcomes? What's preferable, front or back? The bottom line is if you decompress the cord adequately and you leave them in good alignment, you get a good result either way. This study just shows is, ACDF versus TDR, as Dr. Fischer showed. If you decompress the cord, the neurological results are the same, but there's been some evidence to suggest that with total disc replacement, that there's a lower incidence of, adjacent level issues and surgery. So we do believe that, as we do more cervical disc replacement, that we are thwarting some of those secondary surgeries in some patients. Because we always say to all our patients, spine surgery is a great temporary thing. It may not last forever, right? It lasts as long as until your next level goes, and then they come back for another revision surgery. So spine surgery would be great if there was no such thing as adjacent level issues. We'd be hitting home runs all the time, but the reality is we hit a home run and they're back in 4 years with the same issue again very commonly. So avoiding adjacent level issues is very effective. So anterior versus posterior, which is better? Well, the results in the literature say also that I can't say that one is definitely better than the other. If you leave the operating room with the cord decompressed and the spine well aligned, you can have happy. That's the bottom line. Obviously, we said anterior surgery, you have higher rate of dysphagia and dysphonia. Posterior surgery, higher rates of C5 palsy and wound infection. Kind of pick your poison, right? So, but I'd say my practice is split half and half for myelopathy. I think I do half from the front and half from the back, depending on what the issues are with something like this. Thank you.
Dr. Bendis, one question from the audience.
Okay.
Do you offer surgery for myelopathic patients with stable cervical MRI findings for 5 years, previously declined surgery?
Okay, so this is a common thing. It just kind of goes back to were they clinically symptomatic or no? If they're clinically asymptomatic, I think, once again, you can follow these patients over time. And I've seen a lot of patients back that have been told they needed surgery. I say, don't do it. And they'll come back like years later with something else going on. Like, you told me not to do it. And here I am a few years later. I'm still okay. And that's a common scenario.
My question. The patient was myelopathic before. They came to me 5 years later. And I explained to them, they said, well, I do want surgery now. I said, look, I don't think we're going to make any better. It will prevent progression.
Yeah. So you think that's an uncommon scenario, to be frankly myelopathic, and then all of a sudden you're not clinically myelopathic? Oh. Well, listen, if they're clinically myelopathic and they have physiologic compromise of some sort, or physical compromise, I think it should be done because the prognosis is very poor. And listen, you have to factor in everything else: patient's age, comorbidity, bone health. I mean, it's not such an easy decision. There are some people with really bad looking pictures that I've said, something, what you got now. We don't know where you're going to end up after surgery because, you're sick, you got cardiac stents, your bone is really lousy. I really, don't want to do fusion here. So some patients will decide to sit on the sideline and not operate. Now, if this person you're telling me about is 100, very healthy, very amenable to surgery, good bone health, and a relatively straightforward surgery with a lower risk, then you may want to consider it. Every patient's different, unfortunately.
Oftentimes, it occurs correctly with Stenosis.
Yeah.
Can you tell the audience kind of your algorithm for what we prioritize?
Yeah, that's a great question. So the question is, to have lumbar and cervical stenosis together, how do you treat that? Well, first of all, somebody can come into my office with a cervical problem, and I'll diagnose a lumbar problem. Somebody can come into my office with a lumbar stenosis, and I'll diagnose them with cervical and lumbar when they leave. But the bottom line is, number one, you want 30% of people that have severe lumbar stenosis, which I think gets seen more commonly than cervical because that's painful. So those patients all get referred to us because they're in pain, they can't walk. So then we see all these patients with severe lumbar stenosis in the office, and then they we got to ask the question, what's going on with your neck? Because 30% of people that have clinically significant lumbar stenosis also have a clinically significant cervical stenosis. That may have to be addressed before the lumbar. So then you start asking questions. How are your hands? Oh, yeah, I got some numbness and tingling. Yeah, I'm dropping things. Yeah, my balance is off. If somebody's walking like this is not lumbar stenosis. This is lumbar stenosis. This is cervical stenosis. They have a broad-based gait, and they're very unsteady. So you have to watch them walk. You have to watch them walk, and you like that? You have to watch them walk, and but so you have to ask about the cervical. Now, if they're truly myelopathic, clinically myelopathic, that you think their gait disturbance is from their neck, their loss of function of their upper extremities is from their neck, you start asking about bowel and bladder control, and all of a sudden, yeah, the last year I got frequency, I got urgency that you may want to attribute to the stenosis. Then you probably do the neck first, because what Dr. Pashas was alluding to was cervical myelopathy, if it's clinically relevant, takes precedence over lumbar radiculopathy, which is lumbar stenosis. So the cord always takes precedence for most of us, because if we miss the boat, it's permanent. Whereas, usually lumbar stenosis, unless it's a catastrophic neurologic quine or something, can usually wait. Because it's, once again, it's nerve root dysfunction versus myelopathy, which is cord dysfunction. And cord dysfunction does not do well with waiting, unfortunately, for many patients. And many patients say, oh, if I only knew that, I would have done this sooner. We hear that all the time. You don't hear that too much from lumbar stenosis. Lumbar stenosis, they wait till they can't walk, they do it. And listen, you could also wait too long on lumbar stenosis if they have weakness. But cervical stenosis, a lot of people are regretful that they waited. So if they start getting real clinical symptoms, we may want to jump on that sooner. That's the bottom line, yeah. Any other questions? Or? Okay, thanks.
Okay, I hope everyone enjoyed lunch. We're going to get back to the lumbar degenerative session, and we're going to kick it off with our very own Dr. Michael Smith. He's going to talk about the evaluation and management of lumbar disc herniations from an operative and non-operative standpoint. Thanks again.
Thank you, Peter, and thank you all for having me here. It's a pleasure to be back here. I got to be part of this course for a number of years, and then I was gone for a couple of years. So this is my first time back, and obviously a little bit different in the hybrid, live, and virtual version. So I'm a neurosurgeon. I do spine, but I'm here with the orthopedic group, which has been a pleasure to come back and be part of the NYU Langone Orthopedic Department Spine Division. So herniated lumbar disc, pretty common. There's a 1% to 3% prevalence. Not to read through all this, but the annual incidence often strikes people, in their sort of active mid-years. Somewhat of a male to female prevalence, and the majority are at the bottom two levels, right? L4-5, L5-S1. And over all comers, approximately 10% is the number of disc herniations that will ultimately proceed to surgery. So if the main problem with a herniated disc is pain, right, then you manage the pain, right? Non-operative treatment, right? So simple as Motrin, various pain medications, oral steroid tapers, maybe some initial rest, then maybe remobilization with physical therapy. And then, of course, there's the option for intervention, pain management or physiatry intervention, epidural steroid injections. And in many cases, as the inflammation settles down, the body can reabsorb that acute disc herniation, symptoms get better, and person can move on without needing surgery, right? But so, and this is what I really want. I'm going to focus today on, the more severe scenarios, uncontrolled pain or significant weakness, like real neurologic deficit, and specifically as a surgeon, my question, can I tell a patient, look, I think early surgical intervention is going to give you a better long-term, short-term and long-term outcome? And is that an evidence-based statement? Because certainly intuitively, I think, or observationally for many of us, we see people with disabling pain or significant weakness. You take a disc fragment out and their foot drops partially improved in the recovery room, right? But that's observational. And what does the data say? And the problem is the data is not super solid. So does early intervention, meaning surgery to decompress the nerve, improve outcome? Or as the sport trial sort of overarchingly said, maybe everything's the same after 2 years. The problem is it's hard to study neurologic things, right, and spine things because we can't take like 10,000 myocardial infarction patients who came in and all had the same EKG, right? Everybody's different. There's a relatively small number compared to like hypertension or something. So it's really hard to do good studies. And the sports study in the end is terrible, as good as any other spine study, right? But, if only 25% of eligible patients enrolled, if 60% of patients assigned to surgery didn't have surgery and 45 to non-op had surgery, like, what do you make of any of that data, right? Because of the 75%, who are those 75% that never got enrolled? Well, it may be like we see somebody with a small disc herniation who you're not going to enroll in a study that may well assign them to surgery, right? Because they don't really need surgery. And conversely, somebody comes in agonizing pain and a severe foot drop. What are you going to do? Enroll that patient in the study? No. So intention to treat tended to favor surgery, but the ASH-treated group, meaning what actually happened to them, favored surgery. Both groups better by 2 years. And how do you use any of that information to actually talk to a patient in front of you, right? And especially, I think an issue as spine surgeons, the person comes with a new weakness, right? Like, do I say, yeah, go do PT, go take Medrol or prednisone, whatever, or should we just decompress the nerve? Are you going to have less chance of permanent deficit? And lumbar discectomy can be very helpful in the setting of weakness, right? There's a large L4-5 disc herniation. This is a nice picture because you have this more chronic contained disc herniation and a free fragment or sequestered fragment, severe canal stenosis, which would be severely compressing the L5 nerve. And so in this study, Lon et al., 75% recovery within a year, 84% with mild weakness, 55% even with severe weakness. It wasn't really a discussion of timing and wasn't a comparison to non-op treatment, but clearly decompressing a compromised nerve can have a benefit. But the problem is all of it's hard to study, right? And I just cut and pasted all these various studies of, efforts people have made, in good spine journal, BMC, European Spine, all trying to parse outcomes based on surgical intervention. And this conclusion of the one paper is just sort of perfect, right? An adequately powered, low risk of bias prospective observational study is required to further investigate prognostic factors owing to existing low/very low level of evidence. So obviously people study and write papers about herniated disc, but that's the conclusion. Our evidence is at best low level. So that's where we are. These are my words, intuitive, possibly proven, earlier decompression does tend towards a more rapid and possibly longer term, more complete recovery of the nerve root and therefore functional improvement. And so, for instance, this study in 2015, a systematic review, the conclusion that longer symptom duration adversely affected functional recovery after surgery. It's kind of hard to parse down where the magic cutoff is, and there's probably not one magic cutoff like 2 weeks versus 6 weeks or something, but they're saying maybe they said anything if you had a deficit for more than 6 months, that would be less favorable prognosis. And an older paper saying especially earlier, even 2 months. I thought this paper was pretty interesting. In a UK series, herniated disc with foot drop, right? There's a common thing that we see in our office, new onset of weakness, could be 4 out of 5, but could be 2 out of 5, right? And so just to stop a little bit on this and look at it, what is this weird graph, right? So it's weeks are on the y-axis. And what this means is that of the group, and reading down here, right? So of the 16 of 18 patients with symptoms for less than 4 weeks, they had made complete recovery, longer duration fared worse. Okay, so of the symptoms making complete recovery, their average duration of foot drop was only 1.1 weeks before they had surgery, right? So in the group that had an improvement but not complete improvement, their average duration of that group of partially improved patients had foot drop for 5.6 weeks. And the group that had no recovery, on average, had surgery after 18 weeks of foot drop, right? So the only ones looking at it this way, who made a complete recovery had early intervention within a week. All right. So I think that's an interesting manuscript. And their final thing too, because there's both duration and severity. So preoperative strength or severity of the deficit, obviously if you have a severe foot drop, well, not obviously, but what they found is a severe foot drop was a worse prognosis than a more mild foot drop. So this would be pretty good evidence that quite early intervention in the setting of a new acute neurologic deficit can have a substantial positive effect. So again, sort of intuitive, right? Longer the delay and the more severe the weakness, worse outcome. Again, multiple papers, but in this JBJS, the degree of recovery of motor function was inversely related to the preoperative severity and duration of the weakness, right? So, and that makes sense. And then here's the problem, right? Do you want to be randomized? If you have an acute herniated disc, you've got a new onset of foot drop, and, a week ago you were a 35-year-old playing on your soccer team, are you just going to sign up for a randomization study? I wouldn't. I'd sit there with the surgeon and say, is this, I'm not being randomized, I want what's right for me, right? So the data is always going to be poor. I don't really think we're going to have the definitive study that wraps it all up and says, here's like the grid of, exactly how every single patient should be treated. So the data is always going to be poor. You have to treat the patient sitting in front of you. What is a lumbar microdiscectomy? And here's part of the argument, I think, for considering surgery early is that this is a good surgery, right? It's a small surgery. I mean, it may be a little bit more than an inch, but if you do tubes, it's a 1-inch incision. Mine are 1.5 inches. It's usually an hour surgery, microscope, mini open, minimally invasive, minimal bleeding, can be done in an ambulatory surgical center. 95% of these patients sort of sit in the recovery room for 2 hours and go home. Limit bending, lifting, and twisting for 4 to 6 weeks, maybe post-op PT. Some patients come back and they're like, have no interest because they feel great. Their incision's healed. Their leg feels better, and they're like, I'll just go back to the gym. Others do want and, benefit from some structured outpatient physical therapy. Patients sort of guide you on whether they're willing or desiring of doing that or not. Again, this is a tubular-based discectomy with a minimally invasive tube coming down over the L4-5 level. That's a minimally invasive retractor arm. You can see it's an 18-millimeter diameter tube. So you're able to get this small, this discrete fragment of herniated disc off the nerve with really minimal disruption to the paraspinal musculature. And then this is from Montefiore Medical Center, probably 2008, but me doing a microdiscectomy, minimally invasively under a microscope back when. Just for all the non-surgeons in the audience, this is a bipolar. This is a hemilaminotomy. So this is a 1 centimeter by 1 centimeter window in the bone that we're making to get into the spinal canal under the microscope. This is actually, let's say this is L4-5, so this would be the L5 nerve coming past. That's a contained herniated disc pushing on the ventral surface of the nerve. And you can see we made a little incision in this capsule here. And this is actually herniated nucleus pulposus, right? There's the nerve being very gently retracted medially while we take out the fragment of disc. A quick case. This is actually, I did this case like 9 years ago or something, a long time ago. Minimally invasive fusion, which the guy did well from, but it does put stress on L5S1, right? This was the last case I did before COVID. Shut everything down back in March 2020. I was doing fine and developed an S1 radic, right? Unable to raise his right heel off the floor. Less than anti-gravity, and right gastroc, ambulatory dysfunction. This MRI again showing chronic degenerative disease, well-healed fusion, chronic degenerative disease, sort of chronic disc bulge, and then this defect there and this large superimposed acute fragment going distally behind S1. You see this there, just obliterating the lateral recess. So the S1, you can't even see the S1 nerve, right? The left S1 nerve is fine, the right one's severely compressed. He's got a fairly narrow canal down there too in the sacrum. We did an urgent microdiscectomy, and even at his 2-week follow-up, and then I'm not sure I saw him again because of COVID. At some point I did a televisit for what that's worth. But that was the large fragment of disc we took out, already partial improvement in gastroc function, and was doing well. So that's my talk. Questions, thoughts, are we taking virtual questions and as well from the audience?
I think we're going to do the question on the panel discussion.
Okay.
I believe you have to.
Yeah.
So, I have one question, Jeff.
Yeah.
Anyone in the audience have questions about this?
The study that really said that I'm not going to get any subset of patients like whatever, probably really should have surgery. Maybe those who had bladder weakness for 6 days, 3 months, 2 to 6 months, red might go with that.
Yeah. And then it becomes, it's getting the N up high enough is problematic too, right? When you've got this sort of narrow window, and you probably have to be across multiple centers. And, you know, I'm not trying to be nihilistic about the possibility of further intellectual academic learning, but it's challenging, right? And just the heterogeneity of, you know, if somebody's got 2 weeks of some leg pain, they take some Medrol and they're better, to the, you know, finding that, you know, parsing out the, and it is that middle ground, right? Because we're never going to operate on the mild one, and the severe ones, it's not really a big question what the right thing to do. But in that middle ground, some partial weakness, right? Maybe or you get this thing where they get better after the first couple of weeks in terms of the disabling pain, but then they get stuck at like 6 out of 10 pain and 4 out of 5 weakness. So they're better, but, you know, do you watch that? Which may lead to a worse outcome if it doesn't resolve, but they may, and we just don't have the crystal ball. So that's that challenging group in the middle, I think.
Any other questions from the audience? I just have I think it might be helpful for the audience, Mike, and obviously, you know, the surgical perspective, you know, is your area of expertise. A lot of times you're seeing these patients kind of later after the onset of non-operative treatment. But can you take us kind of through how, if you do see someone in your office, you know, with a new onset, absence of, you know, severe weakness, how you kind of manage them non-operatively and before making the decision for surgery?
Yeah, and I think, you know, in the ideal world, that patient wouldn't even see us, right? They'd see a physiatrist, anesthesia pain doc, maybe a neurologist, you know, sometimes end up in a neurologist office because, again, in most cases, you should try non-op, unless there's this, you know, absolutely uncontrolled pain or substantial new deficit. And I think something that can be very helpful when the patient doesn't have medical contraindication is oral steroids, right? Because a lot of them have already taken some Motrin or something by the time they see you, and they're like, it doesn't touch it. But you know, you can just write a Medrol taper. But if you really want to be more serious about a course of oral steroids, actually writing out more like a 10-day course of prednisone, 10 to 14 days, you know, can be more effective. And physical therapy, it kind of depends, right? Because sometimes people just need, early on, I think they just need to rest a little bit. But then I think it's often beneficial when they're already a little bit better. Maybe you give them some muscle relaxer, a steroid taper, and they're sort of 50% better. And I think starting, in my impression, sort of starting physical therapy after a couple of weeks can be more beneficial than trying to get somebody who's in acute pain to like go to PT immediately. And, you know, when I do see that patient as the primary person seeing the patient, I often will refer them on to one of my physiatry or pain management colleagues to say, hey, look, you know, you may or may not need an epidural, but go be evaluated. If your symptoms are persisting, you're still pretty significant discomfort in 10 days or after the steroid taper, that, you know, some interventional procedures. So I don't jump immediately to having somebody, you know, have an epidural, but it is a valuable tool, and certainly a significant number of people benefit from epidurals from that high concentration of the anti-inflammatory right in that area. You know, as I tell patients, look, none of those treatments resolve a disc herniation, right? They're all trying to get you through, you know, those first 4, 6, 8 weeks, during which the great majority of herniated disc, you know, 80% or whatever it is, should improve because the body's reabsorbing, you know, that acute fragment, right? And the term I tell patients, because a lot of people think it's liquid or gel. I'm like, it's not really. I tell them it's more like crab meat in the sense. I don't know if you guys have another analogy, but it's got this consistency to it. but it's hydrated and it's like this soft tissue, and the body can dry it out and shrink it down. And they're like, oh, okay. And I think that sort of resonates for most patients, that idea that, the natural healing mechanism of the body can actually bring the size of that down while the inflammation is going down. I'm like, that's why you're ultimately getting better. So, when you see that big, light, fluffy gray disc herniation fragment, it's pretty good chance that's going to get better in that 4, 6, 8 week time period with non-operative treatment. So,
excellent. If there's no further questions, I'd like to thank Dr. Smith, and we're going to invite Dr. Goldstein, Dr. Jeffrey Goldstein, our fellowship director, and he's going to speak on the evaluation and treatment of spinal stenosis. Yeah.
Thank you all.
Do I pull the slides up? Thank you, Dr. Passius, Dr. Jegede. Great. Great, so today I'm going to talk about spinal stenosis. We'll start with some nomenclature. I'll spend a little bit of time on the pathoanatomy, talk about the natural history, and then treatment, both non-surgical and surgical treatment. And then we'll sum up, and I'll be happy to take any questions from anybody in the room or anybody online when we're done. So obviously, everybody in this room, I'm sure, has some experience treating back pain. I don't know what everybody's experience is, but in the United States, we say about 80% of the population has episodic low back pain. Now, obviously, we're not operating on 80% of the people that come to see a doctor, but it is the most common reason that people will go see a doctor. And I think the key word is that this is episodic, meaning most people will get better. And just a small fraction of those patients will benefit from surgical intervention. But the annual cost of treating this low back pain in the United States is over $100 billion. And the most common source of low back pain is degenerative disc disease and lumbar disc herniations. There are patients who come to the office, have a muscular back pain, and have normal spines also. I mean, if you take 100 patients that are 30 years old that come into your office and have back pain, about a third of them are coming for other conditions. A third of them may have abnormal MRIs. So we can't just treat the MRI. We have to make sure that everything's concordant, meaning the patient's symptoms, the imaging findings, and the neurologic exam. So looking at the disc, which I said can become degenerative, the disc is composed of type 1 collagen in the annulus, which is this outer area around the nucleus, and the nucleus is type 2 collagen. The type 2 collagen in the nucleus helps facilitate water retention by the proteoglycans within the nucleus pulposus, and there's a hydrostatic pressure that resists axial compression of the spine. So when these become degenerative, obviously the functions of both the annulus fibrosis and the nucleus will diminish. So what happens is, over time, when the disc becomes degenerative, there's reduced water content of the nucleus, and this really occurs from the time we're born till the time we pass on. As the disc becomes degenerative, the type 1 collagen actually increases within the nucleus and the inner annulus, and the collagen degenerates, and you get upregulation of degradation. So this is a normal disc, and you can see as time goes on, as you get decreased water within the nucleus, you get distortion of the fibers, which are like a radial tire, and loss of disc height, and you get tears in the lamellae, and this can ultimately lead to a disc herniation or extrusion of disc material through the annulus. So we know that there's a genetic predisposition. I mean, many of the patients who come to our office are often worried that this is the same problem my parents have. I don't want to end up being like my mother when she's got elderly and that she couldn't stand upright. Well, that's not generally the case, and I don't like patients to say that their parents are going to put them in a hereditary predisposition to pain. We do know that there's a genetic connection, and if your parents have had degenerative problems, arthritis in their spine or elsewhere, that you're at a higher predisposition for it. So today I want to talk about lumbar spinal stenosis. Dr. Smith talked about disc herniations. And lumbar spinal stenosis is really a progression which implies narrowing of the spinal canal. And ultimately, when I see the patient as a surgeon, these are patients who have neurologic compression. And it's probably the most common reason that patients over 65 years of age have lumbar spine surgery. Disc herniations, as Dr. Smith talked about, I'll tell patients, although I see them in patients older than 65, you don't generally see lumbar spinal stenosis in a 25-year-old. I mean, certainly you can have congenital spinal stenosis, which is a non-degenerative issue, meaning patients are just born with a small spinal canal. But disc herniations, at least the ones that I treat surgically, are more common in the patients who are younger. And these degenerative changes don't generally just occur on their own. They often occur with other degenerative changes in the spine, including a degenerative spondylolisthesis and scoliosis. Excuse me. So you can see in this MRI, the spinal cord, as we all know, does not go all the way down the spinal canal. It ends at generally about L1, L2, becomes the cauda equina. This is all CSF, or cerebral spinal fluid. And in this area at L4-5, which is the most common area, see spinal stenosis, you see a narrowing of the spinal canal. These are the nerve rootlets that are trying to pass through this area. So spinal stenosis is multifactorial. It's a disc herniation, as you can see here, and hypertrophy of the ligamentum flavum posteriorly that ultimately leads to the spinal stenosis, which can become symptomatic. So looking at the pathophysiology a little closer, it starts off with disc degeneration, and you get arthritic joints. So here's a healthy spinal canal. This is the facet joint on the left side. And if you look at this arthritic facet joint on the left side, you can see how, as it hypertrophies, it's impinging upon the nerve that goes through the spinal canal within the lateral recess. You also see bulging or protrusion of the disc, which compresses the nerve. So if you have compressive disc protrusion, hypertrophy of the ligamentum flavum, and facet hypertrophy, all of these things lead to compression and neurologic compromise. These arthritic joints can lead to spurs or osteophytes. Ultimately, when you have compression of the nerve, you get loss of blood supply. The nerve becomes inflamed, erythematous, and that leads to pain in the lower limbs, which is the most common reason that we'll take these patients to the operating room. Patients say, I can't walk. And you have to differentiate that from other etiologies of difficulty walking, such as vasculopathy, especially on our older patients. So as I mentioned, the degenerative process begins in the disc. Cells, water, and proteoglycans decrease. The nucleus degenerates, so that ultimately leads to diminished disc height. And remember, the nerve lives in a neuroforamen, and it's a three-dimensional structure. So as the disc collapses, the neuroforamen becomes narrowed, and all of a sudden you have compression of the nerve within the neuroforamen. You can get buckling or bulging of the annulus, and then there's abnormal transfer of loads to the posterior elements, which increases the stress throughout the facet joints. Ultimately, the spinal stenosis is a combination of facet joint hypertrophy, osteophyte formation, buckling of the ligamentum flavum, and hypertrophy of the ligamentum flavum, ultimately giving you narrowing of the spinal canal and compression of the neural elements. Here you can see an arthritic facet joint compressing the nerve as it goes out through the neuroforamen. As I showed you in the other slide, this just characterizes it a little bit differently. A disc herniation or protrusion going through the annulus and also compressing the nerve anteriorly, the osteophytes posteriorly, and ultimately giving us spinal stenosis. When you have a patient come into your office that talks about difficulty walking, they'll often talk about some discomfort in their legs feel heavy. They don't necessarily have the radiculopathy that a patient with a disc herniation has. A patient with a disc herniation, they come into your office, they have a characteristic pose. They're sitting in a chair. They sit on one side of their buttock. They have difficulty sitting upright. Their leg is stretched out, and they're just trying to take the pressure off the sciatic nerve. These patients have pain when they walk, and actually they get relief by sitting. A patient with a disc herniation has a very difficult time sitting. They get pain relief when they forward flex, And the reason this occurs is because when you forward flex, take some of the pressure off of the disc, can actually decrease the pressure on the disc by up to 400%. And patients will, as you can see in this illustration in the middle, we call this a shopping cart sign, very characteristic. And if patients will often tell you on their own that they feel better when they're, go grocery shopping, or if you ask them if they feel better when they're on the cart, they'll say, "Oh my gosh, that's right. How did you know?" So these are older age patients, and it's often an insidious onset. The symptoms wax and wane, but get worse with time. I'll always get imaging if a patient that comes to my office. I always start with X-rays. I know many feel compelled to start with an MRI, but this is not the way most spine surgeons will evaluate a patient. The X-rays in the office, they'll show me a few things. It'll show me the patient's posture, their alignment. The full alignment of the spine comes with scoliosis X-rays, which I don't get on every patient. And also show me if there's any instability, and the instability is important to me because it affects the way I treat the patient surgically. This is a patient with a spondylolisthesis. We call this, we use a classification called the Myerding classification that divides it into quarters. So this is up to 25%. So we call this a grade 1 spondylolisthesis. Patients will often ask, well, thank God it's only a grade 1. Will it get worse? And the reality is that the most common ones we operate on for patients that come to surgery are grade 1s and occasionally grade 2s. I know it's disappointing to a patient to think that they actually have the one that may benefit from surgery, but patients with higher grade spondylolisthesis often have different conditions like a spondylolysis or an isthmic spondylolisthesis, and those often present when patients are much younger or in adolescence. The MRI, I won't necessarily get an MRI the first time I see a patient. Most of my patients will come with MRIs. But my point is that if you have a patient that shows up to your office and says, I've had this condition for a month, you do your examination and they're neurologically intact, there's no reason to have an MRI, especially if their symptoms are concordant with your suspected diagnosis of spinal stenosis with neurogenic claudication. But this patient had an MRI, and these are the facet joints. On the right side, you can see this facet joint. There's increased T2 signal in the right-sided facet joint, which is consistent with inflammation. On the left side, you can see that there's some gapping of the facet joint with increased signal. This is a synovial cyst, and patients who have instability of the spine, as this patient does with a spondylolisthesis, can develop a synovial cyst, which can cause a very severe radiculopathy. And when you look at the sagittal image, you can see the synovial cyst coming posteriorly off the facet, and at least on this sagittal view, causing significant spinal stenosis. So when you look at the treatment of spinal stenosis, as I mentioned, the disease is a continuum. The symptoms will wax and wane, but get worse with time. We will always, in a patient who's neurologically intact, as most of these patients are, try non-operative treatments. We know that that long-term, these non-operative treatments really don't change the natural history. So as we will typically prescribe anti-inflammatories to those patients who can take them, acetaminophen, and I know you've had talks already about physical therapy and epidural steroid injections. They will give patients symptomatic relief. So patients who are going to get better, trying these non-operative treatments might hasten their recovery or diminish the length of the symptom episode that they're having, but they really don't change the long-term outcome. But especially, as I said, especially for patients neurologically intact, we will try things very commonly like physical therapy, over-the-counter medications, and epidural steroid injections. So the surgical treatment of spinal stenosis is really decompression. That's the goal. That's most commonly by a laminectomy and decompression. As I mentioned to you in when I was showing you the pathoanatomy, the patients have compression from disc protrusions, ligamentum flavum hypertrophy, facet hypertrophy, osteophytes. So essentially, you want to take all the pressure you can off the nerve without destabilizing the spine. If you have to destabilize the spine, then that's a patient who you should plan preoperatively for a spinal fusion. And so taking the pressure off the nerve is most commonly, as I said, done with a laminectomy. That's a traditional procedure. This can be done typically at one or two levels with either as an outpatient or an overnight stay in the hospital. Really depends on the patient's medical condition, the anatomy, and how much work you have to do in the operating room. There has been this is more of a pain management procedure that using interspinous spacers. To try to, remember I told you one of the reasons that patients can have compression is because there's a decrease in disc height from disc degeneration. You can get foraminal narrowing as the disc space collapses, it compresses the nerve. So if you can theoretically distract the posterior elements and spread between the spinous processes, you can potentially offer the patients more room. The efficacy of these long-term has not been great and has not been consistent. Spinal instrumentation or spinal fusion is generally for patients with an unstable spondylolesthesis or anterolesthesis, or patients who have a degenerative scoliosis. So this is a patient that you can see on their X-rays has no instability, no spondylolesthesis, and has spinal stenosis and would benefit from a laminectomy or decompression. This patient, however, as I showed you previously, has an unstable spondylolesthesis. I'll often get flexion extension X-rays. You can see there's motion between flexion and extension. There's a grade 1 spondylolesthesis. This is the patient with a synovial cyst and increased signal within the facets. That's a patient that you may ask, should you do a spinal fusion? Busy slide. The only point of this slide is to show you that even in our best studies, these are both grade 1, level 1 studies that were done and published in the New England Journal of Medicine, both looking at slightly different patients with spondylolesthesis and spinal stenosis, both with differing conclusions about whether a patient should have a spinal fusion. So I think that most surgeons will agree that a patient has an unstable spondylolesthesis like the one I showed where there's motion on flexion and extension films, that those patients should have a spinal fusion at the time of their decompression. When we do spinal fusions, I think I think Dr. Fischer is going to talk more about spinal fusions, but you want to stabilize the spine. Your primary goal is to decompress the spine. You want to stabilize the spine. We'll often do this with an interbody spacer to get fusion in between the vertebral bodies, and then placement of posterior instrumentation or pedicle screws, which we can now do with robotic assistance in the operating room, so through less invasive approaches. This is a device called the Coflex, a surgical procedure where we'll decompress the posterior elements and then put spacers in to keep that area open. These are indicated for patients with spinal stenosis or with a low-grade instability. So, in summary, most patients who come into your office will benefit from symptomatic treatment of spinal stenosis. This generally occurs, as I mentioned, over-the-counter medications, physical therapy, and epidural injections. While these don't necessarily have long-term benefits, they do provide symptomatic relief, which is often all the patient needs to get over the episodic event that they're having. For patients who do have concordance of symptoms, physical exam and imaging, as I mentioned earlier, surgical treatment is generally very effective. You have a compressed nerve or a neural element, you take the pressure off, and you have leg pain, the pain generally goes away. This is most commonly by a lumbar laminectomy, and for those patients with instability that you can see on your imaging studies, those patients will benefit from spinal fusion. We talk about minimally invasive surgery. I think you have to be careful when you say that. I'll generally talk about less invasive surgery. And patients come in and they'll still ask for lasers or a scraping procedure or something like that. But patients who come in for minimally invasive surgery still has to be maximally effective, or patients are minimally happy. So if there's no, you want to take questions now, Dr. Passius, or wait?
I think we'll let Dr. Fischer speak, and then maybe we'll do a panel discussion if it's okay.
Great. Thank you for your attention.
Now we're going to invite Dr. Charla Fischer again. Who's going to speak about spinal fusion, when and how do we fuse, and we'll reserve questions for after that.
That's part one, and then there's part two.
I see.
Oh, wait, scroll through. Maybe it was pre-combined. Oh, it's
It's
perfect.
combined?
Perfect.
Great.
Thank you. All right. Okay. So I'm going to talk about spinal fusion, when and how we fuse, with a focus on the lumbar spine. And again, I'm going to try and keep us on time, so I'm going to talk really, really fast. No, I'm going to skip over some of the indications because a lot of indications have been discussed previously. We talked about lumbar disc herniations. So when are we thinking about fusing a lumbar disc herniation? If it's a recurrent disc herniation in an older patient, a third recurrent disc herniation in a younger patient, or if it's really foraminal, or if it's calcified. If it's been there a long time and you know that it's not a soft disc herniation that's going to come out easily, you may want to think about doing a fusion in those cases. Spinal stenosis, you might want to consider a fusion if the cause of the spinal stenosis is significant disc degeneration. So you know that you need to restore disc height in order to decompress the spinal canal or to decompress the nerves as they exit the spinal canal. So essentially you can do a laminectomy, but if there's some structural component, like the pedicles are too close together, then a fusion is going to restore disc height, and you might want to think about a fusion for those patients. And then degenerative disc disease. Similar to axial neck pain, back pain due to degenerative disc disease is a very less predictable indication for surgery. But if you have one disc space that is really worn down, then sometimes a fusion at that level can be very, very helpful. So in the right select patients. And then spondylolisthesis, as Dr. Goldstein was going over. If you have a spinal instability, then a structural support to fuse that segment is going to really help. And you can do an indirect decompression by reducing the slip, and then a direct decompression with a laminectomy or foraminotomy. And then there's scoliosis. So some people, as their discs degenerate, it degenerates symmetrically. It goes straight down. Other unlucky people, it goes down on one side versus the other, and that can kind of develop this series where multiple discs are degenerating but not symmetrically. So you start to develop a curve. You can see this in patients if they have issues like the L5 on S1 isn't really the best seating, or they start to angulate and then it starts to slip off to the side, a lateral listhesis. So you want to start to think about doing a fusion for these patients if there's a progression of deformity, or they have the deformity is starting to cause neurologic symptoms. It's starting to lead to stenosis or radicular symptoms because the nerves are getting compressed in the canal, or if they have overall global alignment problems, you want to restore that back to normal. So sometimes we can just do a little clean out for someone with scoliosis, but sometimes that can make the curve progress even worse. So we'll start to think about doing a realignment and fusion surgery. Okay, lumbar fusion techniques. So the posterolateral fusion is this sort of tried and true approach to the spine, sort of developed previously when we were doing fusions mostly for scoliosis and deformities. And this posterolateral fusion predates spinal instrumentation. So you make a midline incision, you open up the posterior elements, meaning the spinous process, lamina, and transverse processes, and you take the cortex off a little bit, you put some bone graft, and then you get them to fuse. Previously, before spinal instrumentation, we would cast these patients, serial casting, which sounds awful. And then now we start to do internal fixation of different kinds, and then pedicle screws were developed, and now we kind of have more of the system that we use today. There's also an inner body fusion. So you can take the disc out, put a spacer in, put bone graft in that disc space, and get bone to form where the disc was. It's asking a lot of the body, but it can happen. So you can either do that through the front, through the side, or through the back. When you go through the back, there's two different angles that you can go from. So one is called a posterior lumbar inner body fusion. You've done a central laminectomy, you retract the thecal sac over, you go directly posteriorly into this space. There's also the transforaminal lumbar inner body fusion. That's where you take the whole facet off and you go in at an angle through a safe space below where the nerve root exits, above the bottom pedicle, and there's a little triangle there that is used to access the disc space. So either way, you can stabilize. Most people stabilize these with instrumentation, pedicle screws and rods. And so there's multiple ways of getting through the disc space. It's sort of dealer's choice depending on the pathophysiology and the preference of the surgeon. Now, placing these pedicle screws you can do by directly looking at the spine. So a midline incision, you're looking at the spine, or a paramedian incision, and you're looking at the pedicle screw starting point. You can do it with X-ray guidance, fluoroscopy, or you can do it with CT navigation and robotic assistance, which is what I like to use. So robotic-assisted pedicle screw placement is basically we take an image of the patient, and then we match it with an preoperatively, and then we match it with an intraoperative image of the patient, and so that the computer knows where the patient's spine is relative to in space in the operating room, and then you can plan where your screws are, or you can use the navigation to show you where you can put the screws, and it's a very safe and reliable system. So I guess I do this a lot. So this is a video of sort of the steps of pedicle screw placement with robotic assistance, and this is similar to navigation. And so you can see on the monitor on the video that I'm able to see exactly where that burr is relative to the patient's spine, and then burr, drill, tap, stimulate the screw, or stimulate the tap, and then place the pedicle screw. And so this is a really nice option for either someone with very abnormal anatomy where their landmarks might not be reliable, or it's a very good option for minimally invasive. You can see down at the very bottom of the screen, my incision size for this single level fusion is very, very small. So this is my fellow stimulating the tap to make sure it's safe. So this is just a secondary safety assessment. Once that's complete, then I can drop the screw. So you can see that the technique for robotic assisted screw placement can be very, very safe as well as very quick. So this video, how long is this? It's like 1.5 minutes. So it takes about a minute, it takes about 90 seconds to put in one pedicle screw. And this is a close-up of the screen showing that I can see where that screw is relative to the patient, where it's going into the pedicle and vertebral body. So that's posterior instrumentation and pedicle screw placement. So a lot of stuff we do is from the posterior approach. Then we can also access a disc space from the front. And so you can have either the spine surgeon or a vascular surgeon do the approach to the front of the spine. Why a vascular surgeon? That's because once we get to the front of the lumbar spine, there are these large vessels that need to be slightly moved. Not a lot, but move maybe a couple of millimeters. So the best person to touch vessels is a vascular surgeon, just in case there's any issues. And then we get to the front of the disc, take the whole disc out, put a large cage, and then fill that with bone grafts and secure it with plater screws. And then there's also the lateral inner body fusion approach. So we can get to most levels of the lumbar spine, about L1 to L5, through the side. And so we can make a small flank incision and get down to the disc space, take the disc out, and put a cage across the disc space with bone graft. When going through the side, we're going through the psoas, and so there's the lumbar plexus in that area. So we use a lot of feedback from the neuromonitoring to let us know if we're near a nerve. We stimulate areas, and if we get any sign that we're near a nerve, then we need to reposition and adjust. So that's also another approach to the lumbar inner body fusion. So this is a video that goes over kind of combining a lot of our technology for getting to the lumbar spine and doing a fusion. I'm just going to skip forward so you can see in the surgery. So this is a single position case where the patient is laying on their right side and left side is up. Oh, let me press play. Oh, it is play. So the patient is on their right side and left side is up. So then we drape basically back, side, and front, so that at one time we can get the posterior instrumentation, we can do a lateral inner body fusion, and we can go through the front and do an A-lift. So this is just showing that with a lot of navigation and a lot of the newer technologies, we're able to do This type of surgery a little bit faster because we don't have to change the position of the patient. And we're able to do simultaneous approaches. So that also saves time for the patient. So this is a video showing the front approach, and then this is getting in the navigation markers for the posterior approach. And then we can bring in the robot or bring in x-rays for our merge with the robot. And skip forward. This is continuing the front, taking the disc out, and then we can bring in the x-ray and do our merge. So while the vascular surgeon is doing the approach to the front, we're able to do some other work at the same time, like putting in the screws through the back. And so here's a video just showing how we were able to do that. And so on the other side of the patient, the front of the spine is being approached. And so we're able to put in our screws while other work is being done. I'm a big fan of simultaneous work, not like work in parallel, not in series, because I can be a bit impatient. I know, shocker, a surgeon is impatient. So I really appreciate the fact that we're able to do multiple things at one time, and that gets the patient off the OR table faster. Ultimately, my biggest goal in surgery is to get the patient off the table as soon as possible safely. So that involves doing things at the same time, staying, and closing together with my fellows. So I'm really cognizant of time under anesthesia. And so this is just an example of a navigated lateral. So dropping in the retractor for the side approach, and then with the computer-assisted navigation, we're able to locate the level, and then our instruments are also navigated. So we're able to see where our instruments are relative to the patient. So we have both direct visualization and indirect. Okay, we can cut to the chase. That's the front. This is finishing up the back. And so this is what I'm able to do with the patient laying on their side, and instead of staging this over a couple of days, able to just do this rather quickly in like maybe 6 hours. So here's just a quick example. We're running behind on time, so I'm just going to skip through this. She had an L4-5 spondy, stenosis, both centrally and as the nerve root exits in the foramen. She had horribly arthritic facets, and then did a minimally invasive instrumentation infusion with a TLIF, or a posterior inner body. And then she had a CT abdomen pelvis at some point after the surgery. So I kind of like scrolled through that to take a look at the instrumentation, and everything looks great. And here she is at 5 months afterwards. So again, for lumbar fusion, we're thinking about fusion when you have spondylolisthesis, degenerative disc disease, scoliosis, or foraminal lumbar disc herniation, or multiple recurrent disc herniations. And then for fusion techniques, we have posterior lateral fusion, posterior inner body fusions, anterior inner body, and lateral inner body. Thank you.
Thank you, Dr. Fischer. That was excellent. We have two panel virtual questions here. One is, the first is specifically for Dr. Goldstein. It's a question in regards to the spinal stenosis talk. What patients receive Coflex versus a laminectomy alone in your hands? And Dr. Goldstein and Dr. Fischer, maybe we can get both your opinions on that.
So in my hands, I'm not doing the Coflex procedure. It is approved for patients with spinal stenosis and spondylolisthesis. I don't personally see the benefit of adding instrumentation to a procedure that doesn't have instrumentation. But that doesn't. But it's also fair to say that they actually have excellent studies, level 1 evidence that show that patients do very well with the Coflex. So it's a good procedure. I choose not to do it, although we were involved in the trial here at NYU Langone, and they do have excellent data. Dr. Fischer.
Yeah, my go-to for spinal stenosis, where I'm doing a laminectomy or non-fusion, is like a tubular laminectomy. So I agree. If you can avoid putting in metal in someone and just decompress and take bone and soft tissue, that's probably ideal.
Thanks for that. And there's one other question online. do you, by Ethan Sisman, do you evaluate bone quality and consider age before you decide to additionally fuse the patient? And how do you decide to do an interbody fusion or to not rely on one, use posterior fixation only?
Yeah, so I do assess bone quality in patients prior to a fusion, particularly if it's a multi-level fusion, more than 2 or 3 levels, or if it's a female patient over, let's say, 65. So I think that is a really important part of the picture, is making sure that you have good fixation in the bone. It can be a little misleading because if you have really a sclerotic bone in one particular area at one level, then sometimes that bone quality is pretty good, even though the rest of their bone quality may not be the best. But it's really important to evaluate. I get pre-op CTs for all of my fusions for surgical planning, and you can measure the level of the bone quality on the CTs, and that's been correlated with DEXA scans. And there was a second part to that question.
The interbody fusion.
Oh, right. Yeah. So you need to get bone to form somewhere, right? So if you're doing a posterolateral fusion, that may be enough. But for minimally invasive approaches that I use, I don't really do a posterolateral fusion. I usually do an interbody fusion. And the reason is that I don't need to expose the TPs to do the posterolateral fusion with a minimally invasive approach. So if I'm not exposing it, I'm not going to really try and fuse it. So I do a facet fusion, and then on one side, and the other side, I'm taking the whole facet out and getting to the disc space and taking the disc out and doing a fusion across the disc space that way. So I think you either need some sort of posterolateral fusion on both sides, or a TLIF with a facet fusion is like 270 degrees of fusion. Or if you do an A-LIF or an L-LIF plus a posterior fusion, that's a 360, because you can fuse both facets. So I think you do need some sort of posterior fusion at the facets, but not necessarily the TPs.
I think I have one last question, then we'll move on to the following panel discussion. We talked about decompression techniques, and we talked about various fusion techniques. There was an intermediate there with the Coflex. But a common question in the office we get is for other types of dynamic stabilization, particularly total disc replacements, and there's been some preliminary studies on other facet replacements, things like that. And in your practices, is there a role for disc replacements in the lumbar spine? Is it more relevant in the cervical spine? Can you give us some opinion on that?
Well, I think the difference, I think first you have to recognize that there's generally, from indications, a difference for cervical spine and lumbar spine disc replacement. Cervical spine patients, the indications are focused around radiculopathy, and in the lumbar spine, it focuses on degenerative disc disease or back pain. And in the lumbar spine, we're very selective about patients that we choose for back pain surgery, and that's a whole other discussion. But I think that for a patient who has some motion of the disc, who's failed non-operative treatment, you've identified the disc as the source of the pain. I think disc replacement is a good procedure because the studies have demonstrated that you can maintain motion and have less stress at the adjacent levels. And we do know there's a small risk, potentially about 25% risk of adjacent segment degeneration following a fusion. So in those patients, I will choose to do a disc replacement.
Yeah, I think the indications for a disc replacement in the lumbar spine are very narrow. So I think that it's challenging to find those patients who would benefit from a disc replacement, because the back pain is so multifactorial that it seems to be motion can aggravate that. So so I haven't really done a disc replacement, and I haven't found like an ideal candidate for that. But if you do have someone who's really, really healthy facets otherwise, and their paraspinal muscles are really good, then disc replacement could be a good option for them.
I'd like to thank the speakers for an excellent session. And we're going to move on to thank you. Okay, we're going to move on to the spinal tumor section of today. And I believe our first speaker is going to be Dr. Anthony Frempong, and he's going to speak to us about primary spinal cord tumors. Thank you so much.
Yeah, it's absolutely. Not sure.
We're on presentation mode. Just 2 seconds. Okay. You can see the upcoming slides there. So I'm just going to give a quick talk on management of intramedullary spinal cord tumors. Again, just for sake of time, there are a lot of videos, so I'll probably move through some of the videos a little bit quicker. By note of disclosures, this has nothing to do with this talk, but I have been a consultant from Medtronic in the past. So this is what we're going to cover, basically these five areas, and let's get to it. So we'll have some time for some questions in the back. So intramedullary tumors they're quite rare. They're only 5% of spinal tumors, and if you see the presentation here, so generally one tumor slash every 2 to 3 years per neurosurgeon. So most neurosurgeons don't actually see a lot of these tumors. The clinical presentation is really, as you would imagine, related to where the tumor sits inside of the spinal cord. So it's very related to, again, what structures and what pathways and what columns are disrupted by the tumor. They tend to invade and destroy white matter tracts as well as gray matter. So pain actually is one of the most common initial complaints: neck pain, back pain, pain that's worse with Valsalva, pain at night. So recumbency is very suggestive of intramedullary spinal cord tumors. If you have a child and they complain about waking up at night from back pain, get them an MRI. They might have a spinal cord tumor. The pain is described often as medullary pain, so the same as the syrinx, because these tumors are generally centrally located, and as they're growing out, they're putting pressure on the spinal structures from the inside out. So with medullary pain, you have the burning, you have non-radicular pain, often bilateral, and again, sometimes this is not affected by Valsalva. So sensory symptoms tend to be non-painful, but then you get, again, the syrinx-type presentation is syndrome, which is associated sensory loss, decreased pain and temperature with preservation of light touch. And you tend to get paresthesias in a radicular, or as I said before, medullary-type distribution. Motor symptoms are generally preceded by sensory complaints, and again, children will complain of nocturnal pain, they'll get gait disturbances, whereas adults, because they can tell you their symptoms, will generally present with long track signs. And oftentimes it gets confused with myelopathies. A lot of these patients will get sent to, non-operative care, physical therapy, things like that before they actually get worked up. And it also depends on where. If it's in cervical spine, then you'll have, upper extremity findings, hand findings. In the thoracic spine, you can have paraparesis, gait disturbances. Either one can give you bowel and bladder issues if it progresses for a long time. Sphincter disturbances, if it's in the conus, obviously you get earlier presentation. If it's not, then a little bit later. In kids, you get, scoliosis, torticollis, things like that. And you can have subarachnoid hemorrhage depending on, the particular tumor type. So if you look at mean duration of symptoms, the important thing on this slide is just that lower grade tumors present a lot longer than higher grade tumors. So 15 years for a grade 1 versus, just a matter of months for a grade 3 or a grade 4. Imaging studies to work up, MRI with contrast, that's the gold standard. That's the mainstay of a diagnosis. Sometimes angiography is very helpful if you have certain vascular lesions, things like hemangioblastomas, and other things that can help differentiate from spinal cord tumors, either dural fistula or an AVM, that can present with the same sort of symptoms a spinal cord tumor would present with. Differential diagnosis, anything that can give you myelopathic symptoms is in the differential diagnosis for a spinal cord tumor. So any of the things that you see, on this slide can give you similar symptoms that would make you think that you're having an intramedullary tumor, including things like extramedullary tumors. And so those are all things you have to think about. So a syrinx, as you see in this slide, can definitely give you symptoms that are identical to spinal cord tumor. On the MRI, look for things like a Chiari malformation, look for things like distant trauma, which can give you a syrinx. Demyelinating disease, one of the
most disheartening things to do is to do myelotomy and send a piece of tissue out and get back demyelinating disease. You really want to help differentiate that before you go in. So workup for demyelinating disease, look what multiple sclerosis do, a lumbar tap, look at the brain MRI to look for, UBOs and things like that. Here's the spinal cord in multiple sclerosis, and you see very circumspect, highly enhancing quadrantic pattern of enhancement that tends to point more towards demyelinating disease than a spinal cord tumor, intramedullary tumor, which tends to be more centrally located. And if you're not sure, time is a good doctor. Just wait a few weeks and repeat the scan. If the lesion disappears, it was probably a demyelinating lesion. This is just an example of unidentified bright objects in a brain scan on a multiple sclerosis patient. You can get some weird things too. You can get abscesses, you can get neuroenteric cysts. So there are some strange things that do present in the spinal cord that aren't necessarily spinal cord lesions. This is just a person that had a neuropsystostomiasis, and for all the world, we thought this was a spinal cord lesion. Just to see, this is getting into the spinal cord. I'm going to skip ahead a little bit just to show you that when you're actually dissecting and working on the lesion, it looks all the world like a spinal cord tumor. And I'll show you a tumor later on that looks very similar to this. We pull this out, send it for frozen, we see eggs, and you realize that this was not a spinal cord tumor. This is actually an infectious process that could have been treated medically. So you do sometimes see things like that. Skip ahead. Whoops, how do you get out of this? Click. It's not letting me skip it. Let me pause it first. Okay. Beautiful, thank you. All right. So here are the common intramedullary spinal cord tumors, and you have things like, the most common astrocytomas and ependymomas and all the other ones you see on the list. We'll spend a little bit of time on the top two, as they're the most common. So astrocytomas are 30% intramedullary tumors, and they're actually the most common outside the spinal terminale, and occur at all levels, slight thoracic prevalence. And you see their peak in the 3rd to 5th decade, slight male predominance, the infiltrating lesions, and they tend to be a little bit more eccentric and a little bit more difficult to remove, except for things like juvenile polycystic astrocytomas, which have a clear-cut plane between the tumor and the spinal cord. Oftentimes cystic, and the cystic fluid is very proteinaceous. There's just an example, H&E with astrocytomas, just to see that the tumor is infiltrated with neural tissue, which means that full excision can often cause disruption of the long tracts, and you can actually leave somebody with a fair deficit if you're overly aggressive in removing an astrocytoma. Except, again, for juvenile polycystic astrocytomas, which tend to push the tissues aside. I oftentimes describe intramedullary spinal cord tumors using a food analogy, that the tumor is a meatball and the tracts are spaghetti, and the spaghetti either goes through the meatball or goes around it. So an astrocytoma, the spaghetti is going through the meatball. So removing the meatball from the spaghetti, you can damage it. So it's kind of a dirty way to think about an astrocytoma. Here's just an example of one, highly enhancing. Low grade, those are ones that, have a much longer presentation. You see an expansion of the cord, but not as a great amount of enhancement. Ependymomas are another 30% of intramedullary tumors. These tend to be very circumscribed from the spinal cord and can actually be removed. You tend to get a very good plane with that. And you can see that you oftentimes have hemosiderin cap, and they tend to enhance very intensely. And this is an example of an ependymoma. Myxopapilloependymomas occur down the level of the conus and often involve the roots of the cauda. And those patients tend to present with bowel and bladder issues. And you can get CNS dissemination from these. If they break out of the capsule, they can go all over the CNS. You really should have a staging workup and get scans of the brain and the cervical spine and the thoracic spine. You can actually have systemic Mets, which I've never seen, but I've definitely read about that. Can you distinguish the two? Well, oftentimes you can, but not usually, and MRI is very good for that. But they have a lot of very similar imaging characteristics, so you really have to find a way to differentiate that. A lot of times you do that in the operating room, by sending frozen specimens, or here we have Raman microscopy, we can help do that also. You can have things like lipomas. You can also have vascular lesions like hemangioblastomas, and these all will present similarly from a symptomatic standpoint, but obviously very different when it comes to resecting these. And the vascular lesions and angiogram can be very helpful in diagnosis. It's just an example of hemangioblastoma radiographically. Cavernous angiomas, again, they often present with microhemorrhage, which tends to be acute, but it can actually, on repeat bleed, be catastrophic. And if you don't remove them, they will rebleed. And you will see hemosiderin on the MRI, and you get kind of a variegated popcorn type appearance. If you look over in this picture over here, you see how you can see the little hemosiderin inside of the lesion. Again, we talked about things that are little oddities like dermoids and epidermoids. These all kind of fall under intramedullary spinal cord tumors. You can have Mets. They're uncommon, but they do occur, and they tend to be very difficult to remove because they're very stuck to the neural structures. They're highly vascular, but you can differentiate them from cord tissue rather readily because they have a very different consistency. It's just an example of a Met in the cervical spine. The key thing here is to note just how different looking this tissue is from the surrounding spinal cord tissue. This particular Met was actually very firm, which quite frankly made it very straightforward to remove. You just had to differentiate and remove the attachments of the lesion from the spinal cord. And the key thing here is just not to overly manipulate the spinal cord during removal, and just extending the myelotomy to get below the lesion in order to find the plane between the lesion and the spinal cord. I'll skip ahead a little bit so we can start to see where the plane has been developed. And we're now actually dissecting the lesion free from the spinal cord. And you can see it's very different in appearance and characteristics from the actual underlying neural tissue. So these, again, they're sticky, but they're rather straightforward to remove because they're easy to differentiate. And we'll get into the issue of differentiating lesions very shortly. This is just another example of a metastatic lesion, and I'll skip through this. And resected, but quickly recurred. They tend to come back, so that's one thing with spinal Mets. Let's talk about the operative management of these lesions, and it really depends on the tumor type. I'm going to talk a little bit about the differentiation between things that you can really separate from the cord versus things where neural tissues are going through them. So it depends on the tumor type. Oftentimes they're surrounded by neural tissue that doesn't tolerate trauma very well, so you have to be very careful when you remove these lesions. And you need to know how to find the tumor, we'll talk about that, and when to stop and do enough of a resection without actually hurting the patient. You don't want to leave the patient with a deficit if you can avoid it. So you don't want to be overly too aggressive, and that just comes with time and kind of some of the adjuncts we use in the operating room. Quick timeline, a lot of early attempts, in the 1800s, the two-stage technique where they go in and split the spinal cord closed, come back a few weeks later and allow turgor pressure to actually remove the tumor from the spinal cord. It says the first success was in 1895. The patient was successfully resected, but then they died of an infection. So take that with a grain of salt. But a lot of continued improvements in resecting these lesions. And actually right here at NYU in 82, Fred Epstein was the first to use ultrasonic aspirator. And actually Dr. Flam was one of the first to use operating microscope to remove these tumors, also here at NYU. We have a lot of adjuncts, operating microscope. Things in the blue are things that are very common. Things in the green are things that we started doing here as of recently. I'll get into that. But there are a lot of things we use, especially important is neurophysiological monitoring, which allows us to have a real-time idea of how the spinal cord is functioning while we're resecting these lesions. So timeline on adjuncts, if you look at just using perioperative CT and MR, we now move towards we're doing actually intraoperative CT scans, we're doing diffusion-intensive imaging, and now we're actually using virtual reality and augmented reality in order to remove some of these lesions, and I'll show you an example of that. So again, here is a lesion, and you can see with tractography, we can actually identify where the lesion is within the confines of the spinal cord and really help differentiate the lesion from the spinal cord and give you an idea of what a safe corridor would be to enter into to remove this lesion. Of examples of tractography. You can then use the same data to recreate the image in three-dimensional space. And here's obviously your tumor and your spinal elements we have in green. I chose red because it kind of looks like a meatball because I like that analogy. You can recreate these images in 3D space in your office and actually manipulate them to get an idea of where you're going to enter your tumor. You can do bone work, virtually before you actually start doing the actual lesion. So the big question is, where is the tumor? In this case, it's not that hard to find. It's underneath this little black spot here because this tumor is obviously bled, and that's in hemosiderin. But otherwise, if you look at another part of the cord, it all looks the same. How do you find the tumor? So we used to use ultrasound. And so here you see solid tumor, you can see a cyst below, some edema of the spinal cord above. It's pretty good, but there are better ways to localize. Here you see it again, solid tumor and a cyst. This is what it looks like in the operating room, cyst above, cyst below, and solid tumor. But now we can actually use diffusion tensor imaging. We can actually use AR, VR, and actually identify the lesion before in real-time space. So where's the tumor? We can obviously see where it is now. We see the tracks going around the tumor. So we know that we want to resect things that are red, not resect things that are green. And here's another example. It looks like in the operating room, we can actually broadcast the location of the tumor onto the spinal cord. And this actually shows where the tumor is going to be once we get past the dura, start getting into resecting the lesion. Again, the lesion broadcast onto the actual field where we're operating. Again, an example of that with the dura open now. The large area is the size of the entire tumor. This area is what we're focusing on with the microscope at the time we're operating. And it, again, gives you an idea of this is the size of the lesion. This is the angle we're taking. Blue is the angle we're taking. Green is the direct on. So you have an idea of not only where the tumor is, but where you're looking, how where you're looking affects what you're going to see when you're doing your resection. As we're getting deeper into the resection, you see that the solid outline where we're looking is starting to match the jagged outline. So operative technique, you want to find the tumor. We use AR and VR localization for our tumors, and then you start your resection by actually cutting into the cord. With the ependymomas, you can find a nice plane. You can get around. You can generally tend to remove the entire thing. So I'm going to skip ahead a little bit just for time's sake and give you his mix of pap that's within the nerve roots. So you have to kind of dissect the nerve roots away to get to the tumor. But let's look at a tumor that was in the conus, and we found it with ultrasound. This is kind of doing it the old way. And here we go. And, we found it with ultrasound. We're going to the dorsal root entry zones. We're going lateral to the midline, and then getting into the spinal cord, and then identifying the tumor just based on where we think it should be based on the ultrasound. We'll get a sample, send it off for further section to make sure that it's not an astrocytoma. If it's an astrocytoma, you don't want to take the whole thing out because you can damage the patient. Here we are, localize the lesion. It's different to the cord. Like this is cord tissue over here. This is lesion over there. And apropos what we did with the cervical metastasis, you then dissect around it and you remove the tumor. The important thing here, though, is just the localization using ultrasound versus what we do today. So I'm going to jump ahead and show how we find a tumor today. And this is something we did, this is a little bit ago. We even have more advanced imaging now where we can then broadcast the tumor onto a model. And I can do this in my office where we can get to the operating room and really start to have a good feel for what I'm going to do when I get to the OR. And then get to the operating room and, again, broadcast what I'm operating on through my microscope on my actual operative field. So I know exactly where the tumor is. It actually, makes it a little more comfortable doing things like cutting into a spinal cord, which, of course, you're supposedly not supposed to do. But we actually do it quite often here. And again, I said before, the solid line is what I'm looking at. The jagged line is the extent of the entire tumor. So I know that my myelotomy has to encompass the entire jagged line, but you start working from a superficial to a deeper plane, again, with a lot more confidence because you know exactly where this lesion is, broadcast onto your operative field as you're moving ahead in your resection. Again, I had the full myelotomy there. I can then go back and keep checking it while I'm operating with a real-time intraoperative augmented reality. So we have it in the microscope. We have it on our pre-op imaging. We're using our eyes. I still have the ultrasound just in case, and you can see we're removing tumor from underlying spinal cord tissue. So a lot more accuracy in localizing tumors and gives you a lot more confidence in aggressively removing a tumor. And then just, again, real-time functional navigation. And I'll skip ahead here just for the sake of time, get you to resected bed and the tumor's gone. All right. So total removal sometimes is possible, but a lot of times it isn't, especially if it's an astrocytoma or something that involves nerve roots. You can get a very high amount of recurrence very quickly if you don't get a good removal. Removing the tumor, really a lot of it is dictated by, the neurophysiological monitoring. If you start to notice a drop-off in your monitoring, which shows that you're disrupting tracks, you're going to leave the patient with a deficit, I would say that you should probably pull out. Am I doing on time? Getting there? Okay. I'll show you quick the lipoma. It's the only place where laser is useful. Gotcha. I see my time up there. Okay. Cavanomas are well demarcated from the cord. You can easily get those out. And quickly show you a cavanoma if it's going to broadcast. And I want to show you just for one reason. It's on the ultrasound. You can find these. It's right there. It's right there where the black spot is. This is easy to find as opposed to the astrocytomas and the ependymomas. This might not play. If it doesn't, that's okay. It's going to play. All right. And I just want to show you that it's easily differentiated from the neural tissue. And you know it's right here because you see the discoloration. And I'll just jump in and show this to you. See the difference in the coloration? It's black. I mean, it's easy to tell a difference. So things like that are easy to find. But if you don't have something like that, then the way we're doing these things now are a lot more effective in making sure that you get a safe resection. Epidermal tumors, you get those. This is one that's in the cauda equina, and we're just going to kind of dissect through the roots of the cauda equina, find it. It was in the conus. There's a tumor right here, right there. Once you enter these, you can easily just evacuate them with the suction and get that out pretty safely. This had a capsule. We actually will dissect the capsule free out of the conus, pull it down into the roots of the cauda equina, and get a total removal of this lesion. All right. Go ahead here. So let's talk a little about prognosis and adjuvant therapy. So you get, better results if you have less symptoms going in. Recurrence rate, it depends on the things you see there, extent of resection, the natural history of the tumor, and obviously the histological grade. You can't really remove things that are very infiltrating. If it's poorly defined from the cord, you really can't remove it. And again, you have a high recurrence rate within 5 years. Prognosis is better for an ependymoma than for an astrocytoma because you can generally remove those. Our radiation therapy, a little bit controversial. We tend to use it, in high-grade lesions, but the result is the same. It's not really as known. Looking at future directions, we really need to do better with our imaging sequences to be able to differentiate bone from pathology, and we're working on that. We have a whole, it's a pretty large grant just working on, helping our imaging quality, imaging techniques, and bringing that to the operator room with real-time navigation. And it's just an example of some of the things we're working on now, and just a much higher resolution of soft tissue from bone. An example of that in the operating room is a picture from the operating room. And we're also doing advanced things with fusions, able to bring in intraoperative CT scan and then fusing that directly to preoperative MRI is very helpful. Example of that. All right. So again, uncommon tumors, MRI is a definitive imaging study. Here are your typical types, and you can't really resect an astrocytoma fully. Role of radiation and chemotherapy is unclear. The outcome depends on histology, preoperative deficit, length of follow-up, and how much you get out. So just want to thank you for spending some time and learning a little bit about this with me. And I enjoy tumors so much, even sometimes I want to be one. Okay. All right. Thank you.
Thanks so much for that talk. I think for the purposes of time, we're going to keep going. And Dr. Ilya Laufer is now going to talk to us about common primary and metastatic spinal tumors.
Well, thanks for having me and letting me talk about tumors. So I'll be talking about tumors that are outside the dura, and there are many, of course. One of the things that are sort of fundamental to tumor treatment in general is figuring out what are the options. And there are really three big categories: systemic therapy, radiation therapy, and surgery. I won't talk much about systemic therapy. I'll spend quite a bit of time talking about surgery and radiation, which has become a really integral part of how we take care of these. The goals of tumor treatment in general: local control, of course, and we do that through surgery or radiation. Sometimes systemic therapy, of course, can help with that as well. And then as surgeons, we care about neurologic function, and that means making sure that the spinal cord is decompressed as well as the nerve roots, spinal stability. With that, we can get pain control. And the important distinction is when we're talking about metastatic tumors, the goal is palliative. Most of the time, we're not curing the patient of their cancer. We're just really taking care of a local problem in the spine. And for primary tumors, sometimes our surgery treatment can be curative if we can remove the whole tumor. some of the major advances, and hopefully I'll illustrate them to you during this talk, are the fact that we've really done a great job over the last decade or so coming up with clear indications and recommendations and much more agreement around that. The advances in radiotherapy have really changed the indications and how we do surgery and the surgical techniques as well. I'll spend a little time talking about primary tumors. They're probably even more rare than the intradural tumors that Dr. Frempong was discussing, and it's a pretty broad range of tumors. They span anything from benign small tumors to really aggressive malignant ones. And some of them are more common than others, but the principles that I'll talk about when it comes to primary tumor treatment are probably common to all. One of the big things that happened probably about 20 years ago was really extension of the Anakin principles of bone tumors to the spine. And that really focuses on determining whether the tumor is a high-grade or a low-grade tumor, whether it has a good capsule, and whether it's actually which compartment it's located in, whether it's in bone, epidural space, or outside of that. And they can really affect how we treat the tumors. And then coming up with a common language for actually describing their anatomic location, because the anatomic location can dictate how we actually operate on these tumors. And that's the Weinstein-Borjani-Biagini classification. So depending on where the tumor is located, if we need to remove the tumor as a whole or even intralesionally, we can do it, say, as a vertebrectomy if it's located in the vertebral body. That's one of the common techniques. There's the technique of sagittal resection if the tumor is occupying a part of the vertebral body in the posterior element. So we're only removing, let's say, half of the vertebral body in that segment, or posterior element resection. And these are all quite well described by Weinstein and Borjani-Biagini. So as an example, this was a 22-year-old man who presented with back pain after lifting and good normal health, and imaging revealed a tumor in the thoracic spine with invasion of the vertebra. Biopsy was done, and that's always the first thing to be done for a primary tumor because the diagnosis will dictate whether we operate on the patient, how we operate on the patient, and whether the patient needs any type of preoperative adjuvant, such as embolization or radiotherapy or chemotherapy in some cases. In this case, we know that for chondrosarcoma, en-bloc resection is really the primary modality for treatment and provides the best chances of prolonged survival and cure. And that's exactly what we did for this patient. The tumor occupied a lateral part of the vertebral body and a little bit of the posterior elements and extended into the thoracic cavity. The patient underwent a sagittal resection with an excellent result. This was, part of it was done through a right thoracotomy, chest wall resection, long thoracic fusion, and partial corpectomy, and he did very well. Metastatic tumors are quite different. As I said, most of the time when we're doing surgery, it's really to palliate the symptoms, and those could be neurologic or instability symptoms. And sometimes it becomes really confusing how to prioritize the treatment options that we have. Does the patient go directly to radiation? Should we start chemotherapy? What's the extent of surgery? And the NOMS framework was devised in order to help make these decisions. And it consists of 4 decision points. Probably the most important thing that I'll say about spine tumors in general is that it's important to have a collaborative team where you can discuss things. And usually that team consists of radiation oncologists, an interventional radiologist, and sometimes a medical oncologist. And so we oftentimes, when we discuss these patients, really go through each one of these decision points individually. The first one is neurologic. Does the patient have symptomatic spinal cord compressional myelopathy or functional radiculopathy? And what is the degree of epidural spinal cord compression? Probably the most important message that I can leave you with when it comes to neurologic function is that time is spine. So if somebody presents, as they often do, to the emergency room with spinal cord compression and loss of ambulation, decisions really do have to be made pretty quickly because they're pretty compelling data to say that the sooner they're treated and decompressed, the more likely they are to restore ambulation. So evidence-supported guidelines recommend dexamethasone, surgery in the setting of neurologic deficit, especially if it's being caused by a solid tumor. And surgery should be done as early as possible and when it's safe to do for these patients in order to improve their chances of recovery. Fortunately, nowadays, the medical oncologists really know that if somebody with cancer has back pain, they should get an MRI. So oftentimes patients with cancer, with known cancer of back pain, are diagnosed much earlier before they present with neurologic deficits. And so it's not just the neurologic examination that determines the N component of NOMS, but it's the degree of epidural extension of the tumor. So oftentimes we can catch these tumors as they're invading bone and extending into the epidural space before they start causing spinal cord compression, and we can divide them into low-grade epidural tumors, which are bone-only or just budding the spinal cord, or high-grade. Those are the ones that are deforming or displacing the spinal cord. And depending on whether they're really compressive, those are more strong surgical indications, and if they're bone-only, most of the time we don't have to operate on them for decompression. The second part of NOMS is oncologic consideration. What exactly is the tumor? As I mentioned earlier, for primary tumors, we need a biopsy. For metastatic tumors, most of the time we know because patients come with a known diagnosis. And if they don't, we have a certain level of suspicion based on body imaging to say there's a large spiculated lung mass suspicious for primary tumor. But even in those cases, if the radiology is suspicious enough for a primary tumor without us knowing, a biopsy is still important to know, because a lung mass can be small cell carcinoma or could be adenocarcinoma, and the treatment for those are very different. This table actually summarizes the results of radiation to various tumor histologies that metastasize to the spine. And some of them respond to conventional radiation very readily and others don't. So we divide them into radiosensitive and radioresistant types of tumors. So things like lymphoma, multiple myeloma, those tend to respond very well to radiation. Things like sarcoma, renal cell carcinoma do not, at least not to the conventional type of radiation. So here's an example of a patient who was diagnosed with multiple myeloma spinal cord compression and underwent radiotherapy. And you can see how the tumor shrunk within 8 days of radiation. So the spinal cord was fully decompressed without having to do surgery. Same is true of prostate cancer. It's quite sensitive to conventional radiation, and after a few fractions, the epidural component resolved. We now have radiosurgery as well, and that's one of the fundamental changes in the way we treat these patients and the decisions that we make. And radiosurgery is actually much more effective in getting control, even for radioresistant tumors. So whereas 15 years ago, renal metastasis to the spine was largely a surgical indication because conventional radiation wasn't going to be effective, now we have radiosurgery that, as an outpatient single fraction procedure, can treat this tumor with very durable control without having to undergo surgery. The fundamental differences are conventional radiation is usually delivered in small doses multiple times, and it covers a very large area, and that type of radiation has been around for decades. And radiosurgery is delivered in a very focal way, exactly to the tumor, in a very high dose that could be completely ablative to the tumor, hence the comparison to surgery. But that requires more sophisticated planning, of course, and radiosurgical equipment. The effects are really amazing and very different from what conventional radiation used to give us. So whereas you saw the chart where I said, some of these tumors respond well, others don't, now with adequate doses of radiation that are completely ablative, we can overcome the resistance of these tumors and really have local control rates that are up to 98%, even 4 years out. And that's histology and volume irrespective. So radiosurgery is very effective under favorable circumstances. This can be done in single fraction or multiple fractions, depending on your institutional preference. It can also be even administered as re-radiation for previously radiated tumors. So if we put the N and the O together, radiosensitive tumors, so somebody presenting with lymphoma, can largely be treated with conventional radiation for spinal cord decompression and local treatment, irrespective of the extent of spinal cord compression. If it's a radioresistant tumor like renal cell carcinoma, those tumors should be treated with radiosurgery, which can provide local control. And if it's a low-grade epidural tumor, that can be done up front and definitive. If the tumor is causing spinal cord compression, there's still a role for surgery in those patients. One of those bedrocks, I guess, of spinal surgery treatment for metastatic tumors is the Patchel study that was published in 2005, where patients were randomized to undergo either surgery followed by radiation or radiation alone. And all patients had symptomatic tumors that are metastatic and solid in the spine. And so the surgical arm did much better. And this continues to serve as one of our strong indications for surgery, symptomatic spinal cord compression from solid tumor malignancies. I've been telling you that radiosurgery is very effective, and we can do it in many instances, but in the instance of spinal cord compression, we're unable to deliver a ablative dose of radiation without risking spinal cord toxicity, and hence we still decompress those patients. The third consideration is mechanical. So is the spine mechanically stable, or did the tumor destroy enough of the spine to cause mechanical instability? And borrowing the classical white and Punjabi definition, we define mechanical instability as movement-related pain, symptomatic progressive deformity, or neural compromise under physiologic loads caused by tumors. The SINS, or Spine Instability Neoplastic Score, is a very useful tool for trying to determine whether the spine is stable or unstable. And it can be used as a referral instrument for non-spine spine specialists, as well as an evaluation technique for spinal surgeons. And there are really 6 portions of it: location, whether the patient has mechanical pain, the quality of the bone lesion, whether it's lytic blastic, the spinal alignment, whether there is subluxation or deformity, the extent of vertebral collapse, and the involvement of posterior elements. And the score ranges from 0 to 18, with 0 to 6 being stable, 13 to 18 unstable, and 7 to 12 potentially unstable or indeterminate. Spinal instability is different from traumatic instability, for example. The bone quality and healing potential is quite different, as well as the integrity of ligaments. In order to sustain a significant fracture in the setting of trauma, most of the time the ligaments are disrupted as well. For tumors, the ligaments are pretty much never disrupted in any way, so they keep things together when the fractures look pretty awful. The healing potential is also different. Healthy bone and bone will heal. When you have tumor that's untreated, the fracture is very unlikely to heal. So when somebody's spine is unstable from a pathologic fracture, most of the time we need to stabilize it in order to provide pain relief. Radiation and chemotherapy don't actually stabilize the spine. And of course, we have many techniques that range from outpatient cement augmentation to percutaneous instrumentation to open surgical stabilization techniques. And then finally, systemic, the extent of tumor burden and medical comorbidities. We can recommend surgery, but if the patient is too sick or has tried 8 lines of chemotherapy and there are no more treatment options left, surgery may not be the best recommendation. And there are some pretty good survival estimation instruments that are available now, SORG being one of them, and several others. This is actually something that's available online and asks several parameters and gives pretty accurate estimates of survival prediction. And it's quite good for short and long survival, and then oftentimes we have patients who have longer than 90-day survival, and then hard to decide how to make that useful quantification. We looked at 20-year survival trends for a very large number of patients, and actually found that the survival and the 30 and 90-day mortality hasn't really changed that much over the years. Median overall survival is 8.5 months. 30-day mortality is 5% after surgery, and 90-day mortality is 24%. It's actually quite disappointing. Histology still matters a ton, and while there are many different systemic therapies that come to market and have really changed survival for some of the patients, majority of the patients are still not candidates for those and receive chemotherapy. And so the classic teaching that lung is not so great is actually still true for most of the patients, even though some lung cancer patients survive much longer than what we're used to. And it's important to know those differences. It's really been very incrementally improving over the years, approximately 1% improvement in survival over the years, with kidney, lung, and colon probably showing the biggest proportionate improvement over the years. So just to sum things up and to tie them up, I'll put up a couple of examples of how things have really changed over the years. So solitary renal metastasis in a patient used to indicate a very significant surgery 10 years ago. This would be a patient who would be recommended for en-bloc resection because the idea would be renal cell is slowly growing. The patient has 1 or 2 metastases and can potentially be cured of them by doing surgery. And the surgery was required because radiation was not really an effective option, and neither was systemic therapy at the time. So these are really massive surgeries. In order to do that type of en-bloc resection, it's many hours, front-back surgery, major blood loss, major recovery. Nowadays, the curve that I showed about radiosurgery being 98% effective holds true for a patient like this. And we also have data for kyphoplasty being very effective for stabilizing compression fractures. This was also a prospective randomized trial showing that kyphoplasty was actually quite effective in stabilizing pathological fractures. And I think while I guess the debate rages on in terms of kyphoplasty and osteoporotic fractures, I think for tumor-related fractures, it really is an excellent way to get these patients out of bed, get them quick pain control, and get them to systemic therapy. So that's exactly what this patient had. The patient had a compression fracture, which was that was symptomatic and was treated with kyphoplasty, outpatient procedure, which was followed by radiosurgery and never required surgery to treat this, and had many years of local tumor control without recurrence. The other shift is what we actually need to do with surgery when we take these patients to surgery, and how we integrate the principles of radiosurgery into our surgical decision-making. So this is a 64-year-old woman with cervical cancer presented with high-grade cord compression at T1, and she underwent something called separation surgery followed by radiosurgery. The idea is if we have radiosurgery and it can really ablate the tumor, how much of the tumor needs to be removed in order for us to safely do this. And basically, we need to create a few millimeters of space between the tumor and the spinal cord. We don't necessarily have to do full vertebral resection in order to optimize tumor control. So the idea is we create a separation between the tumor and the spinal cord, we decompress the spinal cord, and we stabilize the spine. A much more straightforward and easier recovery procedure than full vertebrectomy, especially depending on the levels. So that's the idea. We create separation and then treat the patient with radiosurgery. So this is a postoperative X-ray showing stabilization and decompression. There's a CT myelogram showing that the CSF is reconstituted around the spinal cord, and then the patient underwent single fraction radiosurgery. And we have good data to show that this is also quite durable in terms of local tumor control, over 90%, and with higher doses, 95%. And finally, MIS. MIS has really permeated all the surgery that we do in the spine, and it's probably particularly relevant for patients who require systemic therapy and radiation after surgery. So the better we can facilitate their healing, the safer the surgery, and the more patients we can help. And it's not just MIS approaches, it's also the instrumentation that we have. The fact that we can easily cement augment the screws has made a big difference as well. So instead of going longer, I think the classic teaching was always 2 above, 2 below for these tumors. We're much more comfortable going with shorter stabilization instrumentation. And so here's a patient that was undergoing radiation already for L3 metastasis, and at some point after a few fractions, couldn't actually lay on the table because they had so much pain because of the fracture. And you can see that this was an L3 fracture, occupying the pedicle and compressing the exiting nerve root. And so they required surgery in order to complete radiation. So if we take somebody for open surgery in the midst of radiation, we expect plastic surgery, and then we still expect some wound complications probably to follow. But with tubular approaches and percutaneous instrumentation, we can do this through very small incisions and get them back to radiation pretty quickly. And these do heal very readily. And that's exactly what this patient has. I'm a big fan of fenestrated screws. I think they really facilitate cement augmentation of the screws. And I think we've become convinced that we can go shorter with these constructs. I've never seen one of these pull out. Of course, navigation makes a big difference, especially if we're trying to be targeted for tumor decompression, so we can target our tubular or expandable retractors. Oftentimes, the anatomy is disrupted and the posterior elements are lysed. And so knowing exactly where you're docking without having to push very hard could be important and helpful, and that's where navigation is very helpful. And we also know that we can improve quality of life for these patients. Their pain control improves, their mobility improves over the years, and same with stabilization for unstable fractures. Actually, of course, intuitively, the more unstable the fracture, the bigger pain relief we're able to give these patients because the more severe their symptoms. So hopefully this was a reasonable summary of primary metastatic tumors. I think the takeaway messages are tumor type is critical to know how to treat the tumor and how to prioritize treatment options. Consider NOMS as a way to make decisions for these patients, as we have pretty good indications and consensus guidelines. And SBRT and some of the minimally invasive surgical techniques have really made a big difference in how we treat these patients. Thank you.
I'd like to thank the speakers for 2 excellent talks. We don't have any chats and questions online. I have a quick question for Ilya, if you don't mind. Can you tell us a little bit, I think for the audience, about the workup of these patients, prior to getting to intervention? I think it'd be helpful.
Of course. So biopsy. prior to that, oftentimes we want to get at least a chest, abdomen, pelvis CT, some tumor marker labs. I don't get too much into tumor marker labs myself, but I think an SPEP, which is, an early way to diagnose multiple myeloma, is one of the standard ones that I always order. But otherwise, I think chest, abdomen, pelvis CT, that can show you the mass probably in a more readily comprehensible way than a serum tumor marker. Oftentimes, a PET scan is also part of that. If we find a tumor on, let's say, lumbar MRI, and we don't have a full spinal imaging, I really like to get that as well, especially in the setting of metastatic disease, because oftentimes we're surprised by how unsymptomatic some of these tumors can be when they look really terrible from a fracture standpoint or from spinal cord compression, because you can actually have pretty extensive spinal cord compression without symptoms. So I think that's the basic, but I think biopsy.
Okay, any other questions in the audience? Okay, I think we'll take our coffee break and come back in about 10 minutes. Thanks.
I appreciate everyone for staying late on a Friday afternoon. But I could totally understand why you're staying. To pediatric spine deformity, something that's been a passion of mine. And today we're going to talk about the evaluation and treatment of pediatric spinal deformity. Here's my disclosures, which are not relevant to our discussion today. So, what causes a children's spine to deform? Okay. That's something that there's many different disease processes that can cause that to happen. The focus of it and the overwhelming number of cases in terms of volume that we see is in idiopathic scoliosis. Okay, but there are other deformities such as spondylolisthesis and kyphosis and spinal tumors that we see here at NYU and treat on a regular basis. But by far, probably greater than 80% of them are idiopathic scoliosis. So today I want to talk about 2022 state-of-the-art evaluation and treatment, as well as how to properly evaluate the deformed spine in a child. I'd like to discuss some surgical principles and give some updated research on non-surgical management. So where are we in 2022? Unfortunately, in 100 years, we still have reached a final common pathway of a long bony fusion from a once mobile polysegmental system. But the alternative of not fusing a spine and not controlling these deformities is leaving a worsening deforming spine to its fate with a cosmetically unacceptable deformity with rib humps and waist asymmetry, as well as shoulder imbalance. And these larger curves often give back pain and back fatigue. And the larger curves give cardiovascular compromise and pulmonary impairment. So I would argue there's got to be a better way. And, I think ultimately the holy grail would be a non-surgical strategy to modulate and control the spine, of which we do not have. So obviously, you really can't tell where you're going unless you know where you've been. And, we rely on our giant predecessors in terms of surgeons who have given us the guidance to where we are today for treatment of scoliosis. This is Russell Hibbs, who's credited as the first to do a posterior fusion to control a deforming spine, which is for Pott's disease. He's actually credited for studying it and publishing on that. And Paul Harrington, over here on the right, has published a book, Dodge Persistence, if anyone's interested in spinal deformity, which is a wonderful book, which talks about his career and his experience of dealing with polio in the 50s. At a time he moved to Texas, where the polio epidemic was at its worst, and he was charged with trying to control this infantile paralysis that was happening with all these kids with polio, and how that treatment has evolved, and the creation of what was known as the Harrington rod, which the initial design was actually a hook on the top and a hook on the bottom with a rod in the middle, which was really not a fusion, but just a way to control the spine until hopefully the polio disease would improve and the patients would regain function. Later, it incorporated a fusion. So let's talk about idiopathic scoliosis. So the definition of idiopathic scoliosis is a lateral curvature of the spine with rotation. Okay, so it's a three-dimensional deformity. Just having the tilt that you see on X-rays is not the scoliosis. The three-dimensional deformity of the rotation and the tilting is what happens with scoliosis, and that creates a torsion. And we call it idiopathic scoliosis. It's a diagnosis of exclusion. So you have to know that all other causes of scoliosis have been excluded. So any problems along the spinal axis or spinal dysraphism, Chiari's, syrinxes, tethered cords, you have to make sure all of that is not part of this person's deformity. So as far as the types of idiopathic scoliosis, we have infantile. Basically, it's categorized by age, so infantile, juvenile, and adolescent. You can also classify it based on the disease associated. So the neuromuscular scoliosis is something that we see commonly here at NYU as well. And also conditions which causes scoliosis. Sometimes I'll see a child with a large disc herniation and they walk with a scoliosis, and even if you take a picture, you'll see a scoliosis, but they don't have the three-dimensional deformity. And sure enough, when you take the disc off the nerve, they straighten back up. So here's an example of two of our other children here that we treat here. This is a neuromuscular condition that causes a typical C-curve, okay? And the image on the right there is a early onset scoliosis, which is caused by this child had neurofibromatosis. But you can see it's young. His triradiate cartilage is open. So this is a person who gets treated differently than we treat the adolescent idiopathic scoliosis because they're at a different phase of growth. And we have to take into account the fact that we have to allow that spine to continue to grow as we're modulating or trying to control the spine. So what causes idiopathic scoliosis? Okay, so we have numerous studies to support multiple things which contribute to scoliosis. Genetic causes, so we know that 30% of kids have a positive family history. However, it doesn't help us figure out if that child is going to need surgery or not. We do know when we examine the children with idiopathic scoliosis, they have alterations in connective tissue. A lot of them have hyperlaxity and long trunks, which can make them prone to curve progression. We also notice that there's CNS as well as deficiencies in their equilibrium. I think probably over the last 10 years, the best evidence that we have is this uncoupling of the rate of growth of the spinal cord with the rate of growth of the vertebral bodies. And the EOS X-rays have helped us understand the contribution of the asymmetric growth of the spine as a major factor in the progression of scoliosis. However, independently, all these factors are inconclusive. So our common consensus when patients ask us in the office is that it's multifactorial. So the evaluation of these kids is just like anyone else in orthopedics or in medicine. You need to do a thorough history and physical. And for me, I asked the parents, how was it discovered? Was it discovered by the pediatrician? Was it discovered by the patient? Was it discovered on school screening? Because we know if it came in from a complaint from the parent, it's less likely to be a significant scoliosis than if it came in from the pediatrician. Is there pain associated with it? Are there neurological symptoms? What was the birth history, developmental history? Was there early intervention? And most importantly is where are they in terms of their growth? Did they start their menstrual cycles? What is their Tanner staging? So here's a typical scoliosis. And some of these findings are very subtle, but when you look at them, you can see the asymmetry, and that's really what you're looking for. Their skin patches, hair tufts, midline defects. What do they look like? Is the head over the pelvis or the shoulder height's elevated? So the typical curve you're going to see is a right-sided thoracic curve. So if there's a right-sided thoracic curve, you're going to have a right elevated shoulder, okay? And some of these things are subtle, okay? And, the bigger the kids are or the more muscle mass they have, the harder it is to see and the better that they're going to be able to cover it, okay? But you could see there's asymmetry here. You could see the scapula on the right side, but you don't see it on the left side. And that accounts for the rotation that typical right-sided thoracic curve is going to give you. You also see some waist crease asymmetry. When we see the lumbar curves, it's very often the mom or the pediatrician will say, I think something's wrong with the hips. I think that the leg lengths are asymmetric because the hips don't look right. And the hips are fine. It's just what happens to the spine after it leaves the hips. So here's the pelvic brim here, and then there's a lumbar curve here. Okay. So in addition to the static structural exam, you need to watch the patients bend, and you need to see, especially if they're going to require surgery. Because for me, when I have the children bend, I want to see where their forward motion's coming from. So when they bend down and touch their toes, typically, especially on the females, you'll see a lot of the motion comes from the pelvis. And if a lot of the motion comes from the pelvis, then I worry a lot less than when I'm fusing that spine. But if a lot of the motion is coming from the spine, and I'm fusing that spine, those patients typically wind up very stiff. So forward bending Adams, again, this is showing you the rotation. So when they bend over, you see the rotation, and this is the rotation that you'll see on a typical right-sided curve. You can quantify that with a scoliometer. You can get them on Amazon for $10. But essentially, once you have a significant curve, you want to measure that. And the way that we measure it conventionally is called a Cobb angle. And the way that you measure a Cobb angle is essentially you take the curve from the bone that's most bent up top, and use the top of the top bone and the bottom of the bottom bone, and you make a 90-degree line, and that creates an angle, and that angle is the Cobb angle. Okay, and that's different than most pediatricians. When they do it, they're going to give you the number, which is basically the scoliometer reading, and the scoliometer reading is different because that's measuring rotation, which is different than what the X-ray is measuring. That's measuring the Cobb angle. Okay, and the Cobb angles are a lot more concrete because the rotation isn't always linear with the bending of the spine. Some kids just have some rotation, and they don't really have scoliosis. They just have a little bit of asymmetry in their chest cavity. So natural history. So what's important about it, right? We want to know what happens. This is what parents ask us. Okay, well, what's going to happen if we don't treat this? Are they going to get a backache? Are they going to stop breathing? Are they going to have pulmonary dysfunction? Are they going to die? Are there going to be some issues of having a funny-looking spine? Are people going to make fun of them? These are the questions that people ask. So as far as backaches, 40 to 60% of patients complain of backache. So, always on the test exams and for our residents, we always say that idiopathic scoliosis shouldn't cause back pain. But we do see, if you really ask these kids, they're uncomfortable, and especially with the larger curves. And, they'll come home from school and they'll lay down. Like, that's not normal for a kid to have to lay down because they're fatiguing. But if you ask them if it's pain, they say, it's not pain, I just got to lay down. And that's not normal. So I find that when I really question these kids, they do have a degree of discomfort. We won't say it's pain. But pulmonary function, again, you will see changes in pulmonary function. Nothing that the kids will be able to pick up, but enough that you'll see it on pulmonary function tests, and that's usually in vital capacity and expiratory volume. Psychosocial, again, it's very regional. Obviously, in the 70s, it wasn't as big of an issue as it is today. Cosmesis isn't something that's readily treatable. So kids, kind of come to the office saying, well, everything else is repairable. Why can't I repair this? And again, that's not a reason to do scoliosis surgery. The main reason, the one take-home message from this lecture should be the reason to do surgery on scoliosis is to control the progression. It's the only thing that the surgery can reliably do is prevent progression. Okay, and what happens if you don't treat it as a kid? It goes on to become scoliosis in adulthood, and this is a whole different set of problems, which is beyond the scope of this lecture. But it is a much bigger problem to treat. But if you don't treat it as a child, our studies show that you could expect about 1 degree per year. Even though I hate to use that because it's such a generalization, we have adults that progress 20 degrees in 1 year, and we have adults who don't progress at all, and they do fine. I have plenty of 50-year-olds that I follow, and their scoliosis hasn't changed a bit. But I do continue to follow them for other reasons: bone density, loss of disc height through their or loss of their curve through degeneration of the discs. Mortality rate of scoliosis is comparable to that of the general public, However, there is an increased risk of morbidity and mortality once the curves get above 100 degrees. And that's typically the juveniles who go on untreated. And that mortality is usually pulmonary hypertension and right heart failure. So curve progression, typically the thoracic curves will present earlier, and they're more likely to progress than the lumbar curves. And the double curves typically progress more frequently than the single curves. And the most important thing is that you need to correlate is where they are in terms of their curve magnitude, the Cobb angle, to where they are in their growth height. And this is why. This number right here. So when I'm seeing a 20 to 29 degrees, which doesn't seem very impressive, but the person is at a RISR 0 or a 1, the chance of that person progressing is 70%. So the chance that person needing surgery is very, very high. Whereas if I get a RISR 2 to 4, that's 19 degrees, the chance of progression in that person is only 1%. So it's major, major difference. And the major difference is the amount of remaining growth. Okay, so predictive factors, obviously, things related to being earlier in terms of skeletal maturity have a much higher chance of progression. Things that factor non-progression is someone who's older, a single curve, maleness. So the incidence of females progressing is 5 times the incidence of what males progressing are. Even though the incidence of scoliosis in males and females is the same, just to have the diagnosis of scoliosis, it's the same. But the chance of a female progressing is 5 times higher. Okay, so skeletal maturity, we talked about that before. This is the RISR sign. Okay, we know that skeletal maturity on the iliac crest progresses posterior medially, and we grade that. We also use the hand. We also correlate that to bone age with established norms. This is something that I do routinely, especially when I'm trying to figure out when to get a kid out of bracing. But essentially, curve at presentation. This is for the residents that are often get tested on this. If it's less than 25 degrees, our treatment is observation, which is a treatment. 25 to 29 degrees in New York, I brace, and up to 40 degrees. And typically my cutoff for surgery is greater than 50 degrees because I need to prove to myself that that curve is progressing. Because again, that's the only thing that I could tell them that the surgery is reliable to do. So the treatment indications, again, 20 to 25 degrees, there is a gray zone. But again, I think in New York, I think it's safe that we should be bracing children at that. I have hundreds of kids that I braced successfully. I do a full-time bracing regimen, which we'll talk about. As far as treatment options, short of surgery, so once they're at that 20 to 25 to 30 degree mark, what are the options? And again, these are questions that are often asked in the office. So it's what can I do about this? Because very often patients are not happy with saying, well, we're just going to keep an eye on this. And it's like, we'll just come back in 3 months and see what happens. Well, what if it's bad? What if, is there something I could do in the meantime? So some of the questions is manipulation, chiropractic manipulation, exercises, electrical stimulation, which has gained some ground on the internet, and orthotic treatment, which is really, for us, is the mainstay of treatment. However, there is a society on scoliosis, orthopedics and rehab, which is a European society, which is really started in 2005, but has really gained some ground, and it really fosters the concept of a multidisciplinary team. It's really fostered by rehab doctors in Europe who treat scoliosis, and they've really done some really good work and published some really good studies on bracing and exercising. Unfortunately, there was a study in 1979 that was published in Spine, which had shown that exercise plays no role in the treatment for scoliosis. However, if you really analyze that study, it's really only 4 out of 42 patients who actually participated fully in the study as it was written. And again, this was in the 70s when females had very few exercise options for them and did not have the same degree of fitness. So there's been evolutionary. There's been evolution of different treatment options and different physical therapy-based options. Schroth is kind of a buzzword, which we hear about in the office all the time, which is a scoliosis-specific exercise regimen proposed by Katarina Schroth and it's been published in a book, which is readily available on Amazon for a soft cover, which is very cost effective. There's also a CAS protocol, which is Scientific Exercise Approach to Scoliosis, as well as traditional exercises and global posture education. And there's a hybrid of similar crossover in all these protocols, but the focus is essentially different than just going for generalized physical therapy, where in these techniques you're essentially stretching the concave side, you're strengthening the convex side, and you're focusing on postural awareness as well as breathing techniques. And there's something to it, and we have a lot of randomized trials that are underway outside of the U.S. as well as inside the U.S. that show some promising results. Okay, and this is from Schroff's book here. So, but however, the mainstay in the U.S. is still bracing for these curves that are progressing, and the indications are basically skeletally mature. So if you have somebody who's coming to you and they're 17, 18 years old and they have a 30-degree curve, there's no role for bracing. These fall into the category of low-yield bracers, and that is 4 and 5s. Okay, but skeletally mature bracers, 0, 1s, or 2s with a curve of 20 to 40 are the ideal bracers, and that goes back to that slide I showed you with the 68% chance of progression. They should be braced. Okay, the indications, as I mentioned, they have to be compliant to the brace. Again, there is a dose response. Their full-time brace, a full-time brace wear has better results than a part-time brace wear. The Milwaukee brace, if you need to control the proximal thoracic or the upper main thoracic curves, it's very hard to get kids to wear this, but I do have a couple that are in a modified Milwaukee brace, which incorporates the cervical spine. Typically, the TLSO is what we use, and it's indicated, again, that the apex of the curve has to be below T8. But however, it works completely passive, so it modulates the curve. It modulates the growth of the spine. It does not correct the spine. It doesn't bend the spine to be correct. It does improve cosmesis as well as patient compliance when we incorporated the TLSO. There are other ones that patients are constantly asking us about. Spine core brace is a flexible brace. We have nighttime bending braces for kids that absolutely will not wear the brace during the day. I put them in a bending brace, which hyper-corrects the curve. Basically, the braces are very regional. A Chenot brace is something that's commonly asked for in my office. I don't know, they must have a very good internet presence. But that is a 3D that de-rotates the spine, and that's what they report. But if you talk to the orthotists, they tell you that they all kind of try and push on the spine to get it to de-rotate. So as I mentioned, it's 23-hour a day bracing protocol. We constantly have to adjust the braces because these kids are typically in their peak height velocity, so they have a change. They're changing, their body's changing, and we have to make adjustments because of that. I tell the patients to continue to wear it, and once they're done in terms of their growth, then I wean them out of it. As far as brace classification, and again, this is from the SOSORT, there's nighttime rigid bracing, as I mentioned. There's the soft bracing, which is that spine core brace. There's part-time rigid and full-time rigid bracing. And again, the full-time rigid bracings tend to do the best. Again, I take a picture of them in the brace and to make sure that it's doing its job. If I want to make these poor kids wear this brace every single day, 23 hours a day, I want to make sure that it's doing its job. It should reduce the curve 50%. If not, I send them back. The results of orthotic treatment are very good. They're not as good as I'd like them to be. Obviously, if they were very good, we wouldn't have to do surgery anymore. But I could save 3 out of 10 kids from needing surgery if I catch them early enough in terms of their skeletal maturity. But what happens essentially is it initially looks really good, and then once they graduate from the bracing, you get a gradual loss of correction. And on average, you get about 10 to 15% improvement when they're done with bracing. But when you continue to follow them at 5 years or more, it falls back to where it started in terms of the bracing. But again, as long as that's less than 40, the chance of that progressing is low. So it's worth doing. The Depending on how you rate failure for bracing, it's 40%, and this has been our problem. And trying to get a kid to wear this every single day, full time, for something that has a failure rate of 40% is not ideal, which is why we still need to figure out a better way to treat these kids. And some kids, despite them wearing it all the time and catching them, and I know these kids are wearing it, I see callus marks on them, I see red marks on them, and the curve will still progress. So it is not foolproof, and is not something that will guarantee them not needing surgery. Okay, so some of them will still ultimately wind up with this. So when they do need surgery, what are some things to consider? We worry about the indications to treatment, what the curve magnitude is what the typical indications, curve magnitude, and rate of progression. And I have to figure out what levels we're fusing, what instrumentation we're using, how we're doing it, and if we're going to mobilize them afterwards. So in general, the general understood indications are greater than 45 degrees with remaining growth, and that's the key point. If it's 45 degrees and it's static and the kid's doing fine, I just continue to follow them. I follow them. Some of these kids come back after college. I continue to follow them and make sure the curve's not progressing. If the curve's not progressing, they don't have any back pain, they're doing fine, then there's no indication for surgery. But if it's greater than 45 at a child with remaining growth, that's an indication for surgery. If there's progression and onset of growth while under non-operative therapy, or curves greater than 50 or 60 degrees in a mature adolescent that continue to grow. As far as what levels do you fuse, again, that's a bit trickier, and we can have multiple discussions about that. But in general, you obviously want to control the spine, and you want to fuse the least number of segments that you have to. In general, if you're a resident here and you have to answer a question, just say cob to cob. So you want to fuse the most bent one on the top to the most bent one on the bottom. And again, the levels of fusion are more critical to how a patient's going to do compared to the instrumentation system or the approach. We use the Lanke classification commonly because it's a good language to communicate the deformity and some of the other variations which affect how a person does with surgery. You could do a posterior approach where you make the incision in the back, or you can do an anterior approach where you're making the incision through in between the ribs, which is called the thoracotomy. Anterior approach is something that we do a fair amount of here at NYU. Part of it is because we have a long history of doing them. The prior generation instrumentation before we were doing derotation, and also with the tethers, is a anterior approach as well. Dr. Juan Carlos will talk to us about that shortly. Anterior has some advantages, and again, I don't want to get into the minutia. It's something that we constantly debate about, anterior versus posterior. Sometimes we do anterior and posterior. I have a case coming up that I'm going to need some help with, that we have to do an anterior to release the spine, put the person in traction, and then take them back eventually to fuse them, because I don't want to stretch them out too much at one setting, because there's something called distraction paralysis that can happen when then. Historically, we used to do anterior and posterior when we worried about something called crankshaft, when we would only fuse part of the spine, which would allow part of the spine to grow if there was significant remaining growth left. Posterior spinal fusions, again, are not all the same. You may see this on the schedule that we're doing a posterior spinal fusion, but we're only doing it in 2 hours. And this is a growing rod construct that we do when we have someone who's skeletally mature, has significant remaining growth, and we're just putting this assembly on them to try and control the spine, so that as this child grows, we have control of that spine, so that when it's done growing, it'll grow and allow the chest to expand to as large a volume as possible. So operative results are excellent. We've incorporated these new technologies. In 2000, we started this three-dimensional 3D correction, which is called DVR, to derotate the spine, which, the advent of our spinal instrumentation and cobalt chrome rods has allowed us to do that. And it made our results much better in terms of cosmesis and correction, but not necessarily it doesn't necessarily correlate with patients' outcomes, saying, oh yes, I'm definitely better than our kids that we operated on 10 years ago. So scoliosis summary, you brace only skeletally immature. You have to document progression because that's the reason to do surgery. You have to document what it's doing to the child in terms of back pain or dysfunction. And surgical referrals is requested if they're structurally unbalanced, progressive, or have painful curves. And again, this is what we're trying to prevent. These are the adults that we wind up seeing, which I don't want to spend too much time with and steal someone else's thunder. But one thing I just wanted to briefly talk about is, we've gotten so good at our ability to change the position of the spine and lock them into whatever position we want it to be in. But what parameters do we use to know where to put it? There's the SVA, which is some pelvic parameters with overall global balance. And we've been able to use this special X-ray, which we have here at NYU as well as our other locations, which allowed the whole spine, us to see the whole spine in place. And we know we can put this wherever we want now, but it's important to know where it needs to go. And this is something that we're doing. We're doing a study here at NYU where we're trying to evaluate where I would do a surgery on this. Actually, I did the surgery on both these patients. Same surgery, same level, same procedure, but yet look at the difference in motion between this person. They both had fusions. So why is one person bending like this and this person just bending like this at the same time? So we noticed that some kids lose a significant amount. This is another patient who I operated on. This is her before surgery, and this is her after surgery. Lost zero motion. So why is that? So we're looking at that, and we're using actually video metrics to understand that. And, obviously I alluded to it before, but, some kids move a lot at different parts of their spine. And if someone's moving a lot in a part of the spine that you're not fusing, then they're less likely to lose motion than if you're fusing through an area that they're losing a lot. So that's something that we're trying to understand better. And that'll also help us figure out, this other iteration of treatment for a deformed spine, which is growth modulation with a tether, which I'm not going to be talking about because we're saving that for someone else. Okay, so thank you for your time, and if anyone has any questions, here's my email here.
Thank you very much, Anthony, for that great thorough talk. We're going to move on to early onset scoliosis and casting by Dr. Darryl Lau.
All right. I'm Darryl Lau. I'm one of the neurosurgery spine faculty, and my practice focuses in pediatric and adult spinal deformity. Today's talk is really to focus on, our patients with early onset scoliosis and really concentrate on the early years and the role of serial casting. All right, so here are my disclosures. It's not relevant to this talk. So really the objective, again, is to discuss the role of metacasting in early onset scoliosis. We'll do that by touching on briefly the subtypes of early onset scoliosis. We'll talk about the indications and timing of casting, discuss the casting technique and some considerations in regards to pulmonary function immediately when applying the cast, and then the efficacy and outcomes. So at the end of the day, we have to kind of discuss how is early onset scoliosis dangerous? And it really comes down to curve progression. And in young children with early onset scoliosis, growth is the biggest thing. So when curves progress to greater than 75 degrees, we start to see some cardiopulmonary compromise. And when curves are over 75 degrees, we see significant reductions in PFTs. Their vital capacities are less than 75% of predicted values. And when curves are over 100 degrees, we see total lung capacity about 50% of normal. And when curves are greater than 120 degrees, then we start to really see restrictive lung disease, even right-sided heart failure. And unfortunately, even in the United States, we still encounter rarely patients with very severe deformities This is a 13-year-old with an infantile scoliosis, diagnosed, untreated, not braced or casted, and presents when he was 13. His main complaint is really shortness of breath. Clearly, he has a spinal deformity, and on his X-ray here, you can see severe kyphoscoliosis, and his left chest cavity is severely deformed and compressed. So this is a type of patient that clearly has a very bad deformity, kyphosis of 162 degrees, scoliosis 147 degrees, very bad deformity, very high risk type of patient to treat. And in this type of patient, you have to set your goals. And the goals for these type of patients with early onset scoliosis that have advanced disease, really the key is to halt progression of the curve, but you also have to apply correction because you want to expand that chest cavity by correcting that deformity, improve cardiopulmonary function, and allow them to have a balanced spine. But this patient is neurologically normal too. So the risk of correcting such deformity falls into considering, not correcting him to a manner that would put him in very high neurological risk deficit. A way we do this is put them through halo gravity traction for 6 to 8 weeks to hopefully decrease the severity of deformity. You can see here he had some improvement in his kyphosis in particular, but that kyphoscoliosis is quite severe. At the end of the day, when these EOS type of curves become that severe, we have to implement very invasive techniques that are associated with high complication rates. Complication rates of 59%, even in the most experienced hands. Neurological deficit rate is as high as 10% in these type of cases. But luckily in our pediatric population, they have a pretty impressive neurological recovery. And in patients that have those neurological deficits in the form of weakness, 91% do return to baseline at 1 and 2 year follow-up. So clearly it's very important that we need to be aggressive before these patients present with this type of disease. This patient underwent 3-level VCR, a T2 to L4 fusion. We got him nicely balanced. These are his clinical images here. You can see that this is his back in before traction, after traction, then after surgery. But most remarkably, clearly he had a correction of his deformity. But I wanted to highlight it's really his chest cavity that has become much more physiologic, which then represents the improved cardiopulmonary function in these patients. So, early onset scoliosis, it's really indicated based on the presentation of their scoliosis. Generally less than 10, we then subdivide that into infantile and juvenile, which again is categorized based on age 0 to 3 for infantile and 3 to 10 for juvenile. And there's a lot of options, especially non-surgical options for these patients as we want to avoid any type of surgery, especially during their growth phases. And today we're really concentrating on casting. So again, early onset scoliosis can occur in all subtypes of scoliosis that we see in pediatrics, idiopathic, neuromuscular, congenital, and syndromic type of cases. In regards to casting, the timing and indication for that, ideally children less than 3 years of age are the best candidates because they tend to have smaller, more flexible curves that are more amenable to casting. There's also indications for patients that are have very severe type of deformities, such as SMA patients that are not amenable to any type of surgery. Casting could be a good indication for those. But in general, curves that are between 20 and 25 degrees, we start thinking about implementing casting, or if patients have vertebral angle differences of greater than 25 degrees. Now, the technique utilizes the concept of being able to derotate and translate the spine. We typically use some sort of casting table, ideally a wristed table. Traction is often used, traction in the lower extremities and in the head. And really the motion and mechanical force that you apply should derotate and translate the spine. Often intraoperatively, we can use an X-ray to make sure that we did the correction that we needed. And the goal for post-cast major curves, for moderate curves, is less than 10 degrees. Studies have shown that if you don't reach that threshold, maybe there's a less optimal result in the long run. This is an example of some of the metacasts that you would encounter. There's various types. Different people use different types of cast. Some people don't utilize shoulder straps. One of the things I want to highlight when looking at this image is that, these casts, it's really important to cut out your windows sufficiently, meaning that you want to leave adequate space for chest and abdominal expansion, especially in children that utilize their abdominal muscles to ventilate. In addition, you want to make sure your cast actually is over the areas of the ribs, because that's really where you get your mechanical force and correction while patients are in these casts. This is an infantile idiopathic patient who has a 52 right main thoracic curve, presents a 22-month-old. Clearly a good candidate for casting. This is her post-cast X-ray. You can see that we got nice correction, a little bit of derotation, and less than 10 degrees. This is 3.5 years out of a cast. You can see that in idiopathic scoliosis with very flexible curves and moderately sized curves, you could potentially cure these patients. And it's very cautious when I say cure because, obviously these patients have significant growth left and they clearly can, their curves can return quite rapidly. So you have to be very careful with these type of patients. Considerations to casting. I think most people utilize general anesthesia with the ET tube. I emphasize ET tube because a lot of the ventilation physiology has changed when you apply these casts, and having control of the airway is a key factor for anesthesia. There are some people that are promoting maybe doing awake casting, and these are patients generally older, more tolerable to it, lower BMI, so you can get better control of the curves. And it's probably the case is because of the mechanism in which younger children breathe. You're probably applying more restrictive pulmonary compromise and discomfort when patients are awake. And specifically, the pulmonary changes that occur when you cast someone is you are decreasing their chest abdominal expansion, essentially decreasing the compliance of the chest wall. This does increase the peak inspiratory pressures. In fact, after cast, a study has shown that you have over 100% increase in their peak inspiratory pressures. And again, this study highlights the importance of your windows, and you can decrease that PIP about 70% when you have adequate windows. And fortunately, when we take these casts off, all of these lung function parameters do return to baseline and are not permanent changes. So what's the evidence? Casting for these type of curves have been utilized for quite some time, but unfortunately, there's not a lot of good data for this. The best study, I think, is this study here. It's a prospective comparative study, and really they looked at patients that eventually needed surgery, but they compared patients that underwent casting versus bracing only. And what they found was at the time of surgery, which is important, they found that patients that underwent casting tend to have much smaller curves, which makes their surgery less invasive and less risky. So 36% had smaller, less than 70 degree curves versus 17%. They also showed that in patients that did progress, they had a slower progression rate while in the cast versus bracing. And then those patients that didn't tolerate casting, that transitioned to braces, they had a rapid curve progression of 8.4 years. So clearly the casting was effective for those cases. And when you stop it, those curves progressed aggressively. In regards to more severe curves between 50 and 106 degrees in this study, 46% had resolution of the deformity, 34% maintained the deformity. So pretty high success rates, almost 80%. 20% of those patients progressed and underwent growth-friendly surgery. And then when you look at these patients 5 years out, at least half of them had less than 15-degree curves, which is pretty amazing. But at the same time, we have to remember that the treatment of EOS is not truly finished until these patients are skeletally mature, so we should highly consider bracing these patients, even if we have their curves relatively well controlled. In regards to non-idiopathic type of scoliosis, the general message is that casting could be helpful in buying time for them to undergo some type of growth-friendly surgery. The casting is not going to correct their deformity, but it could keep those curves stable. So if you keep those curves stable for as long as possible, you may buy them enough time to undergo an appropriate and safer surgery. And this is the case for neuromuscular, syndromic, early onset scoliosis, and in congenital scoliosis. In serial casting, we often change these cast out, typically around 3 to 4 months. And then discussion is usually held with the parents on when should we reapply the cast. Should we do it immediately? Should we give them a break? And this is a question of cast holidays. Typically, cast holiday, we would say over 4 weeks, that would be qualified as a holiday. And does that affect their outcomes is the main question. So a study looking at this with 90 patients, 59 versus 31, they compared whether a patient had a holiday or not. And the defined success is less than 15 degrees. And generally what they found was that patients that had no holidays had greater success, regardless of subtype of scoliosis, 44% success versus 13% in patients that had holiday, and then especially for idiopathic types of curves, 56% versus 22%. So the answer is really no. The best, holiday seems not as successful, and especially important in the first 18 months of casting. If you need to cast, you should consider a very aggressive type of brace. In regards to long-term benefits and side effects, this has been looked at in terms of HRQOL outcomes. It's actually quite interesting. In idiopathic scoliosis, they actually found that casting resulted in residual negative effects, especially in the emotional subdomains of patients, right? And then in syndromic congenital neuromuscular, the non-idiopathics, they actually had mostly improved outcomes compared to the baseline subdomains. I think this is just really a representation of the baseline function of these type of pathologies, right? If you take a relatively healthy idiopathic scoliosis patient and you cast them with rigid immobility, compared to their baseline, they will feel like they are doing worse, right? Compared to if you took a congenital or neuromuscular scoliosis patient that has a pretty severe deformity and you casted them, you helped them with their ability to sit up, clearly they may feel better. So this might be just a representation of where they're starting off. So in summary, early onset scoliosis can be rapidly progressive, can become a very morbid thing for the patient, cause significant functional disability, physical deformity, but with early screening and appropriate applications of serial casting, we can really help these patients delay the progression of their curves. And in idiopathic subtypes, we can even maybe give them a chance for cure. I want to thank you for your time and attention.
Thank you so much for that great talk. Unfortunately, one of our speakers, Dr. Rodriguez, is stuck in the OR on a case, so he's not going to be able to make it. So I think I'm going to give and we're also running behind, so I'm going to give the talk kind of an overview on adult spinal deformity, the only adult-related talk in this session, and then we'll have a few moments for some questions, and we'll try to get back on track in terms of the schedule. These are my disclosures, nothing directly related to this talk. So we're going to talk a little bit about, we refer to as ASD, but basically you just saw kind of the pediatric version of what we're going to discuss, but even after skeletal maturity, spinal alignment is really critical to functionality and symptomatology. And we're going to talk about kind of how we've evolved in our understanding of this. Previously, this was really an under-recognized and undertreated condition in spinal surgery. And we're going to talk about advancements we've made in terms of diagnosis, customizing treatments, And also some of the techniques that you've and the advances in technology that you've heard about before, we're going to see how they're being applied in the adult spinal deformity realm. And something that's near and dear to me, we're going to touch upon cervical deformity just for completion's sake, and we'll end with a few discussions. So very distinct from what you just heard in the pediatric realm, which has a very defined diagnostic criteria, really kind of a mixed bag in the adult spinal deformity realm. And we're dealing with different diagnoses, which we'll talk about shortly. And we're dealing not just with the coronal plane, with the side plane, but we're also dealing with the frontal plane, the sagittal plane. So after in adult and with advancing age, the prevalence increases. So by the time we reach about 65 years, almost 2/3 of the general population has, at least radiographically, what would be considered some element of a spinal deformity. But fortunately, only about 1/3 of these have some type of related symptoms, as opposed to severe curves in adolescence. There's a male and female equal prevalence, and the mean age is about 60 years. And the most common presentation is in the lumbar spine, and which is in contrast to the most common curve in the pediatric spine is the thoracic, secondarily the thoracolumbar curve. And despite common misconceptions, even after skeletal maturity, there is progression of our deformities in adulthood, and it really depends on the state of the person. So generally, it's a low progression for many decades after adolescence, but when osteoporosis and measures of sarcopenia become involved, there can be more rapid progression later on in life. We know that this is an increasing problem. The rates of treatment in North America went up 60% in the last 2 decades. And it's thought that this is a reflection of multiple factors, certainly our techniques, and we'd like to think our understanding of the presentation has expanded, but also our perioperative care and anesthetic techniques have been minimized, and the general aging of the U.S. population and the increased years of activity and health years has contributed to this as well. We know that the diagnosis of adult spinal deformity, whatever the etiology, has the potential really to result in a severe disability and diminishment of quality of life. A few years ago, very commonly quoted study, Shea Best looked at population norms for just an overall health state. This was measured by the SF-36, and they found that patients presenting right prior to surgery for treatment, corrective surgery for their ASD, basically they had functional scores equivalent to patients with certain types of cancer. They had psychological distress scores from the mental component score, similar to patients with an acute episode of major depression in 40% of patients. And from a functional perspective, many of them performed worse than amputees on skills testing. It's a heterogeneous etiology, as we discussed. Just to go over some of the common causes, probably the most common cause is what we refer to as de novo or degenerative scoliosis, where there's asymmetric deterioration, either from a right to left perspective, when a scoliotic curve can ensue, or in the front and back plane, resulting in sagittal imbalance. You heard earlier, I'm not going to belabor the point, you can have progression of adolescent and early onset curvatures into adulthood. That's another common cause of requirement for treatment that we see. Hyperkyphosis in the thoracic spine, we haven't touched upon it too much in this block. This is a recent patient of mine with kyphoscoliosis that we'll get into later, her treatment. Increasingly, we're seeing iatrogenic sagittal deformities. So as we learn more about the spine, sometimes we fix one problem. In this particular case, there's been expansion of the lung fields, derotation of the curvature. But from a balance perspective, the patient's been thrown off balance. And this is another recent case of mine that I did. And this patient presented to me with this X-ray, and they actually initially saw some improvement with their lumbar treatment elsewhere, but obviously there was not a respect here for the global balance, both in the frontal and the side plane, which we'll talk about later. And certainly, as you heard, tumors and post-traumatic spinal deformities have similar presentations, after their initial course of treatment. So what about, where does the role of surgery come into play? So we know that symptomatic patients progress. It's kind of, in many respects, similar to the myelopathy talk that you heard. There can be periods of stability, but they do tend to progress overall pretty consistently. One of the largest national studies that we have is the adult symptomatic lumbar scoliosis, the ASLS, which was a $2.5 million study funded by the government. 9 North American centers randomized patients into operative and non-operative cohorts. And basically on their as-treated and MCID analysis, they found that their conclusion was that if a patient is not satisfied with the current spine health and expects improvement, surgery is preferred. But I think that's a complicated way of saying that the operative patients did a lot better in really all the metrics that they measured, except at the 6-week mark, which is pretty understandable. In terms of improved walking ability and quality of life, surgery was superior. In terms of reduced analgesics, including opiates, surgery was better. And with regards to all the HRQ metrics, some of which were disease-specific, some of which are spine-specific, and some of which are just general health outcomes, they're all better. And now this study has up to 5-year data. So I want to, in terms of, we'd like to think we learned a lot about this. I don't think there's any other field in spine surgery that's had more publications and more research efforts in the last 2 decades. If you do a quick PubMed search, there's over 13,000 publications in the last 20 years just on adult spinal deformity. Just to go over some of the initial alignment concepts without getting too technical here, but I think that these are important to note. So one of the initial things that kind of got us to thinking about this was this concept of sagittal balance. So, the fact that scoliosis does not just occur from a rotational perspective and from a side-to-side imbalance plane, but also the most common disabling presentation is in the forward plane. And this landmark study by Steve Glassman showed that there is really a linear relationship between the disability of the patient and the degree of sagittal plane malalignment, so their forward posture. And we'll talk about why that is shortly. And this kind of led to, there's been a lot of iterations of classifications, but this kind of led to the first kind of broadly accepted, which was partly developed at this institution, the Scoliosis Research Society, and also nicknamed the Schwab classification, where it really had 4 descriptors and certain parameters. And the main point here was that it gave us kind of the first understanding of how we should assess our patients, how we can study our outcomes, and how we can plan our realignments. And this all centered around the concept of pelvic morphology, which was really the main finding early on when we started studying these. So the way the pelvis develops is really intrinsic to how the shape of the spine develops. And this concept called pelvic incidence, I'm not sure how many in the audience have heard of it, but it's basically, after skeletal maturity, it's a fixed parameter. It's an angle between the center of the femoral head and the midpoint of the vertical from the sacrum. And it correlates in 80-90% of patients with the amount of lumbar lordosis. We're talking non-surgical patients, just routine people walking down the street. And that's kind of the basis of that classification. And the reason why that is because not only with disability, but also our outcomes after all types of surgery, degenerative surgery, deformity surgery. If the lumbar lordosis wasn't within 10 degrees of the pelvic incidence, so if the shape of the lumbar spine didn't match the shape of the pelvis really on the side plane, there was unlikely to achieve a good outcome. And some of that depends on age. Certainly there's different expected postures, which we'll talk about. So, but basically, as you can see, if your pelvis is and this is what we're considering the pelvis here, the shape of the sacrum there. So if it's anteverted or if it's retroverted, there's that's how the spine compensates. But basically, there needs to be some type of match between the two. Also, with not everyone has the same type of pelvic morphology. We're all kind of made differently. So, and kind of if you're falling within the mean of pelvic anatomy, About 2/3 of your lordosis is in the lower portion, lower two levels of the lumbar spine. As we start to go kind of higher pelvic incidences, more forward pelvis, you require more lordosis, and you need to recruit your upper segment. So there's change in the proportional alignment, which we look into. We also know there's individualization of the shape. So it's not just the amount of lordosis you have, it's the apex, and it's also the inflection point between the thoracic and the lumbar spine. So ultimately, the kind of common theme here is that patients with adult spinal deformities really lose the sufficient amount of lumbar lordosis they have to maintain an erect posture, and they start to recruit compensatory mechanisms and eventually fall forward. And this really increases exponentially their energy expenditure with every centimeter increase. There's approximately a 20% increase in energy expenditure on force plate analysis, where they have to recruit accessory muscles. And kind of the end stage here is, as you can see here, is we're recruiting the lower extremities, where you have hip extension and knee flexion to attempt to maintain an upright posture. Despite the technological advances and all the literature that we've done on adult spinal deformity, one thing that kind of plagues us is it's still amongst the most complex surgeries that we perform, and complication rates remain relatively high. And a lot of the research efforts now are aimed at addressing those. If you look at the largest study to date on complications, mean 2-year follow-up, almost 60% of patients experience any type of complication following corrective surgery for adult spinal deformities, and major complications occurred in approximately 20% of patients. And it's not just perioperative complications, it's also postoperative complications. And I know it's not something that's appealing to talk about, but I would be remiss if I talked about adult spinal deformity surgery without addressing the efforts that are being made to minimize the complications that occur after these procedures. Are we getting better at complications? So for a while, we were pretty stagnant. There is some recent literature saying that we are making improvements. Some of the major things that we're working on is perioperative optimization. There was a question earlier on metabolic bone health, and that's kind of a routine assessment at this institution and many institutions prior to engaging in any of these invasive types of surgeries where we're changing the posture of the spine. Enhanced recovery after surgery protocols have been developed, and many other forms of optimizing patients for surgery. We're also really beginning to tailor our surgical treatments for specific patients. So we talked a little bit about alignment. I'd say about 2/3 of the correlation with outcomes is realignment based, but that's not the whole story. So, just achieving a good radiographic alignment does not ensure a good outcome. And there's other factors. We talked about comorbidities, but also frailty and age play a significant role. While working at this institution, the Fahad team was one of the first to talk about age-specific goals of realignment. But chronologic age is not always physiologic age. So, the concept of frailty, which is prevalent in the geriatric and the cancer literature, has really creeped into the adult spinal deformity literature. And, the first literature was really a reflection of that these patients are at heightened risk. So they had increased length of stay, increased perioperative burden, and potentially worse surgical outcomes. Revision surgery rates were higher. And our group was one of the first to kind of look at tailoring our corrective and surgeries for the frailty state of the patient. So we know that high frail patients, they have more to gain from surgery, they're more disabled, but they're also at higher risk. So we wanted to diminish the amount of invasiveness and the amount of correction that we apply to these particular patients. This is an example of mine, a 75-year-old patient who had functional outcomes that were consistent with really a 55-year-old. And she tolerated what I would consider an ideal realignment procedure without complication. We talked about some of the advances earlier with some of the new techniques applied to single level and degenerative fusions. This is also starting to enter the field of adult spinal deformity. Historically, we did all these procedures open with these large incisions, and minimally invasive surgery is not specific to spine surgery. It's really affected all of our surgical fields, but certainly it's had a footprint in spinal surgery as well. And most recently to adult spinal deformity surgery. And this is a 6-week post-op MRI of the multifidus and longissimus muscles, and you can see in the MIS group, it's a lot more robust than the open group. I will say, and then some of the theoretical advantages of MIS surgery are not just the exposure-related morbidity, but increasing the perioperative course, faster recovery, earlier ambulation, return to activities. And some of this has been borne out in the literature. But I would take these studies with a grain of salt, because if you notice, a lot of these are propensity score matched. And the reason why that is because the open deformities are more severe, they're more rigid, they're more difficult cases, and we kind of mitigate that difference, with statistical means. But the fact of the matter is, a lot of the more complex surgery we're not doing through minimally invasive techniques yet, and it's more for mild and moderate deformities. Robotics, there's also, this institution is really adapted to robotic techniques, I'd say more than any other really regional institution. And there's currently 5 robotics approved for spine surgery. I think there's 3 more coming out this year. And there's some early kind of meta-analyses, systematic reviews that show that they do enhance accuracy rates. But we're still at the inception of the use of robotics, again, for spinal deformities, because there's very complex anatomy, and sometimes the timing is prohibitive, and also sometimes there's difficulties maintaining accuracy with very distorted anatomy. But I think it's something that's grown in usage and has the potential to impact utilization. We looked at our own experience, and we saw that there were some perioperative advantages to the use of these techniques in our cases. But it's also kind of collectively, all these technologies have made us able to treat some patients that perhaps weren't great candidates for surgery in the past. So this is a 56-year-old patient, Jehovah's Witness, adamant about not receiving, blood products surgery, which is pretty standard for a lot of these open procedures. And so this patient went on all percutaneous lateral, followed by a posterior-based procedure, both anterior and posterior reconstruction, and ultimately did well and did not require any types of blood products. You heard a little bit about single positioning. I'm not going to go into this in too much depth, but we have started to apply these to kind of moderate deformities. Not only, a lot of the MIS techniques really rely on anterior column restruction, so taking out the discs, taking out portions of the vertebral bodies. But oftentimes, historically, that requires stage procedures or flipping the patient intraoperatively, which really can prolong the surgery itself. So we really diminish the operative time and the surgical time and increase the operative efficiency with some of these techniques. And this is a recent case where I'm doing a lateral. A colleague of mine is doing a posterior exposure at the same time. Basically, we're reducing the extent of the surgery and the duration of the surgery significantly. This is a recent case of mine who presented with a previous fusion. They have a very high pelvic incidence, so there's a mismatch between their lordosis and their pelvic morphology by about 30 degrees, and obviously they've had a previous fusion, so they're rigid. This patient had a mini open osteotomy at the L5 level, and the rest was performed in a single position surgery, really in 3 hours. So I want to touch upon cervical deformities. And I know we're running out of time, so I'm going to run through this. But these are amongst very complex problems, very complex patients. Not only do we have to worry about the parameters that we just thought about, but we also have to worry about the occipital-cervical junction as well as horizontal gaze. These patients have very broad-based distribution of presentations. It can be nerve-related pain, spinal cord dysfunction, pure axial pain. Collectively, they all have significant disability. This was quantified by Justin Smith, who showed that these patients, their overall health state was 34%, the bottom 25th percentile score of a similar age and gender-matched cohort. So that's pretty depressing. Fortunately, we have treatments that we can help these patients with. We know that these patients are more comorbid, more frail, and more elderly than the typical spine patient. And we also know that, if you look at kind of the average frailty of a patient presenting for spine surgery in the United States, about 4%. If you look at the average patient presenting for thoracolumbar adult spinal deformity surgery, it's about 70%. If you look at adult cervical deformities, it's almost 90%. That's at least mild frailty. So this patient is really an at-risk population. Some of the traditional causes of dropped head and cervical deformities, like inflammatory arthritis, are diminishing with advancements in immunomodulation. Again, we're seeing increased rates of cervical surgery for degenerative causes, and oftentimes we're seeing, as in the thoracolumbar spine, iatrogenic related problems. This is a patient presented to my office with this X-ray. Previously had a 4-level, what's referred to as a standalone interior, which can be fusion, which can be kyphogenic, as it was in this patient in previous normal alignment. And unfortunately, they had a cardiac event in the perioperative area right after their surgery. So they had to wait a year after being stented. And by the time they presented to me, they needed an extensive reconstruction. So these are things with our understanding of alignment, we want to try to avoid. So we know that cervical deformities don't present in isolation. They're often part of a global spinal problem and malalignment. And we've learned not to just look at the cervical spine, because we can stare at this when really we have a bigger problem that we have to address. And if we just treat one, we can have catastrophic failure really at the distal level of that. We also know that they commonly occur with adult spinal deformities. Just to pick up the pace, this is a patient of mine about 12 years ago, had a thoracolumbar. Unfortunately has a movement disorder, and which I think really contributed to this and progression, and went from a normal posture to a really severe chin on chest deformity. Required a 3-column osteotomy to normalize her gaze. Our understanding of cervical malalignment has come maybe not as far as thoracolumbar malalignment, but it's come certainly a lot more than what we understood in the last 20 years. Basically, we went from 2-dimensional lordosis measurements to now incorporating more advanced cluster analyses that kind of group these patients into different types of presentations. So this is one of our most recent works, where we group patients into flat neck deformities, focal cervical kyphosis deformities, as well as cervical thoracic deformities. And these patients have different surgical plans, different radiographic goals. This is a recent case of mine, maybe 6 months ago. 52-year-old presented with ataxia. If you just look at their x-rays, you can see there's a lot going on here. So the patient, not only is their head way forward relative to the thoracolumbar spine, but they're also compensating through the lumbar spine as well as the lower extremities. On advanced imaging, this patient actually has a fourth recurrence of an intramural lipoma, and quite extensive, extending from the C7 to the T7 levels. And these are the axial cuts, and you can see the ventral, really occlusive lesion here. But when these are revision cases, as you saw in an earlier talk, it's really difficult to distinguish this between neural tissue and tumor tissue intraoperatively. So this patient was floridly myelopathic, had spinal cord dysfunction. Not only did they require the 3-column osteotomy to realign their spine, but they also required tumor excision due to their post-laminectomy kyphosis. Unfortunately, this patient had a good outcome. I'll end with 2 quick cases. 68-year-old patient, maybe 10 years ago, we did a Chiari decompression and a cervical myelopathy corpectomy, anterior posterior fusion. She did well, but then her posture and her worsened, and her scoliosis, which was pre-existing, worsened. She ultimately required extensive reoperation. This is a patient who was a truck driver who had severe spinal symptoms due to multiple fractures, multiple accidents. But his biggest complaint was, if you can see here, he's hyperextending his hips, and he's had recurrent dislocations of his hip. And if you can see here on his sagittal alignment, we achieved a nice posture, and his hip extension normalized. So I think with that, we're going to close, and I'd like to, we're a little bit above time, so I'd like to give the existing audience maybe one last chance to ask any questions they had. I think we lost some of our speakers, but I'd certainly do my best to answer. Any questions? Friday afternoon? Enjoy your weekend, guys. Thanks again.
Thank you very much, Dr. Pashas, for a great talk, and thank you for our participants virtually and in person for a wonderful course. Also, thank you to the neurology department, rheumatology, physical medicine and rehab, anesthesia and neurosurgery departments. Thank you all. Have a good weekend.